Recording in progress.
Yeah.
So we need to use mics for all.
Okay. Well, good morning. Good morning, everyone. Good morning. Ah, that's great. I walked in over there, I felt the energy. So we want to make sure it transfer into this room as well. And we're going to have a really great day today, discussing a topic that everybody cares about. So I would ask Jennifer to speak very shortly. But I know that today we are all together talk about a topic that everyone in this room cares deeply about. So before I begin, I want to thank Jennifer Kwan and her American Junior Investigator Association for their partnership. You know, it was Jennifer who actually came to me to say, I want to have this meeting and I'm trying to organize this. And of course, it's so important that we're very happy to step in. But I did tell Jennifer that I want this meeting, not another one that just talks about the problem. We've been to many of them. Want to come and talk about solutions. One that actually about what actions and how much out of the box thinking can we capture. I do want to thank Barrow's Welcome Fund, Lasker Foundation, ASCI for the generous support of this meeting. Now, I think it's very special that we have actually Director Jay Bhattacharya here. You know, if anything has to happen, certainly we rely on NIH. And when I talked to Jay, when I met with him in Building 1 on another matter, I said, how about this meeting? On the spot, he said, I'll be here. Literally, he called his schedule and said, put it on my calendar. That goes to show how important he takes this topic. We certainly look forward to hearing from him. And for my good friend Bob Lefkowitz, of course, he's here. He is the quintessential epitome of physician scientist, a role model, and is here to inspire all of us to say, yes, we can do this. And so very much appreciate Bob being here, our two keynotes. Now, many of you know I'm also a physician scientist. And in fact, I feel that most of my identity has been linked to my work as a physician scientist. I still run an NIH-funded laboratory, thank you, Jay. But so I understand the challenges of being a physician scientist. And so Jennifer approached this meeting. It was quite easy to say, of course. But then the heavy work begins to get all of you together, put the program together with her help and her leadership, of course, my staff, etc. Now, you know, people talk about this issue, I mean, as long as I can remember. As a young man, I remember Jim Weingarten in 1979 wrote in New England Journal of Medicine, endangered species. Well, 4 decades later, we're still here, right? So the good news, we're still here. The challenging news, the numbers are dwindling. So we're here to talk about what do we need to do. Now, I would say to begin with, there's been numerous efforts to address issue, to activate policies, and to give opportunities. And many of the people who did those work are here today. And we do have a session to say what are lessons learned. But to begin with, Dave Ginsburg is here. I said hello to him earlier. Dave Ginsburg, 2014, NIH Committee on Physician Scientist Workforce Working Group. And of course, he wrote a very powerful report that resulted in an increase in terms of K99 awards. I think the allocation was 50% increase from 2014 to 2020. Loan repayment program, expansion from a maximum of 35,000 to 50,000. Well, maybe it's not enough. We'll talk about this. Also, contributed to NIAID development of R25 education grants, R32 mentor research program residents, the next generation of researcher initiative. So overall, great recommendation, but we know that it's still not enough. We have a long way to go. Now, in 2017, a group led by Bob Lefkowitz, Brian Kubuka, who unfortunately can't make it today, sends his regrets, Vivian Chung, Mukesh Jain, Paul Utz, and Tachi Yamada. Many of those individuals are here. They founded the Physician Scientist Support Foundation, PSSF. How many people know about the foundation? Show of hands? Great. So it was really a great idea to actualize. They had McKinsey report, which I hope that Mukesh may say a few words about this. But to actualize this has been really quite challenging. The good news is that there is a medical student research fellowship program, which is now run by ASCI, that they're able to get Amgen Foundation to provide $1 million with matching from Barrows Wellcome Fund, ASCI, Janssen Pharmaceutical, and others. So then, of course, after that meeting, we actually held a meeting on this topic. Bob, remember, right here. That was in 2020, to talk about what next. And of course, many great ideas come, and I still feel that we need to push hard on those actions. So I think the conclusion overall of all the efforts is clear. No single entity can do this alone. We need a broad alliance and coalition to reduce and to ensure support and to have from student to professor. ASCI, AIM, Barrows Wellcome Fund, Pathways Workshop, webinars, and many others that continue. So I think what we want to know is where do we stand today? Okay, there's some good news. I'm told that the number of students entering MD, PhD programs has been rising slowly and steadily. More medical students are reporting more research exposure, which I know that to be true. And the NIH Career Development Awards, K Awards, have grown since 2015. But despite that, many obstacles remain. Challenge of inadequate resources for research training, debt relief, and early career support. And I'm not going to go through all those because I'm sure we capture a lot of those issues. So why are we here today? I think, looking at so many friends, so many leaders here, it's truly encouraging because we all care about this issue. But the point we want to make is not to rediscover the challenges, to find solutions. So we've organized the meeting in such a way that we'll have those opportunities to discuss this. For example, after Jay and Bob's keynotes, where they frame the issues, we're going to have groups that talk about lessons learned and looking backwards, but also broaden our lens to say what technological advancement has been made, and therefore physician science today have a lot more opportunities to look at their application of their knowledge of medicine to science through digital data, AI, as well as bench research and a whole variety of opportunities. We should acknowledge that. And then, of course, we want to get models of the future, and we have gathered together models which are working in other countries, from Singapore, from Canada, and actually I just came back from Tsinghua, Tsinghua Medicine, and of course I'm chairing their council, in which they want to put forward this major academic health center, and in which case the government is now committing to create major support for physician scientists. Because people all recognize there's great research here, there's clinical care here, the gap is there that needs to be filled. And so you will have also interactive breakout sessions to look at what actionable strategy. So I think, let me conclude by saying our goal is clear. Bold, practical ideas that move us forward. We still have far to go, but I think we should all work hard together, listen with intent, contribute with purpose, and collaborate with creativity. With that, thank you very much for being here. I'll be with you throughout the day. And of course, I'm really looking forward to this meeting. Thank you. Now, let me ask Jennifer Kwan, my partner in crime, somebody who really had pushed hard on this issue, someone I greatly admire, to say a few words to open the meeting as well. Jennifer?
Thank you so much, Victor, and thank you everyone here for coming. We appreciate all your leadership and advocacy for physician scientists. And I guess that's how we produce. So since AJIA is a relatively new organization, I wanted to give a little background on it, but also want to share some data that we have from a national survey assessing early career investigators and some of the challenges that they face. I was actually on the Hill yesterday talking to Rep. DeGette's team. They're currently updating Cures Act 2.0. And they said that we definitely need data. So we have data for them. And also we're going to launch a survey towards MD and MD PhD trainees as well, and look forward to working with all the program directors in the room to help make that successful. So I think everyone in this room knows this problem. Physician scientists make up only 1.3% of the physician population today in the US, but we make up a disproportionate number of Nobel Prize winners and Lasker Award winners, and early career are the most vulnerable in the entire pipeline. So we're a nonprofit dedicated to advocacy, career development, and mentorship of early career physician scientists. And this is the pipeline that people have seen many times, but the leakiest part of that pipeline is at that junior faculty stage, with continual decline from this FASA study in 2022. We're looking to discuss solutions, like Dr. Zhao mentioned today. Can we support more bridge funding? Can we create some stocks that provide dividends to academic medical centers? Can we increase research RVUs? Those kinds of things, because these low grant funding rates, grant uncertainty, balancing research clinical demands, economic misalignment of incentives have contributed to this leaky pipeline. And the NAM actually put out this report back in November. That was one of the reasons why I wanted to reach out to the NAM to organize this think tank. One of their high priorities in order for us to strengthen US biomedical research and also the health of Americans was to prioritize expanding early stage investigator funding, particularly for early career physician scientists, and to stabilize their launch. So we bring together this think tank. Many of you guys are here today to contribute to solutions. And we thank our co-sponsors, the Burroughs Wellcome Fund, Lasker Foundation, AACI, with leaders from academia, industry, philanthropy, government, and also the media is online as well, as I understand. And this contributes to this very delicate ecosystem where funding that comes from the government, including to the NIH, is crucial for training current scientists, physician scientists, and the next generation of scientists and physician scientists, and leads to fundamental discoveries that industry is able to take and translate that into therapies for the public. But since those are threatened, unfortunately, we've had significant number of job losses this year, biotech, pharma, academic centers, federal health agencies, with T32s and Fs affected at the post-grad training stage, in addition to the pre-doc training stage as well. And so we did this survey to assess what is the current pulse of early career physician scientists. This data was from April 2024 to August 2024, just as a comparison. At that time, already of the people who were surveyed, 260 respondents from around the country. 49% had considered leaving their research career, with the top reasons being they were unhappy, stressed out, burnout, funding challenges being number 3. At that time, 23% of the respondents said there were research RVU mechanisms. 35% of the respondents said that their department equalizes salaries between the clinician and the researcher. And now we surveyed again, starting in February to now, with 278 responses from around the country. That we have some from Texas now. I know there's a little white spot there, but we have some from Texas as well. And 82% of the respondents are early career. This is the breakdown of their specialty on the right side. 43% of them have a career development award. And in terms of support, 30% said that their department equalizes the salary between the clinicians and the physician scientists. In terms of research RVUs, 29% of them said that their department provides research RVUs, including things like bonus compensation for grants, recognition awards, RVUs for grant submission by itself. And so in terms of the current situation, 58% have considered leaving their research career, 45% had considered leaving the country, and 10% have received offers from other countries trying to recruit them. Now, the top reasons for leaving include funding challenges. Now it's like, by far the front runner, followed by undercompensation, then being unhappy and stressed out. Oh, and then 50% of them are pessimistic, 27% are optimistic about their career as a physician scientist. Some of the top solutions that people responded to or about said, how can we address these funding challenges right now? Tapping into philanthropy, legislative advocacy and targeted policy, multi-institutional consortia, public-private partnerships, institutional bridge funding, innovative funding models. Oops. All right, thanks. Let's see if this works. Now it's frozen. Let's see. Okay. Oh, all right. So this is a summary between 2024 to 2025. Even though this was not a head-to-head comparison, but in terms of the percent respondents that said these were challenges, we have an increase in the number who have considered leaving the research career. There was a significant jump in the numbers that said the reason for leaving was funding challenges. There was a small bump in the people who said that there were research RVUs given. There was not any significant change between those that said there was an equalization of salary. So we have some sub-analyses underway, including what are the factors associated with those who want to leave their career, those who want to stay versus those who want to leave the country. And I want to thank our entire think tank planning committee, because we're put together a great agenda to try to help address these and find bold solutions, as Victor mentioned. And also thank the NAM staff, Melissa Leitner and Emily Schongberg, for their dedicated efforts to get this all together. We thank the AJIA leadership team, our board of directors, and in addition to having live events such as this think tank, we also do national studies, as I just described, and we thank our supporters for enabling us to do this. We recommend all those in the room to join us, including your trainees. We have the live events, we have these national studies, we are planning a celebrity Shark Tank, and we are also developing a resource to match domain experts, early stage investigators with investors, to try to galvanize additional networking and funding opportunities. And this is our AI-powered grant matching app. Thanks to Sean and the Codex team and Mark for helping to get this together. And thank you. Now on to the rest of the agenda.
Now you can see trying to keep up with Jennifer is not easy. She's full of energy. But importantly, I think the data you show is quite sobering. I guess that's another reason why we're all together here today. I won't get into the details of how you designed the study, et cetera, but I think the message is quite clear. Something needs to be done. And that's why we're so pleased to have Jay as our keynote speaker. As I said, Jay, Director Bhattacharya, is the 18th Director of NIH, and previously he was Stanford. I think we overlap to some extent, same with Ellen Garber and many others. Jay, of course, is well known for his research as a health economist working on population aging, chronic disease, health and well-being of vulnerable population. But I think what he has clearly said since he assumed the directorship is that he's really interested in early career researchers. And again, counting my experience with him, just ask him to say, be here, he's here. So we're so glad that you're here, Jay. We'd love to hear your thoughts on this very important issue coming up.
Thanks, Victor. Thanks for the introduction. I should say, this topic of physician scientists is near and dear to my heart. Clinician scientist is near and dear to my heart. My first interaction with a clinician scientist that I admired was Alan Garber when I was 19 years old. And he's actually the reason I chose this career path, which led me to this directorship. I myself have an MD and a PhD in economics. I think I made $8,000 a year for like 4 years during in the early 90s when I was as a physician scientist trainee. And in the room, there's at least one of my star students who's also a MD PhD scientist and clinician. So it is absolutely an important topic to me. But I want to echo the theme that we've heard from Victor. We are actually in trouble with our support for early career researchers, and this is not a problem that started this year. It's a problem that goes back decades. So let me show you some data. If I can get this to move. That's not it. That's not it. There we go. Okay. This is the average age of the first R01, going back to 1980 to 2020, for MD PhDs, for PhD only, and for MD only. And what you can see is that it takes so much longer than it once did to go into independent research. Right? The R01 is the marker. The first R01 is the marker of essentially, like it's a declaration of independence in 1980, first R01s were people in their 30s, and that includes MD PhDs. Whereas now it's mid 40s. If MD PhDs, you're talking about late 40s. That's a long time to wait. That's a long time to wait before you have a chance at trying your new ideas out. There's lots and lots of factors to go into this, and that also explains Victor's observation that we've tried so many things. I'll talk a little bit about things we've tried over the years, but we haven't made any progress. In fact, we've gone backwards. Right? This is a very sobering graph, and it's true not just for MD PhDs, but for all researchers in the biomedical research space. We require 1, 2, 3 postdocs before there's any chance of even getting an assistant professor job. Like we have for a while, there were restrictions if you had a K award to even apply for an R. We have basically made it so that it's all but impossible for early career researchers to get support until they're, again, into their late 40s. Okay, these are data from the NIH that we I think it's the first time this I've publicly presented this graph. We just compiled going back to the 70s on the set of researchers who had F-32 support. And it's a Kaplan-Meier curve where it's essentially a measure of dropout. Like one is that you've essentially decided not to go out to like seek further support. And the blue line is the 1970s, orange 80s, 90s, 2000s, 2010s, and 2020s. The good news is that we've stemmed the bleed in a sense in the 2020s. The bad news is look at the graph. I mean, just look at it. In the 1970s, folks who received F-32 support, maybe 10, 20% of them, 15% of them dropped out in the first couple of years after they left. But in the 2010s, 2020s, more than half drop out almost immediately after F-32 support. More than half. This is a problem, again, that goes back decades and decades and decades. And nothing we've done seems to have worked. There's something, it's not, because so the lesson, we'll talk, I'm going to leave time for Q&A because I should just say up front, I do not have the answers to this, but I desperately want to solve it. And so I want to leave time for Q&A so that we can talk about how to potentially solve it. I have some ideas, which I'll tease at the end. I'm going to spend the balance of my time just talking about why it's so important, right? Because I think it's easy in an audience like this. I can tell you it's important. You all have lived it, so you know it's important. But I want to tell you why it's important for the public at large for us to solve this problem. You know this guy, right? Max Planck. He won a Nobel in physics, I think. And he is. This is as far as the public is concerned, this is what they know about Max Planck. He said, there's his famous quote: "Science advances one obituary at a time." That is a very depressing thought. Right? You think about scientists and science as we change our minds when data come. We allow new ideas to enter our domain, our thinking. But physics, which is the queen of all sciences, has this problem, or had this problem. Maybe it still has this problem, where in order to make changes in how physicists generally think, the old guard has to like give up. In this case, give up in a very exact way. So it's one of these things. You look at this statement and you think to yourself, is it really true? And the answer is, it might be an exaggeration, but we really need to make it not true. We need a culture that allows our scientific ideas to change with over time before the old guard dies. Let the old guard come along with us, right? Let me show you. I published a paper in 2019, I think this was, with the title "Age and the Trying Out of New Ideas." Let me just describe what the paper does. We take all of PubMed, every single paper published in PubMed going back to 1940. Miko Pakalin and I, when we look at every single word and word combination in every single paper published in 1940, and they just list them. And then you do the same thing in 1941, and you subtract off all the 1940 words, and what you're left with is, after you do a synonym checker and all that, is a set of new ideas introduced in 1941. You do this in 1942, 43, 44, and so on, and it looks like a history of medicine. You show up in it, Doc. So it's a fantastically simple embedding of the history of medicine in the published biomedical literature. Now that you have the age of every single idea, the year every single new idea was introduced, PCR shows up in 1982 or whatever, you can go back to every single paper and ask, how old is the newest idea in every single paper? How old is the newest idea in every single paper? And what you can do is you can go to every single author, everywhere in the author list, and ask, what was the first year they published their first paper? Once you do some disambiguation about names. So for instance, my first paper was 1996. As of next year, I will officially be 30 years old. You guys can, okay. Let me show you some results from this. This was depressing. When the first time Miko showed me this graph, I just about lost it. This is the on the y-axis is the probability of a newer idea showing up in your paper, and on the x-axis is the career age of the first author. Career age of the first author. Basically, 1 or 2 years after you publish your first paper, you're trying out you're trying out older and older and older ideas. Generally speaking, for every 1 year of chronological age, the age of the ideas in your papers ages by about 1 year for the typical scientist. For Nobel Prize winners, every 2 years of chronological age, the age of the ideas trying out goes up by 1. So you can tell Nobel Prize winners are trying valiantly to combat the problems of age, but I mean, it's just, it's completely natural that the ideas that you have as a young early career researcher, if you're creative, they're going to be different than other folks, and you're going to spend a lot of time wanting to try them out, to test them out. We need a scientific infrastructure that allows early career researchers to try out their new ideas, or else we will end up in a situation where science advances one obituary at a time. This graph made me a little happier. This is a heat map of, on the x-axis is the career age of the first author, and the y-axis is the career age of the last author in each paper. And red means the most likely to try out newer ideas in the papers they publish. So it's this pairing of early career researchers as first authors with mid-career to later career researchers. That's the pairing, that's the sweet spot. right? So there's really an important role for later career researchers as well. Mentorship really, really plays an important role in essentially, I've had this experience over and over again. What I tell my my trainees once upon a time when I was still a professor was, go for it. Even if I was like, I don't know if this is going to work, I just say go for it. And that kind of encouragement, along with some, you have to still be critical because, that's who we are. That kind of encouragement plays a big role in giving permission to early career researchers to try their ideas out. Maybe they won't work out. I'm going to come back to that theme about maybe don't work out, because I think one major problem we have is in biomedicine, we punish failure too much. We punish failure too much, especially early on. I'll come back to that if I show you some evidence on scientific stagnation. So this is a paper that was published by Nick Bloom. It's a working paper. I think it's finally been published. Nick Bloom was a colleague of mine at Stanford, and Chad Jones. The theme is that per dollar, although we're spending a lot of money on research, a lot of money on R&D, the amount of return we're getting per dollar we're spending has declined over decades. The amount of money, and so what you have on the left scale is research productivity. I'm not going to get into exactly how they did this, and on the y-axis you have effective number of researchers, right? So the number of researchers has gone up. The productivity per researcher has gone down. Productivity. This is the general kind of idea. They have a whole, they're amazing economists, so they've spent a lot of time thinking about the measurements. I'm not going to get too deep into it. If you have a chance to read the paper, the title is "Are Ideas Getting Harder to Find?" I actually think that the answer to that question is no. They're not getting harder to find, but we have set up an ecosystem that doesn't allow early career researchers and newer ideas to have a shot. Here's Eroom's law. It's the opposite of Moore's law. This is the total dollar. This is again from a paper in the Science of Science literature. This is the number of drugs per $1 billion of U.S. R&D spending from the 1950s to 2010s, and you can just see a secular decline in the dollar spent per new drug. Now, there's lots of things that go into this. It's not just of course, regulating new drugs is a very important part of what we do. That probably in the 50s it was regulated too little. So that there's something we're getting for this. But here's those are the stats. Here's another one again from Bloom et al. Breast cancer, years of life saved per scientific paper, and per 100 publication. By the way, we've made tremendous progress in breast cancer. Huge advances in treatment, in prevention. So the point of this isn't that we're failing. The point of this is that we are spending a lot, and we've, in a sense, given the system we have, we reached the point of, we are at the point of like the flat of the curve. Every single idea requires vast investment. It's like a major fight, whereas like previously it was much less so. And the question is it just means that ideas are not there? We're just, putting up the last footnotes of all the ideas that exist, and that's why we're getting very little progress? Or is it that we have systematic barriers that prevent us from trying new ideas out, challenging other paradigms we have? We are in Max Planck's dream world of science advancing one obituary at a time. Or maybe it doesn't advance even after the obituaries. Okay. So I wrote this paper, again, with Mikko Pakalin. This was published in 2020 in PNAS. Just to give you some sense of I favor the second explanation. I think that we have systematic problems in how we support new ideas. I don't think that we are at the end of history as far as science goes. There are tremendous ideas out there. The science that we will have, if we do things right, 20 years from now will look nothing like the science we have now, because we'll revolutionize how we think about things. That's an article of faith for me. And I think that if what we have to do is we have to set up incentives and structures so that it actually works correctly. So what is this paper? This paper takes the age of the newest idea input for all papers in biomedicine. I'm sorry, not for all papers. This is for all the papers published between 1990 and 1999, and asks what is the share of papers that have NIH support, given the age of the ideas in every single paper. And so like here in the 90s, papers that were relying on ideas that were 0 years old, about 55% of them had NIH support, or reported NIH support. And you can see there's the NIH support fraction decreases with the age of the ideas, just exactly what you'd expect. The NIH is supposed to support early or new ideas. I mean, I could fund 40-year-old ideas. It'd come at a waste of time, but like you can see, that's exactly what we do. If you have old ideas, NIH is less likely to support your ideas. That's for the 1990s cohort of papers. Let me show you the same thing for the 2000s to 2009 cohort of papers. Our support for the first idea of papers that were relying on ideas that were about between 0 and 7 years old actually declined. It became more and more difficult. You know, it's like 45%, only 45% of the papers that were relying on 0-year-old ideas received NIH support for the cohort of papers that were published between 2000 and 2009. I was planning to like go back to this in 2020 later. If I'd had weird things that happened to me in the last 5 years, I would have updated this to 2010 to 2020, but I didn't, I got busy. So maybe someday. The point is that we have become way too conservative in a really bad sense in the set of ideas that we're willing to support. The typical age of NIH-supported research now is about 7 years old, whereas in the 1980s it was 1 or 2 years old. And there's systematic reasons for this. I mean, I just tell you one reason is that this is anecdotal. Who served as an NIH reviewer for on review panels? God bless you, every single, oh my God, I'm in a room with friends. God bless each and every one of you. I've also served on this. How easy is it to kill a new idea by saying it won't work? I've sat through that, and how hard is it for someone sitting on those panels to say, you know, I don't know if it'll work, but it's worth trying. It's difficult, isn't it? Ask yourself that question, right? You have to stick your neck out. We've become much more conservative than we kind of ought to be. Let me show you what I want to leave time for Q&A. So let me just go through this model very, very fast. It's a very, very simple conceptual model about what's going on. On the y-axis is the cumulative scientific effort, all the effort by all the scientists on any one particular idea. You can make a complicated version of this, but like here's a very simple version. And there's just like sort of this classic S curve. If you need a lot of cumulative effort before you make any progress on an idea. You know, you're going to stumble around in the dark down at the bottom of on the left of the curve over there before you get any kind of thing. What we call, Miko and I, what we call that kind of effort where you're doing this exploration, we're calling that the edge factor. Maybe if the scientific idea is good, you'll see this explosive S curve kind of growth, this sort of exponential phase growth. But eventually there's diminishing returns and you sort of get the flat of the curve for the idea. You know, for yet another paper on the structural anatomy of the small intestine is probably not going to produce a lot of advance, but you know, and so you just have this sort of classic natural history of what happens to any single idea. But this is a good idea. This is a really, really good idea. The problem is like, you don't know when you're down to the bottom left of that curve, if I keep investing in the idea, will it produce this explosive growth? You have some ideas that are like idea D over there. No matter how much effort you put into it, it's never going to go anywhere. And then you have some ideas that are like idea A. It's going to win you a Nobel Prize. And some of them are you know, B and C. And it's really hard to tell when you are down on the flat there how productive the idea is going to be. And so, you know, you can measure the impact of an idea, but you can also measure the amount of support we have for the edge factors ideas, like, you know, the sort of the early exploration. The problem we have now is that our research funding infrastructure, not just the NIH, looks like this. A huge amount of support for stuff that's like on the flat, up on top, and we punish people that are down at the bottom. We punish people that are down there at the bottom. You know, if your postdoc doesn't work out, you're done. I want to contrast that with Silicon Valley, where an early career entrepreneur establishes some company, it fails, and that's a stepping stone to future success. Because the infrastructure, the structure of how support happens for researchers, for entrepreneurs is that people are looking for constructive failures. We don't allow for constructive failures as much as we ought to in biomedicine. this is what, let me tell the story about Max Perutz. You guys know the story, I'm sure. The guy spent a decade trying to figure out the structure of myoglobin in the late 40s, 1950s. The guy he was a University of Cambridge researcher. Every single one of his professors told him, Max, you got to stop. You're very smart, but why don't you work on a feasible problem? This is just impossible. We don't have the tools to do it. He figures out the structure of myoglobin, revolutionizes our understanding of protein structure, and wins the Nobel Prize in 1962. The question I have is, could someone like Max Perutz survive in our infrastructure? Could you go for a decade where you're just you has this idea, it's like you know it's just going to work. He would have failed out, I think, a long time before he got to his success. It's very, very difficult to be someone like him. This is a healthy research ecosystem ought to look like. But we're very, very far from this. Again, lots of reasons why this is the case. So let me talk about some ideas for reform. I'm going to talk, let me just very broadly, we have to de-risk and expand transformative research. We have to reduce the price of failure, the cost of failure for early career scientists. We have to embrace metrics that I'm biased on this. This field of science is my field, so I kind of like it. But I liken it to baseball. Those of you baseball fans probably remember Bill James from the 1980s writing the baseball abstracts, book after book after book, complaining about the narrow set of statistics used to evaluate baseball player productivity. Right? You just looked at like RBIs and home runs and you said, okay, that's enough. Turns out RBIs and home runs are not enough. If you draw walks, actually, that's really productive. You know, Wade Boggs was a fantastic player because he's really good at getting walks. James develops all these metrics for what a good baseball player should look like. Moneyball essentially was the outcome of that. The metrics fundamentally changed baseball so that you could identify what's valuable in a baseball player much more effectively. Right now, the metrics we use to evaluate the productivity of scientists are basically two. It's how many papers you published and how much influence you have, volume and influence. But we know that there's so much more to a great scientist than just those two metrics. We are in the 19 pre-Moneyball stage of science. We are not measuring the things we want to measure, and so we're not rewarding the things we want to reward for scientists. If you go to Google Scholar, what do you see? You see an H index, which is essentially a terrible combination of volume and influence. Just as an aside on H indices, I'll just say, like, suppose you're James Watson and Crick, you publish one paper. It's the structure of DNA, right? And it gets 1 million citations, but you don't publish any other paper. What is your H index? It's 1. What if you publish 1 million papers in the Journal of Irreproducible Results and they each get 1 citation each? What's your H index? But it's 1. So you can see the H index is not measuring the thing we want to measure, right? I'm not saying don't measure influence. I'm saying that we need a broader set of dimensions on which we measure scientist productivity. And this is part of the problem. We're not measuring the thing we want to measure, but we want to reward. And so okay, I've already, God, I remember these days. Look at everyone remember the pile of papers before computers and you like threw the paper into the middle? I miss those days, but those days are long gone. One of the reforms that's happened under my watch is that we've centralized CSR, Center for Scientific Review. So it used to be that actually I think somewhere around a third of our institutes had separate reviews from the Center for Scientific Review. We centralized all of that so that all the reviews that happen for extramural research will happen in the Center for Scientific Review, which I believe is the best scientific review organization in the world. I mean, I've looked at Europe and other places. The nice thing about that is that we now have a common set of criteria that we use to do science. You don't. The problem with having the institutes do their own separate reviews is that it's very easy to get sort of like groupthink if you're reviewing yourself essentially. By doing this in the Center for Scientific Review, we're sort of guaranteeing that you're going to get independent reviews. The second thing we've done is we have reduced the 5 criteria. Everyone remembers the 5 criteria, right? So it's background, innovation, background significance, innovation, methods, investigator, and environment. And the problem for those 5 is that we often overemphasize methods at the expense of innovation. And we also overemphasize the quality of the investigator. Now you're saying to yourself, okay, well, of course we should fund great investigators. But imagine you're an early career investigator. You haven't yet made a reputation. It really hurts your chances. And so what we've done is reduced from 5 down to 3. 1, importance of research, including innovation. 2nd, rigor and feasibility. Methods, of course, is important. So we still have that. And then 3, expertise and resources. But that 3rd factor is no longer empirically, numerically scored. It's just a 1-0. Are you in a good environment, and do you have the sort of training you need to try the idea out, rather than a numerical score from 1 to 9 or whatever we used to do. It helps reviewers concentrate on, should this project be done, and can it be done successfully? I've just put into play a new unified grant funding policy. This is something we're working on right now, and we're going to you'll start hearing announcements about it very, very soon. It's a shift away from a strict pay line system. Now, about half of our institutes had this strict pay line system where you look at the scientific scores from the Center for Scientific Review, and then you look at the money that the Congress has given, and you just draw a strict pay line. It's just a very easy calculation, and you fund everything above the pay line. Sounds like a great idea. You're rewarding scientific merit, right? The problem is that as great as the Center for Scientific Review is, the fidelity, the sort of like ability for scientific panels to tell the difference between like a score of 11 and a score of 20 or is not that different actually in terms of the measured productivity. The other problem is that every single institute has its strategic plan that says we need to focus on this area. Here's a new area of promising area for scientific investigation. They have a strategic plan they put out every 5 years. There's no guarantee that the things that come out of that pay line system will meet the strategic plan that the institute directors themselves worked for years to develop. Under the new NIH updated unified strategy, pay lines are no longer the primary driver. The institute directors will still consider scientific scores. That's a fundamental driver of whether a scientific project is worth doing, but it is not the only driver. They'll consider whether the proposal aligns with the NIH's mission and strategic priorities. If there are new areas that pop up, there's going to be a mechanism for the NIH to convey to the scientific community that we're really interested in this area, that don't involve like a cumbersome process of a NOFO. We'll just put the idea up and say, look, we're interested in this idea, and the scientific community can respond or as they see fit. The scientific reviewers, of course, will provide their feedback about the rigor and so on. But if, let's say, there's a scientific idea that's up and coming and new, and it just scores just under what the old pay line would have been, or maybe even just a little worse, but it's really, really important part of the portfolio, the scientific directors will have the capacity to pick that project, so that the portfolio will allow the institute directors to take scientific risks, to try out new ideas. And the evaluation of the scientific directors will not just be on how many papers does each grant produce. If the portfolio as a whole succeeds, right? So we have a portfolio that cures type 1 diabetes, and 40 of the 50 projects funded all failed, but say 49 of the 50 projects all failed, but the 50th cures type 1 diabetes. That's a very successful portfolio. So they'll be able to consider scientific scores alongside other career stage and sustainability, and the metrics for success for the IC directors will be: do we advance health of the American people? If it's in basic sciences, does it fundamentally change how we think about some field in basic science? Have you funded a transformative paper? And it's the idea, and the idea would be you evaluate the portfolio as a whole rather than project by project by project, as far as the success of the institute director goes. Okay, the NIH has lots of existing, so I knew I was talking to an audience that already knew this, so I took out like 5,000 slides. The idea that we're like, the idea, it's been depressing to me to watch sort of the scientific community tell its early career researchers now that there's no more support for early career research at the NIH. Exactly the opposite is true. A lot of the statistics you saw that Jennifer put up is reflecting that sort of doom and gloom naysaying. When in fact, I'm sure you saw that the House and the Senate both approved essentially a budget that keeps us exactly the same as last year, right? There's no cut proposed by the House or the Senate. There's bipartisan support in this country for continued investment in biomedical research, and I'm absolutely heartened by that. Go back and tell your early career researchers the future is bright, and if you want to go to Europe, you'll take a 60% pay cut, and you won't have you won't have a garbage disposal. It's a depressing thing. Okay, the point is we need a culture shift that benefits early stage investigators for MD PhDs, of course, but also just generally. And we're considering many innovative approaches. I'm just spitballing here. This is not something that I've adopted. I really do want the feedback of the community for how to fix this problem, because it's going to take an embrace of the entire scientific community to say, look, we really do need a problem here. We need to figure out a way so that early career investigators can get their ideas tested. We need to punish failure less, and we need to empower, because, once upon a time, actually, we used to do that. It was not that long ago, in living memory. Okay, I'll just, rather than talk about the spitballing, let me open up to questions so you guys can have a chance. Thanks.
Follow the same curve with the age of ideas, and if they actually do better, is there any way you think about implementing that on the curve of the project or the investigate?
Yeah, so I have not done any empirical evaluation of it, but friends of mine who have, so, they tend to find that the HHMI model actually works really well for that. I've been talking a lot with Bob Tejan, the former head of HHMI, and I think he has some fantastic ideas. Now, that mirror program, I think, is a nice model, although it's a relatively small part of our portfolio. I think that's a very, very productive approach. How to implement it in the NIH context, especially for the extramural community, where we're working with, obviously, universities that have their own policies. That's the challenge. Like, the policy challenge would be that. But I think that's a very, very productive thing.
Hi, Atul Grover from Johns Hopkins University. Thanks for your remarks. I am curious, really intrigued by your idea of the science of science, and coming from a health services research background where we've sort of studied and tried to get at the improvement of health systems over time. You could debate how successful that's been, both in terms of generation of meaningful findings, as well as uptake on creating changes. So I'm wondering, particularly in light of kind of how we view health services research, AHRQ, kind of that health system science over the last 2-3 decades, how you view that science of science moving forward.
So first, let me just say I was part of that whole field. So it's been in 2010, the NIH issued a guide notice that essentially said that the NIH was no longer going to fund a lot of what that health system research did. I think that was a mistake. I think that the science applied to how the health system works is actually very, very important for the improvements of health systems. The NIH sort of getting out of the game actually, I think, hurt health policy over the last decade and some. It's not, I don't think, an accident that we've seen sort of a huge increase in spending without very much to show for it in terms of, like, increased life expectancy, for instance. So I think that was a mistake to not do those kind of metrics. It's going to be messy. It's going to be fight, but it's always going to be. I think it's very productive. Science of science as a field, actually, I think it's one of these things where, like, people go read the field. Like, you can sense the frustration of people writing in the field. They've been, like, writing these things for decades. And they have all these, like, fancy metrics that they want to use, but everyone ever does is they do, like, number of pubs and number of citations. And so we're still in the Bill James 1980s. He's like, I think he was like a night guard or something, writing the abstracts phase of science of science. But we can be in the Moneyball phase. We just need to, like, move to it.
David Hafler, Yale. I just stepped down as a chair after 16 years and trying to support physician scientists. And I haven't seen a big issue in getting K awards. The big issue has been these awardees looking at mid-career scientists and how to support over the cap. NIH grants have not gone up since Victor was my chair at the Brigham. The numbers are the same. I don't know how to support the over the cap for physician scientists. And to throw out an idea, we have K awards. Can we have something equivalent to HHMI, where we have salary support over the cap, evaluate on productivity, however you want to measure it, for mid-career scientists? Because the young scientists are looking at the mid-career and saying, how do you support it? And now I don't know what's going to happen with will there be Medicare cuts, how it will affect, but we are very worried about the finances of clinical departments using clinical revenue to support physician scientists, which we did. I don't know if we can continue that moving forward. So that's something you folks can actually do.
Yeah, thank you for that. I mean, I'm worried about that too. I've seen that. Just real fast about the early careers. A lot of the Ks, like I don't actually I spent a bunch of time trying to get I got a K myself. I spent a couple of years fighting to get the K. And essentially, I've told all of my advisees who want to get Ks that you have to tell essentially the story that you're really, really well trained. You have a great idea for an important topic, but you're just missing that one piece.
Yeah.
Right. And then after you get like a big KO2 or something, 5 years, you're not allowed to go for an R.
Which is crazy also.
It's nuts, right? So I like the institutional case. So you guys fight, you have a great environment, you have a great track record, you have an institutional K. As soon as you hire an assistant professor, you hand the K to them. And then, but you encourage them to get an R. If they get an R, you take the K back from them and you give it to the next assistant professor, right? So we sort of more have rapid support, so you don't waste 2 years of your assistant professor's time fighting to get a K, and then 5 years of no R. The mid-career thing is really, really important, and the salary cap is really, really important. How to address that is going to be a big challenge for us. And I don't have a solution to that, but I completely understand the problem. I mean, having sort of faced it myself.
So you asked for ideas?
Yeah.
There's plenty out there.
I can tell, yeah, especially a lot of folks I admire in the audience. So it's just
Stop this conversation.
oh God,
right?
okay.
Let's
So on the Kaplan-Meier curve that you showed for F-32s, some of the aspects did get worse, but actually the aspect that stayed the same was the immediate death of the career right after the F-32, which echoes exactly what happens when an MSD student matches into a residency that doesn't support research. Their career falls off immediately too. So I was wondering, going back 50 years, how can we address that problem that's really stayed stagnant in terms of death of careers immediately after they receive funding and leave that fellowship trained program?
I mean, I think some places are better at allowing folks who have a residency, working through residency, to stay engaged with research. It's tough. It's tough. I've seen this happen to my students too, where when they enter residency, it's like, and then it's 5 years of completely disconnected. I think in principle, it has helped to have that 80-hour work week, so that you could have, in theory, some extra time. 80 hours sounds like a lot, but it used to be like 120 or something, right? So the old guys remember. But I think having protected time in residency for folks who want to do research might be a way to at least encourage that and maybe fund that. Might be a way to sort of to address this. But that's definitely, it was a challenge in the 70s. It's a challenge today.
Hello, Sean Wahi, Yale. I just want to say I'm a bit on the younger side. You know, I'm trying to get into
You got black hair and everything. I mean, look at me.
Yeah,
it was.
But so I'm looking at it from a little bit of a different perspective. Also, I had an engineering undergrad, so not the traditional pipeline going into medicine. But one thing that stood out to me in your talk was that you mentioned that we see in Silicon Valley and these entrepreneurs and startup culture, they have VC funding, they have angel investing, they have opportunities to immediately get running, right? Even from a very young age, comparatively speaking. And we don't see that here. You know, waiting for R grants, K grants, et cetera. It's after years of training in this pipeline in the first place. Is there anything we can potentially learn from that side of things, the engineering, the tech side of things, Silicon Valley, where we see these younger innovators. Not everyone's successful, but like you pointed out, it's almost a badge of honor to have a failed startup and keep going. It propels you towards success. So what are your thoughts on that?
Yeah, I
Is there
mean,
any-
I think first, I think the funding structure should address that problem more than it does. I mean, I think I ran through this fast, but like I can't show you this, but like the set of things that we've tried to do has tried to address that first problem of making sure that even pre-docs have some capacity to get funding. As far as like the failure problem, it's not just early career researchers. We punish failure too much all across biomedicine. I mean, can you publish your productive failures? It's very difficult to do that. We need a culture that allows us to publish our productive failures and so that we can all learn lessons from it. It's not just this, but it's just a broader change. I don't know how to do that, but I other than maybe to encourage journals to allow that to happen, but it really does need to get addressed.
Makes sense.
So Anna Ganesan, UC Irvine. So I had a question about, you presented some very positive data in terms of the return on investment in NIH dollars. But as a junior career investigator I'm not a junior career, but I talk to a lot of junior career and mentor them. They are dispirited by the information they read and how the public perceives or thinks about the value of NIH funding. So what PR strategy are we going to use? Because it's really dispiriting for young investigators in this information environment of not hearing that positive information.
Yeah, I mean, I'll tell you, like I've talked to thank you for that question. I've talked to a crazy number of people. I think the mistake that we as scientists are making is essentially blaming the public for not supporting us. That's a message that's doomed to failure, right? What happened during the pandemic essentially caused a breach between us and the public. Right? 1 in 4 Americans think that we scientists do not act in the best interest of the public. Think about that, 1 in 4. We have to fix that breach, but that involves self-reflection and reform, not essentially telling the public, oh, you just don't understand science. And I think as far as like the message to tell young researchers, just look at the reality. The reality is the House and the Senate both agreed to fund the NIH at basically the same levels they've always funded. There's tremendous desire for cures for all these diseases. Even the movement, this MAHA movement, reflects a real desire by the American public for science to provide answers for thing after thing after thing, for diabetes, for obesity, for heart disease, for cancer. The American public, we actually have a great thing to tell the American public, great story to tell, but it has to also include self-reflection, honest self-reflection about what happened during the pandemic, and an addressing of that in a manner of humility rather than a demand that the public just understand science better.
Well, that was an excellent talk. So I just had a quick question. I'm a resident. I would say a young investigator. And I'm actually originally from Spain. I'm from Europe, and I came here not only because of the research opportunities, also because I wanted to have a garbage disposal system. But when transitioning, especially international physician scientists sometimes find the issue that we're a little bit limited, especially on the K field. We only can compete for K99s, where you're competing with also PhDs, and that makes it a little bit harder. And if the mission for the NIH is to recruit, international talent as well, and international physicians, are there any thoughts on potentially, changing that so that it's, these K awards are also accessible to potentially international physicians as well?
Yeah, I mean, I think the investment that the NIH makes in foreign collaborations is really, really important. And, I think attracting the best scientists from around the world to come to the US and work is a really good thing. The challenge is that we should be training researchers from around the world who want to be here and stay here and work here. And so that's the policy challenge. Like if we can address that policy challenge some way, we can find other ways to support foreign research. I personally am deeply committed to that kind of foreign research, but honestly, it's a challenging policy environment right now for reasons I can understand. So I'm working to try to figure out how to address that. Thank you. Thanks for coming to the US for this.
Jose Cavazos, UT Health San Antonio, MSTP, and ADRC. Can we supercharge K99s, R00s, and make them really more like K99, go and find a better job with an R21 type of award?
That's a great idea. That's a great. Good
I
idea.
mean, physician, there are mechanisms. Unfortunately, they are very underutilized
Yeah.
because they are not precisely very well aligned.
It's a really, really good idea. If you have more suggestions like that or other suggestions, or if you just want to tell me I'm wrong, please don't reach out. Victor knows how to get in touch with me. So I really do appreciate it.
Okay. I think see that people are very excited and energized by this meeting, and the lineup of questions is great. You say you open your input and ideas.
I am actually. That's true.
Well, I think what's going to happen is we'll have proceedings from this meeting. I'll be sure you get a copy of it. Look at some of these ideas that came out from us and see what you can do, right? We do thank very much. I do want to point out that the focus on earliest career is important, but I think physician scientists have additional challenges that simply having more grants may or may not address the issue. And we need to address those things as well. But thank you so much for spending your time with us. I know how much in demand you are in your time, and it goes to show that you're certainly open to many of the issues that we're concerned about.
Thank you, Victor. I wish I could stay the whole time because this is going to be a fascinating discussion, but I will read the minutes very carefully. But my schedule is kind of crazy. So, but thank you so much. Appreciate it.
Thank you.
Bye now.
Take care. Okay, we're off for a good start. Obviously, time is going to be an issue. We're about 15, well, actually more than that, behind. But you know what? We want to ask them these questions, and I hate to cut it short. So that's great. So the next speaker, obviously, is someone who needs no introduction, Bob Lefkowitz, a good friend from Duke, Nobel laureate, and of course, he has a world of experience in living through different stages or different phases of research in this country. So we'd like to hear him to come and share his experience with us and set the stage. Thank you, Bob.
Well, thank you very much, Victor, for that kind introduction. It's indeed a pleasure to be with you today, a subject of great interest to me for a great many years. So I imagine that many of you in the audience, but perhaps not all, are familiar with the term the yellow berets, the obviously pejorative moniker that was applied to a cadre of future physician scientists whose research careers were essentially kick-started when they were drafted into the United States Public Health Service and assigned to the NIH during the Vietnam War. I was one such individual. And today in my talk, I'd like to share with you my own personal perspective on the experience and what this program, which, as I say in the title, was arguably the most successful program ever developed for training physician scientists, was all about, and see if there are any practical, actionable lessons that we can draw from that successful program that can be applied in the present era to the problem that we're all here to discuss today, namely, as we've heard, the marked decline in the number of physician scientists. Okay, so this is not advancing. Well, you're missing my first slide. Okay, yeah, let's try again. Well, okay, too bad. That was a picture of me at my medical school graduation in 1966, flanked by my parents. And the reason, that's not this one, obviously. Yeah, too bad. Anyway, that was a happy day for the family, needless to say. But the reason I wanted to show it is because as I graduated, from medical school in 1966 from Columbia's College of Physicians and Surgeons, I had done no research, not one day, not ever, not in college as a chem major and pre-med, not in medical school, where we had multiple opportunities to do research. But I always took clinical electives because I was a man in a hurry who wanted to become as adept a clinician as quickly as I possibly could. I loved science, but I had absolutely no interest at that point in my career in doing science. I did my internship and residency at Columbia. Let's see, here's me. Some other future physician scientists here that you may recognize: Mike Weisfeld, Susie Operl. But I would have gone directly on from here to finish my residency in medicine and a fellowship in cardiology, hung out my shingle, and I would have been a very happy camper. That was the plan. But it was interrupted by a cataclysmic event. Again, these slides are not advancing. Thank you. And that cataclysmic event was the Vietnam War. It was an extremely unpopular war. There were demonstrations, even riots, and nobody wanted to participate in this war in any way. And this was certainly true of many physicians. However, there was a draft. Now, for young men over 18, there was a so-called lottery draft. Everybody got a number, and whether you went in or not depended on the luck of the draw. But for physicians, no lottery. There was a doctor draft. And as you can read here, following your internship or a period of residency training, all doctors were inducted for 2 years of service in the armed forces, potentially disrupting their plans to begin clinical residency or continued education and training toward a research career. The formal name for the doctor draft was the Berry Plan. It had been developed during the mandatory doctor draft during the Korean War. It allowed graduating MDs to defer service to undertake 2 years of clinical training without interruption. It allowed military to draw upon a physician workforce with more advanced training, and provided civilian hospitals as well with needed resident physicians. 42,000 MDs participated in this program during its lifespan. Now, once you were drafted into as a commissioned officer in either the Army, the Navy, the Air Force, or the United States Public Health Service. I would point out that at this time, the United States Public Health Service was not only one of the uniformed services, it was one of the military services. Now, if you were drafted into the Army, the Navy, or the Air Force, you were pretty much guaranteed of spending one of your 2 conscripted years in Vietnam. But if you were drafted into the United States Public Health Service, then you had at least the chance to be assigned stateside, for example, to research institutes like the NIH, the CDC, et cetera. So you can imagine just how competitive it was to get these commissions in the Public Health Service. So of the 7,500 or so graduates each year, up to 30% would apply to get the Public Health Service commissions. And they went through a lengthy screening, many different steps, and in the end, less than 10% got the commissions and were assigned to the NIH. I was one such lucky individual. The formal name for the program was the Associate Training Program, or ATP. However, as you know, more commonly it came to be known as the Yellow Berets. So where did this pejorative term come from? Well, the history is the following. The Green Berets are, of course, our most vaunted and elite combat special service officers. And in 1966, the year of my medical school graduation, the peak year of the Vietnam War, a song came out and rose to the very top of the hit parade. It was called The Ballad of the Green Berets. And it basically talked of their heroism and great deeds. Within a couple of months of that, another song came out by the very well-known folk singer, Bob Seger. You can see the logic. the words there, the lyrics. And he was poking fun at the draft dodgers, the people who in the lottery draft who escaped it by going to Canada or claiming they had heel spurs, which perhaps they didn't. And it was not directed at the public health service officers, but it wasn't too long until at least some began using that term for the people in the public health service. Now, we were commissioned, as I said, as commissioned officers. We were given naval ranks, so we were lieutenant commanders when we entered the service. That's the equivalent of a rank of, say, major in the United States Army. And unlike this good-looking young man, we did not wear uniforms. We wore white coats because we were either in the lab or on the clinics. In this photograph, there's me, and there are a couple of other future notables in here. Now, as I said, we did not wear uniforms, except if we wanted to fly on a plane. Because at that time, and I don't know if this is true today, but at least at that time, if you were active duty military in uniform, you could just go to the airport and fly standby on essentially any domestic flight. So what we did is groups of 5 or 6 guys would get together and we'd buy one uniform. And whoever wanted to fly would wear that uniform. Now, of course, the problem was in my group of half a dozen guys, we ranged in height from about 5'5" to one guy was about 6'3", 6'4". Okay, so depending on how you fit, you could either be stumbling over the pants or they could come down to your knees. Now, I was fortunate. At least way back then, I was 6 feet tall. So I was right in the middle of the range. And so the 2 times that I flew wearing that uniform, I was fairly comfortable in it. Now, we didn't know much about military protocol, but one thing we did learn and even practice before we wore the uniform and went to the airport was how to salute. And we also knew the rule that if you encountered an officer above your rank in any branch of the service, it was your obligation to initiate a salute. So one of my colleagues told the following story. I cannot vouch for its veracity, but I had no reason to doubt it. So he was at Washington National, not so called at the time, waiting for a flight at the gate when a uniformed officer, perhaps looking much like this guy, showed up. He was an older man and had a variety of stripes and epaulets on his uniform. And so he very reasonably assumed he was a more senior officer. So he popped up, gave him a crisp salute, and the officer returned it, and they started chit-chatting. And the officer, the senior officer, asked my friend and colleague, well, what branch of the service are you in? He said, I'm in the United States Public Health Service. He said, oh, that's wonderful, he said. And so my colleague said to him, and what branch of the service are you in, sir? And the guy said, well, I'm not in the service at all. I'm the pilot. I'm here waiting for the flight just like you. So there were some hazards in some of these military responsibilities. This photograph was taken in 68 or 69 and shows those of us who were in the program in the National Institute of Arthritis and Metabolic Diseases. This was not a happy time for me. Up until my experience at the NIH, I had, somewhat immodestly, I tell you, succeeded in everything that I had set out to do in my life, whether it was schoolwork, playing baseball, whatever, stickball. But here, for the first time in my life, I failed. And for a year or a year and a half, I made no progress at all. It was the first time I had ever encountered something where no matter how much effort I put into it, I did not seem to succeed. I became very depressed. The only thing that was clear to me was that research would have no future plan for me in my future career. As fate would have it, during the last 6 months, I did begin to make some success in my project and published my first couple of papers. As they say, the rest is history. But it was a rough start. It was a rough start. Now, so What were the duties of the NIH clinical associates? Well, we had two responsibilities. We cared for patients at the NIH Clinical Center, and then we conducted mentored research. The split between the two activities varied a lot from one institute to the other. In my institute, they're known as NIAMD, National Institute for Arthritis and Metabolic Disease. We spent about 80% of our time doing mentored research and 20% of the time on the wards. For me, I was assigned to the clinical endocrinology branch, although I would ultimately become a cardiologist. But the training I had was very much the equivalent of a 2-year endocrine fellowship. The organization, the physical organization of the wards, the clinics, and the laboratories was as shown here in the clinical center, building 10 as it was then known. I haven't been back for a number of years, so I don't know whether this is still the same. But the key feature is that the patient rooms and the laboratories were directly next to each other, separated only by some nursing service officers and service offices and walkways through between the two. And so you could walk directly from your laboratory. It was maybe 30 or 40 feet onto the clinical service. And this close physical proximity of the two tended to very much encourage even those doing very fundamental or basic research to always be looking for the clinical ramifications and implications of that work. Now, the academic legacy of the Yellow Beret program was just remarkable. Here's some data. One study in 1998, so roughly 30 years after I was there, shows, as you can see, that anywhere from 15 to 30% of all professors of medicine, chairs of departments, division chiefs at the major teaching hospitals had all been Yellow Berets. This study found that you were much more likely to become a dean or a chair of a department or to achieve full professor rank if you had been a Yellow Beret as compared with a cohort which had not been. And then there were the academic accolades, which are really quite remarkable. So in this study done in 2010, 64 had already been elected to the National Academy of Sciences. 125 had been elected to the, as it was then called, Institute of Medicine. 4 of the 9 NIH directors to that time had been Yellow Berets, and 10 of the 122 NIH Institute directors had been. And then, as has been, I think, briefly alluded to earlier, there was this proliferation of Nobel Prizes. So just to brag on my class, if you will, those of us who went in 1968 and left in 1970, this is a picture of 4 of us from an article in the New England Journal on saving the endangered physician scientist. And I think the caption kind of sums up a lot about this. It says, on July 1st, 1968, at the height of the Vietnam War, 4 young physicians with little to no background in research reported for duty at the NIH to begin fulfilling their draft obligation as commissioned officers in the United States Public Health Service. This intensive 2-year experience ultimately led each of them to incorporate scientific research into their career plans as physicians. Their future accomplishments would include the discovery of oncogenes, research that led to the development of statins, and the discovery of a family of receptors that now serve as the targets for 1/3 of all drugs approved by the FDA, and as a bonus, 4 Nobel Prizes. The 4 physician scientists were Harold Varmus, Michael Brown, Joe Goldstein, and myself. Now, I want to make some points about the importance of mentoring, which has already been referred to. And this is a slide which shows the scientific lineages of remarkably 10 Vietnam-era Yellow Berets who trained in research at the NIH in an 8-year period between 64 and 72, and later won the Nobel Prize. Now, these 10 future Nobel laureates are shown in the yellow ribbon down below. And each one is surrounded by a blue rectangle, which I am using to try to indicate that they were Nobel laureates. Now, as you can see, 4 of these actually trained with a Nobel laureate. Nobel laureates colored blue. So 4 of the 10 trained with a Nobel laureate. For the other 6, however, including myself, you don't have to go back any further than a scientific grandparent. So if we say, if you trained with a Nobel laureate, you had a Nobel laureate parent. If you had a Nobel laureate grandparent, that covers the other 6. So for example, for myself, you can see that through Jesse Roth, connected to here, yeah, Roger. And then if I go this way, I go up to see it. Some of these lineages are really quite remarkable. Here's one going down this way, where in 7 generations, there's a Nobel laureate in the tree at every generation except for Earl Staton, a noted biochemist, certainly of Nobel stature. And he trained 2 Nobel laureates, as you can see, Prusner and Brown. He also trained Ira Paston, who trained 2 Nobel laureates, myself and Varmus. And 4 of us have already trained another Nobel laureate. Now, the point isn't so much Nobel laureates or not. The point I want to make is that there are clearly must be transferable elements in learning how to do high-level science. Elements, styles, judgments that can be passed experientially from one generation to the next. And to emphasize a point made by Jennifer before about the importance of physician scientists, here's the same family tree where I have basically annotated it with a red symbol for everybody who was not just a Nobel Prize-winning scientist, but was a physician and therefore a physician scientist. And if you look at that, you can see how much red there is here. But if now you just confine your attention to the blue rectangle, you can see just what a significant percentage of the Nobel laureates were physicians, including some people who, if you look at them, I'm sure you're surprised to see that they were physicians. And in virtually all of these cases, they had done at least some clinical training post-graduation. So again, I want to stress 2 things. 1, the importance of mentoring and developing physician scientists. And 2, the obvious conclusion about the importance to medicine and biomedicine of research carried out by physician scientists. So, okay, what conditions in the 1960s enabled these 10 physicians who were yellow berets to win Nobel Prizes and hundreds of others to become leading figures in academic medicine? And so in this and the next slide, I have tried to summarize information from a lovely essay that was published in 2012 by Mike Brown and Joe Goldstein, analyzing just this situation. And here are some of the conclusions that I drew from their paper. 1, and most obvious, the Vietnam War drove intense competition for United States Public Health Service commissions. There were outstanding mentors, both PhD and MD. There was an intense research experience with relatively few distractions. There were evening courses in many cutting-edge areas of basic science taught by staff scientists. There was a focus on fundamental rather than translational research, but discoveries strongly influenced drug development nonetheless, as well as medical practice and human health. And of course, those who were yellow berets didn't just go on to careers in basic research. They went on to careers in translational research and clinical patient-oriented research as well. Importantly, I believe, basic science was at the core of medical education. Medical students were taught the joy of finding new facts or overturning old ones. So Brown and Goldstein then went on to ask, well, what's changed over the last 60 years? I took 4 points from their essay. First, there's no doctor draft or other obligatory service obligation for young adults. Second, basic science is no longer at the core of medical education. It's been reduced to 1 year or less. Courses focus on a restricted set of disease-relevant facts with little discussion of where these facts came from. Now, Duke has been a leader in the compression of basic sciences to 1 year. And I often tell the story that when I came to Duke in 1973, having just been training at the Mass General at Harvard and Columbia before that, I was used to dealing with medical students on rounds who had had 2 full years of basic science before they started their clerkships. But here at Duke, on my first few rounding tours, I was confronting for the first time students who had only had 1 year of basic science. And there was an immense difference. I had to completely reboot. We use the Socratic method, obviously, in teaching. And what I found in my clinical teaching was they couldn't answer any of my questions. Okay, so I had to completely reboot the way I did rounds. But yes, they had very little basic science education. Finally, the conviction that progress in medicine ultimately rests on a fundamental understanding of physiology has been largely lost. So, are there any lessons that we can take from the yellow berets that might be applicable? Well, I have a few ideas, and you may have others. First one is we might offer alternative medical school curricula, for example, as they do at Stanford, with increased emphasis on basic science and which stress the scientific and experimental basis for current understanding of physiology and therapeutics, while also offering opportunities for actual lab experience. So PJ Utz, who I think is going to be on one of the panels virtually, went through with me recently a series of, I think, 4 or 5 different pathways that they have at Stanford for educating their medical students, where the students can opt into one or another pathway and get an enhanced exposure to basic science and even some lab time. Now, this is one that I happen to believe in very deeply, but maybe totally impractical, but I keep hoping. I favor the development of government-supported peacetime service programs for physicians in training, highly incentivized and competitive, which offer research training opportunities modeled after the yellow berets. Only the most highly competitive applicants would be accepted, so that these would be prestigious appointments, and only the most highly accomplished mentors participate. I would add that my own personal view is that this shouldn't be just for those wanting to become physicians. I myself favor the reinstitution of the draft, but not a military draft. Okay, although one of the options in my fantasy would be if you wanted to serve your 2 years in the military, that's fine. But there would be all manner of other things, and there would be deferments in this idea. So if you were going to medical school, for example, it would be like the yellow berets. You would keep getting deferments through graduation, and then you could even get a deferment for a couple of years of clinical training. But then you'd have to go in and you'd have a series of options, one of which would be attractive research possibilities. If you were stopping your education at college and didn't know what you wanted to do, then your deferments would end then and you would go in. And today, most college students I've found get 1, 2, even 3 gap years. And then if you were stopping at high school, your deferments would end and you would go in then. So that's one idea. Finally, we could increase the participation of physician scientist role models in clinical teaching, rounding, and clinics. I think it would be important to vet them so only the most clinically adept are showcased. And I found for the first 20 or so years of my career at Duke, amongst the things I really got out of my annual teaching stint on the wards was I could attract third-year medical students, second-year medical students who were doing their rotations. I could attract them to my laboratory for their 3rd year, which was always a research year. So it was a chance for them to see an adept clinician, who had a laboratory. So those are some lessons, and hopefully some of them will resonate with you, and perhaps you have other ideas as well. I think this talk, in a way, has sort of complemented what Jay had to say, in that he was really focused, really, when you think about it, on issues of retention of young physician scientists. I'm more focused on how do we get them in the first place? How do we convince young, aspiring physicians that there's a very attractive research career where you can not only be a doctor, but you can be a scientist. So if I piqued your interest at all in the Yellow Berets and that whole era, I have 3 recommendations for you for further reading and study. The first, unabashedly pushing my little memoir from a few years ago, a lot of material in there about the Yellow Berets, the pathway for physician scientists, if I experienced it, and a little bit about my science. A deeper dive into the whole Yellow Beret experience was this book from a few years ago by Ray Greenberg, which talks about the class of '68 that I just showed you, Mike, Joe, Harold, and myself, and how our careers were shaped by that experience. But if, as I imagine, and all of us do you have limited time, want to get the most bang for your buck, I recommend this 4-part podcast by Alan Alda from a couple of years ago called Soldiers of Science, the Vietnam War, Anthony Fauci, and the Doctors Who Revolutionized American Medicine. And the photographs on this jacket for that podcast are those which we all submitted they were taken in 1965 when we were medical school seniors, and they were on our applications for the United States Public Health Service Commission. I can't recognize all of them, but going from right to left, you probably recognize a young Tony Fauci, who, by the way, was also in our class of 1968. He always tells us when we get together, he feels like he has an inferiority complex. He claims he's the only one in the class who didn't get a Nobel Prize. Well, we always reassure him and said, Tony, you did okay. So there's Tony. This is Joe Goldstein. I don't know who this is. That's me, Krusner, little piece of arm that's right there. So anyway, I thank you for your attention and happy to take any questions.
Thank you so much, Bob, for that inspirational and historical lesson in terms of the Yellow Berets and physician scientists. Do we have any questions? I have a question for you. In addition to the basic translational fundamental sciences, what are your thoughts on some of the newer kinds of work that people are working on, including use of foundation models and AI in trying to make discoveries?
As we were hearing from Jay, each generation has its new approaches. And for those who are as long in the tooth as me, we're used to a very different approach, a reductionist biochemical approach. One of the things I have found in my own career is that if you're going to stay at the front of a field, you need to continuously regenerate the technologies and approaches that you use. From time to time, I'll have somebody who trains in my laboratory, and they learn a certain technique or set of techniques. And through the almost 60 years now that I've been doing this, with a turnover time of about 10 or so years, the technologies in my lab are changing. They're adapting. The questions are flowing naturally from what we did before, but the technological approaches are changing. But some trainees, when they leave, think they can build a career on a technique or a set of techniques. There was a wonderful ASCI presidential lecture somewhere around 1986 by Joe Goldstein called PAIDS, Paralyzed Academic Investigator Disease Syndrome, okay? We talked just about this, that if you try to hang your career on one technique, you're paralyzed.
Yeah.
The question has to come first. And then once you have your question, then you have to evaluate what is the best technique or set of techniques that I can use. And they're always changing. I mean, I often point out that at this stage of my career, with the exception of a couple of different relatively primitive forms of chromatography, there's not a single technique used in my lab that I did with my own hands, okay? which makes it more difficult to obviously troubleshoot. But anyway, so I think, yes, you have to be continuously open to new things.
Hey, Bob, that was an absolutely spectacular talk as always. I could listen to you for the rest of the meeting if you could go on with it. It's really great. And I love this idea of public service and making that as a way. I think that's a brilliant idea. Any thoughts of how we could sell that? I
Well,
mean,
you know,
how,
I'm
what can
sorry
we do to
to
other than,
stick
it's
around.
obvious to all of us.
Jay
It was,
didn't-
yeah.
Need government participation. I mean, I think we need legislation, but I think we should have a mandatory draft, not for military purposes, but
Right.
so that every young person feels an investment in the country. I serve. And in the course of doing that, like the Yellow Berets, there are unintended consequences. Nobody ever dreamed what would come out of that. So yeah, I think, you know, we need advocacy at the level of legislatures. I have no personal experience with that. I'd be happy to, you know, pitch the idea to anybody who's willing to listen. But yeah, I mean, if we get a group of us together and maybe get some influential senators or congressmen, this may not be the best administration to be pushing that, but who knows?
Thanks, Bob.
Thank you. One more question?
Great. Thank you so much. I'm Talia Swartz at the Icahn School of Medicine at Mount Sinai. Amazing talk. And I'm very curious about this idea of curiosity in our medical students and with the shortening of the pre-clerkship phase of curricula sort of around the country. This is a theme, this idea of free, less basic science training and less time for curiosity. And so this idea of getting sort of bit by the bug is something that is going to be harder, I think, for us. And so your idea about creative curricula is ambitious. I don't know that all of our schools are equipped to allow for multiple pathways, but what are the other things that you think that we can do to get people in this sort of arms race where they're trying to keep up and match for residencies and the barrier gets higher and higher? How do we get them to be excited about the science for the sake of science?
So I think that key role models, and Jay spoke about somebody who turned him on. On the Nobel website, you can find an autobiography for every laureate you're required to write. And Harold Varmus and I were classmates in medical school. I didn't read his autobiography. He won the Nobel Prize very early, I think in 1989. And I didn't win the prize in 2012. I never read his autobiography. I wrote mine a few years ago. I just happened to look his up for some reason. Both of us, in our autobiographies, cited the same professor in medical school as really turning us on to the idea that a physician could do research. And that man's name was Paul Marks, who was a very noted cancer hematology specialist. He was a real physician scientist. He ran and taught most of the course called Introduction to Clinical Medicine. You did blood smears, you passed NG tubes on each other, all that stuff. But he assigned readings to the literature, not just about, for example, hemoglobinopathies, sickle cell disease, thalassemia, which was just being worked out at the time. He assigned original papers so we could read about how, sequencing proteins and DNA was leading to these amazing discoveries. And that was a real turn on, and we both cited it. So I think that kind of role modeling is the way to go.
In the interest of time, could we have any other questions come up to you after? Yep. And so we'll want to introduce our first panel. This is going to look at previous past efforts, what has worked, what hasn't worked. Our moderator is Dr. Juanita Merchant from University of Arizona. Our panelists include Sam Gill, the CEO of Doris Duke, David Ginsburg from University of Michigan, who also authored that NIH report, Mukesh Jain from Brown University, Dean of Brown, Louis Muglia, who is going to be on Zoom or virtually, the CEO of Burroughs Wellcome Fund, Ivy Ng, immediately former CEO of the Singapore Health System. She will also be joining us virtually as well. So we look forward to the discussion.
All right, good morning. I'm really excited to have this panel and just to briefly introduce them again. So I'm Juanita Merchant at University of Arizona. I'm a physician scientist there. We have Sam Gill, who is president and CEO of the Doris Duke Foundation, David Ginsburg, my mentor, who's the James B. Neal Distinguished University Professor, and Warner Lambert Davis Professor at the University of Michigan, and Mukesh Jain, who is the Senior Vice President for Health Affairs and Dean of Medicine and Biological Sciences at Brown University. And online we have Louis Muglia, who's the President and CEO of the Burroughs Wellcome Fund. And joining us from Singapore is Ivy Ng, who is the Senior Advisor for the Singapore Health System. So there's a general question for each of you to answer that we had discussed ahead of time, which is that as you think about the arc of physician scientist experience, perhaps your experience, what worked and what you think did not work as we lay the foundation going forward. I'll start with our foundation.
Right, starting with the one person who's not a doctor or a scientist. Well, thanks a lot, Juanita, for moderating this. Thanks to Victor and the Academy for including us, and excited to be a part of this conversation. My principal experience with medical science is my annual physical, which I only do every 3 years. So I'm not the world's expert, but I'm really lucky to work with a group of really committed scientists who lead our work. Many of you know Cindy Escobar Alvarez, who directs our program in medical research, and Doris Duke Foundation, among other issues, has been a significant investor in medical research and early career physician scientists. Why do we do this? First, let me just sort of give you some context before I offer a few less sort of localized lessons, and then maybe as the panel goes on, we can talk a bit more globally about the kind of the wider context in which these questions are being raised. Doris Duke in her life was a significant investor in medical research to cure diseases. And when she died, that's what she said she wanted part of her legacy to go to. As you all know, it's really difficult to make significant progress against diseases with, $10 to $15 million a year nominally. But thanks to folks like Tony Fauci, who's on our board, the early leaders of the foundation recognized that physician scientists represented a population that, as you all know, has historically accounted for an outsized share of innovation in medical research and in biomedicine that ultimately has profound practical applications. And it's a relatively small population. And so the feeling was that with a limited amount of resources, we could make a difference in this population nonetheless. And it's a population whose future we've had anxieties about for decades because of all the trend lines that have been discussed. We've invested about $300 million over the past 25 years in supporting the careers of early physician scientists. Our programs have actually ranged from secondary education research exposure opportunities all the way to more later stage career awards. Our two most significant programs, one was a longstanding fellowship for predoctoral would-be physician scientists to give them some research exposure. And then the other, which many of you know, is the Clinical Scientist Development Award for early career researchers. I'm sure we have some in the room. We're very proud of you and proud to be associated with you. So just a couple insights from those programs. The first one is efforts to engage medical students in to engage their interests in research by providing resources for research exposure just were not that effective in turning predoctoral medical students into late stage into career researchers. I mean, single digit percentages conversion. That's number one. The second lesson is that the providing support to early career researchers can be very effective in advancing research. We don't find that it has a huge marginal impact on research protection. So a lot of the clinical scientist development award winners had existing research protection. What the CSDA allowed them to do, though, was to actually advance research. And we saw, some really significant effects from that in terms of career progression. And then, of course, ultimately the benefits to society from this research. The sort of the third lesson that I would hold up from that is our work was not effective in changing the way research was happening or driving innovation in the kind of research that was happening. So, by and large, we were enabling great scholars to move more quickly. We weren't necessarily enabling iconoclasts to challenge what the research agenda was, or to pursue topics that it might have been more difficult to build a case for a K-1 or an R1 grant. And then the last lesson that I just offer before yielding is we did find that we had trouble. This isn't, well, let me put it this way. This isn't surprising. I thought, Bob, your presentation was tremendous. And I think, one of the things that your chart really illustrated is that social capital density is really important in research productivity and discovery. But we also know that forms of professional progress that rely on social capital and social network density then tend to replicate other patterns of inequality that exist within the society or within that field. And that was something that we certainly encountered as well. So we were having a very difficult time with our research awards, bucking trends in who's represented among early career physician scientists and who succeeds. We were able to undo that over time in changing the way that the award was judged and changing what the criteria were. So some of you have read some of that work, but that was another challenge that we had to confront, sort of independent of our ability to enable research. So anyway,
maybe
thanks.
I can interrupt. Maybe because we're talking about the foundation support, I'm going to jump over to Louis Muglia from Burroughs Wellcome, and I'll come back to the physician scientist. So we'll have that discussion first. Louis, did you want to make a comment?
Yes, please. Thank you, Anita. I truly appreciate being invited to contribute to the panel discussion, even though it's virtually, and I wish I was there with you in person. Truly enjoyed Dr. Lefkowitz's talk and Dr. Bhattacharya's talk that I heard earlier. I'm, as mentioned, president of the Burroughs Wellcome Fund, and the Burroughs Wellcome Fund has had a longstanding commitment to physician scientist development. The Burroughs Wellcome Fund was established from the Burroughs Wellcome Company in 1993 as a separate nonprofit with a gift from the Wellcome Trust. And since that initial investment from the Wellcome Trust, like the Doris Duke Foundation, we've invested about $300 million in our overall physician scientist development programs overall. And I would say, we view really what's been successful is investing in early career development of physician scientists. Our flagship program started as the Career Awards in Biomedical Sciences, which awarded equal numbers of grants to PhD, non-MD scientists and clinical scientists, MD or MD PhD scientists. I was fortunate to get one of those in 1995. And I can say from my experience and from our awardees through the years, I think what those awards have been able to do is first provide resources in a way that are very flexible to be used. And I'll tell you, what we're trying to select for in our awardees is individuals that are taking risks, that are looking beyond what looks like an incremental process in the discovery pipeline. And so it allows them to take chances, it allows them to branch off into some new areas. We allow them to flexibly utilize their resources. And what we really hope to do is build community amongst our awardees, them with our advisory committee members, and have an ongoing mentorship role, as we all believe is very important. And Bob Lefkowitz, I think, has experienced this by being one of our board members for several years, that we remain very committed to this development. With the genesis of the NIH K99 ROO Awards, the PhD portion of CAB's Career Awards in Biomedical Sciences was sunsetted so that we could fund more medical science, clinician scientists, and that transitioned to our career awards for medical scientists. what's been successful about that is we're getting wonderful candidates and applicants who I think are benefiting from our investment. What we wanted to see more of and have tried to actively engage this is for those physician scientists that find their passion, like we heard from Bob later in their careers, mechanisms of support for those, especially with MDs and don't have PhDs. For our CAMS and CABS awards, the predominant awardee recipients were MD PhDs. And so we've tried to address that in a couple different ways. One, we really think about the MD non-PhD applicant pool as a little bit different from the MD PhD applicant pool. And we try to select individuals that give us equal numbers from that so that we're approximating parity when we come to our finalists. And that's worked very well in terms of they don't have the same CVs, but we don't expect them to, and we try to evaluate them against their peers. The other thing we've done is we've piloted a program called the Physician Scientist Institutional Awards, which start out as 10 awards to different institutions. Several of the folks are in the audience that have gotten those awards, and I think they've been very successful. So what those were meant to do is, again, try to preferentially support physician scientists, particularly from non-typical areas, surgeons, interventional physicians that wanted research time. Again, challenges around protected time certainly appeared with those, getting people involved initially. And then some medical school pushback actually to engaging students in year-out programs and other commitments. So the physician scientist program has informed us for what we will do in our next phase of physician scientists, but we'll probably have something that supports MD, non-PhD physicians more on an individual than institutional basis moving forward based on the experience, just to open it up to a broader catchment area. We've had other programs. We had a program called Clinical Scientist Awards in Translational Research that was from 1997 to 2006. It was, again, a very successful program, but Burroughs Wellcome Fund, I would say, is a modest-sized science philanthropy. We give about $40 million in grants out a year. And what we really wanted to do is maximize the impact of our awards. And we saw at that time, maybe not now, a significant overlap with what the NIH had taken on as priority areas to fund. So we always are looking for where we can fill gaps. And we feel this clinician scientist opportunity to really support individuals, maybe before they're ready to be competitive for a K award, similar to an institutional K-12, or maybe even before an institutional K-12, is one place where I think substantial impact can be made. So we are continuing to try to promote diversity of all kinds in the physician scientist workforce in terms of individual demographics, but also in terms of geographical demographics. We want institutions from around North America, United States and Canada, to have the opportunity to be supported and look forward to encouraging the young scientists in a time that we have heard has been really challenged. So looking at opportunities also to help individuals during this transition phase where funding has been cut so dramatically in training programs and in awards that they thought they were going to receive. So we are always looking for ideas and partners. We have a great series of advisory committee members that support our programming. And we invest in physician scientists, not only in our career awards in the medical scientists, but in our pathogenesis of infectious disease program, our innovations in regulatory sciences program, which is meant to accelerate drug and device discovery into clinical practice, and our science interfaces awards. So lots of opportunities. I look forward to talking with any of the students, trainees, and faculty members about the opportunities that exist at the Burroughs Wellcome Fund. So with that, I'll thank you for the invitation and look forward to any questions later on.
Great. Thank you, Louis. So I'm going to turn to our panelists here from the university camp. So first, I'm going to start with Dr. David Ginsburg, who was the chair of the Physician Scientist Task Force, and it kind of reminded me of what Bhattacharya Science of Science. So that was the original Science of Science back in 2012. So maybe you can give us some the high points and what we need to use from that to go forward.
Yeah, thanks, Juanita. And Juanita was a member of that committee. We worked on that together. Well, I think Bob's talk in a lot of ways summed up. I don't want to be too depressing or pessimistic here, but when you talk about the charge here of what worked and what doesn't work, I think a lot of it, to me, what I'm going to tell you is that what we used to do, I think, worked, and what we're doing now doesn't. And this may be a sign of my age, being too backward looking, but I think one of the key things, it actually came out of our study, different than what Bob described, but in the cohort we were studying, one of the fairly almost universal things is the people who became successful physician scientists had a seminal research experience as an undergrad before they got into medical school. And, you know, I think that's something that we want to make sure to enrich. And then to build on the points that Bob already made, a critical thing for us was who you encountered as an attending. And, you know, when we were growing up, the attendings were largely physician scientists, you know. Victor was my chief resident when I was an intern. And, you know, this is what you thought, you know, you want to be when you grew up. And that's no longer the case. Nowadays, if you're a serious, well-funded, particularly laboratory-based physician scientist, the fundamental problem, in my view, is the business model of medicine right now. They don't want us on the wards. We don't know we're not as fast with EMR. We don't use the optimal billing codes, and, you know, they'd rather we're not there. And so you don't see those role models the way we used to. You know, I was Stu Orkin's second postdoc, and the way I ended up in Stu's lab was when I was a heme fellow, we had to do a month of pediatric heme, and the attending that month just happened to be Stu Orkin, you know, and I said, can I come work in your lab? And he said, okay, you know, and that was the kind of stuff that I think just doesn't happen the same. When I first started at Michigan, all my early postdocs were MD fellows, heme fellows who, you know, worked with me in the lab. You know, Kathy Cooney is the chair of medicine at Duke now. She was a fellow with me on the wards, and, you know, asked me, can I come work in your lab? I said, sure. And she said, one problem is I hate blood clotting. Is that okay? And I said, sure, you know, and she did okay. But, you know, that world has really changed. I'd also go, you know, to what Bob also talked about, the basic science education, which has really, you know, when I started out, I teach genetics to first-year medical students. We used to have a whole semester course on genetics. Well, you know, genetics is so unimportant to medicine nowadays. I'm down to 2 lectures, you know, what had been a whole course. And that's, I think, an increasing thing. Oh, you don't have to know the details of the science. So to me, I think, you know, one of the key takeaways, particularly after listening to Bob eloquently describe this, I think you know, the things that have worked were largely, we could look back to the way we used to do things, and we maybe need some more of that. And the things that don't work, I think we can look at a lot of what we do now. You know, hyper specialization, taking the basic scientists, the physician scientists off the wards and sending them, you know, they're not going to have any contact with medical students anymore. I think that changing world is a problem. And I think we ought to be looking to what can we bring back. I love Bob's idea of a public health service, you know, everyone mandatory service, you know, the practicalities of getting that passed, like the practicalities of convincing our medical centers they ought to put the physician scientists back on the ward and get students exposed to that. You know, that we should have more of a basic science curriculum. And maybe it's not for everybody. Maybe we ought to have separate paths for those who might potentially be physician scientists someday, and a separate one for the masses that we need to get out in the clinic. But, you know, clearly it's broken now. And I think thinking seriously about how we fix that, you know, from the physician scientist workforce, you know, we learned that what we used as a metric for successful physician scientist after the initial phase was R1 funding, because that was an objective piece of data we could get. And we looked at R1 funded MDs. About half were MD PhDs and half were MDs. I'm not quite sure what that is today. The other really important fact we learned was that if you looked at everyone who got an R1 funded as an MD, and the same is true of straight PhDs also, half of them are one and dones. They never get another R1. And we have to accept that. That's going to be part of the cost of doing business. You know, not everyone's going to make it, and it's a competitive business. So I think, you know, there's a lot of lessons we can learn from the past. You know, a lot of things I think we need to go back to, you know, may not be able to do it system-wide, but just some ideas.
Oh, yeah, thank you. So I want to talk about the elephant that's in the middle of the room, and I think our next panelist, Mukesh, can speak to that as a dean. And I think we served on ASCI Council together, right?
Yeah.
I'm a gastroenterologist, you're a cardiologist. The RVU, growth of the RVU and the influence of the hospital system, because that's really, I think, in the end, many times the dividing line of physician scientists going forward. Do you get clinically trained? What master do you bow to?
Yeah.
I think this will be an interesting discussion in comparison with what Ivy will have to say and what Singapore has done. So maybe you can probably set the stage for American medicine and
Yeah.
academic medicine.
Well, thanks for giving me the lob question. What I maybe just before I get to the health system part, what I would say is, David, even though the lessons of the past, I think the simple ones, seminal research experience, great role models, a sense of community for physician scientists worked then. And I would say that if there is a commitment on the part of the medical school and the health system together to build that sense of community, it is doable. It's not for every place. It's not for every individual. We have to select individuals that are going to be physician scientists and mentors and building that community very carefully. But I think the principles are still there and they're still important and they can be replicated. The health system aspect of it is, look, health systems, you know, healthcare is a really challenging industry, right? We're not the tech world. Our net operating margins on average are 1% to 2%. The investment, what you get out in that 1% to 2% often has to go back, obviously, to feed the clinical enterprise. That being said, I've been in 2 health systems now. I was a chief academic officer in Cleveland of a $5 billion health system and worked very closely with the dean there. And in my current role, serve both as dean and the chief academic officer for both our health systems. I think there's an opportunity when you have someone committed to the research and education mission at the table during board meetings and in conversations with the CEO and the leadership group, but particularly at board meetings, to be able to advocate for the importance of research in general, be it PhD scientists or for today's discussion, physician scientists. The boards of health systems and CEOs of health systems, there is a very corporate mentality, okay? And in the end, if there is no margin, there is no mission, so forget about it. You need to have that margin. But people on boards understand, even if they're in the business sector, that you have to invest in innovation of any enterprise. And that case needs to be made over and over and over again, because every 3 months, a board member will stand up and say, why are we investing in research? It's a money loser, this, that, the other thing. But there is, everybody in this room could recite the same thing, but people need to be reminded when they're not in the business like this room, that there is a downstream impact of innovation on the health system. That's why you get the best and brightest physicians and trainees that you like to brag about.
that are in the papers. That's who bring the next generation of therapies to market. There's an alternative revenue stream from those activities, and it gives you prestige. All of those things have to be repeated over and over again. There are institutions. I'm looking at Dr. Deemer, who's not too far away, and the work that's been done at UCLA. Penn has a program that is early, but really focused on basic career physician scientists with support of the clinical leadership. Vanderbilt has done a lot of work in this space as well. So when you have a shared vision, I think it is achievable. You can get health system and the leadership to see the opportunity. Let me pause there, and we can, come back to other aspects of that.
I'm going to turn to Ivy, but just so we actually start to engage the audience early, I'd like people to start moving to the microphone as Ivy gives her comments so that we can move into some of the question and answers. Ivy.
Great. Thanks so much, Juanita. And, I apologize I can't be there in person, but, I've learned so much from everything that's been shared. I'll give a little background about Singapore, and, thank you for inviting us to share. We seem like a world away, and we are. But we started on our academic medicine journey following a government task force report in 2000, where, ministers came together and they envisioned that Singapore had to develop in the area of biomedical sciences and had to be a hub. That whole train needed to be developed, including academic medicine. SingHealth is the largest public healthcare cluster in Singapore, more than 10 institutions. The flagship is the largest hospital, Singapore General Hospital. It's more than 200 years old. And we had one medical school. All of us were alumni from that school. And after more than 100 years, following this task force recommendations, they decided to bring in an American-style medical school so that we would, have a different view. The medical school in Singapore was very much British traditional. So, after visiting several schools, Duke was very wisely chosen as the partner for the National University of Singapore. And so we had our second medical school opening in 2005 after more than 100 years of just one medical school in Singapore. So that was the birth of our academic health system in SingHealth and Duke NUS. So it's really young, just adolescent, really, 15 years old. Challenges, we had loads of challenges. This was a healthcare system that had deep-seated focus on clinical service delivery, lots of challenges in the healthcare scene, as Mukesh alluded to. And we were partnering a fledgling boutique medical school. So we had to make sure that the medical school worked first. The government said develop academic medicine, but there were no obvious dedicated resources for us to do that. Well, we were fortunate because we were working with Duke, and of course, a number of people have mentioned Victor Zhao as being a wonderful mentor, and that was our blessing. He was president and CEO of Duke when we started the partnership, and I have to say that he was critical in guiding us through the very difficult first couple of years, and was truly a wonderful mentor and advisor. We wanted to first, articulate a compelling vision, and that's critical. I think that we came together and we said we could embark on this, there were many gaps in the way we deliver care. We needed to create this constant sense of constructive discontent so that we would want to venture out beyond just delivering healthcare service today. We did a massive organizational restructuring. David alluded to it that, physicians on the wards can be encouraged to see opportunities for where they should focus efforts to improve. And so we involved our talented staff. We created joint leadership teams between the school and the health system and multi-layered joint structures, academic joint structures to bring, in a way, the two sides of the coin working together. And I think Mukesh talked about that as well, the health system school partnership. You need to create that sense of community and sense of single-mindedness in the two organizations that seem somewhat divergent. So the common purpose had to be very clear. Transformation of the culture was key, with clear goals so that we could link and track academic performance measures for every institution, department, division, and link them to some incentives. And, that kind of aligned everybody in this effort. Juanita asked what doesn't work. And I would say, the difficulty is that potential physician scientists can be isolated from and marginalized by peer clinicians. And we need to very much ensure that they are recognized and valued on the ground so that it becomes a career path that others want to follow. So we took concerted efforts to identify and support each physician scientist at all the different stages of their career. We hired some strategic hires to act as mentors. We created a mentorship scheme with Duke physician scientists, and we worked towards physician scientists being welcomed, recognized, valued. We set up a center for clinician scientist development. We've had, some achievements. Our physician scientists increased from about 1% to about 10% now, and a larger group of clinician investigators, innovators. We've seen the physicians more fulfilled in their careers. There's been a marked decline in attrition of medical specialists to private practice. We've brought in we call them clinician scientists in Singapore as residents, and we have residence programs especially for them. And the National Outstanding Clinician Scientist Residence Awards have been given out in the last 9 years, and 15 have won them, of which 13 come from our AMC, of which 7 are Duke and US grads. So I would say, that's been very heartening. Maybe just one last point. Challenges obviously still remain: sustainability of funding and support. Victor in his opening said 4 decades ago, it was said that physician scientists were an endangered species, but they're still around, which is great. But I think that's key. I think that we need to continue to view physician scientists as an endangered and valued and precious species that need nurturing and careful, unwavering support and protection. And then 40 years from now, they'll not just be around, they'll be growing, they'll be doing impactful work, and medicine will be delivered. Medicine and science would have changed dramatically. Thanks.
Thank you. So we actually have a line now with some questions. So introduce yourself.
Thanks, Juanita. For those of you that I haven't met, my name is Skip Brass. I'm at the University of Pennsylvania, which has already been mentioned as a place that's trying to train physician scientists. I've had the privilege of being the director of Penn's MD PhD program for the last 27 years, which staggers me, a time during which the program has grown to be the largest MD PhD program in the country. I've been to a lot of these meetings over the years, and I served on David's physician scientist workforce panel. I'm struck by how much of the conversation stays the same over the years. Endangered species has been around as an expression for a very long period of time. What I see from my perch as a program director and somebody who works with a lot of undergraduates and post-bac students is that there's no paucity of individuals who want to grow up to be physician scientists, who dream of being successful, who understand that the mission of being a physician scientist is not only to learn how to practice the old stuff, but how to develop the new stuff and make breakthroughs. They really do get it, and they want to do it. They want to come into MD PhD programs, or they want to start medical school and then discover they really did liking the research that they did to get into medical school. And so we have a path to allow them to do that as well at Penn. The real challenge, as far as I'm concerned, is what happens to people after they graduate. All of these people graduate from medical school or MD PhD programs. We're really good at picking people that are smart enough to do that. The attrition rate is very low. It's what happens to them afterwards as they try to have a career that can sustain itself. The obvious things that we can do are the following. One is we have to shorten the career path for the training to become a career member of all of this. And everybody sitting in this room who's been around for a while can remember the age of their first R01 and compare it to the graph that you saw earlier today. So we have to get them there sooner. We have to stop thinking of additional cool things we could have them do along the way in order to be better when they eventually get that at near retirement age. And that's something we can do. And then we have to sustain them once they get there in ways that aren't happening right now. And I don't know that every institution, every medical center in the United States or around the world is going to be able to do that. But there are plenty that have made a huge investment in discovering new things that have turned out to be amazingly lucrative for the medical center where they work. So we have to reinvest those dollars back into things. We need to encourage them to keep marching forward. And we need to let them know what has not been mentioned at all here today, which is that at present in 2025, we're living in an era in the United States where there is a real turning of the back to discovery research in the United States, where the investment in doing research and therefore in helping people develop their careers is crumbling even as we watch it. So I think bottom line is we have people who want to do it. They're great, diverse, and varied people who want to do it in a lot of areas. We need to encourage them and keep them moving forward through an investment that many of us have the ability to contribute to at whatever institution we're in, and we all have the ability to vote. So please do that as well.
Great, thank you,
Thanks.
Skip. And I think this is going to be one of the points going into the panel later today, which is sustainability. We won't have time to talk about it today, but David, you wanted to make a comment?
Yeah, I just one comment, Skip. I really agree with pretty much everything you say. One thing that sort of strikes me, and I have to apologize in advance. I think I'm going to come across as much more pessimistic, and I'm usually accused of being overly optimistic. But I'm really concerned about this. And one thing that, you talk about, there's all these kids who are really interested in doing science. There's a perversion in the system, I think, in that I see. I mean, a lot of kids want to go to medical school, and they're all sort of conditioned nowadays to think that one of the boxes they have to check off on their medical school application is that they've done research. So like all of you, I'm sure, who run labs, I get, 20 emails a week from some undergraduate who amazingly has always wondered how blood clots and wanted to come to my lab, you know. I think AI is increasingly writing those emails for them. And it's because they think they have to check off this box. And, you know, the most attractive specialties for medical students nowadays, I'm sure many of you have heard of the road specialties, the road to happiness, radiology, ophthalmology, anesthesia, and dermatology. These are not the 4 specialties where you'll find the densest group of physician scientists. But they feel that's, and a disproportionate number of our MD, PhD graduates are doing those specialties. When, if you look at, I think Dr. Bhattacharya showed it in his data, the overwhelming majority of physician scientists running R1 funded labs did internal medicine, some in path, some in peds, not that many in radiology or ophthalmology or anesthesia or dermatology, yet we're sending a lot of our MD, PhDs there. So there's a lot of perverse pressures and all in the system that somehow I think we're going to have to figure out how to deal with over the years.
We'll go to our next question. Thank you, David.
Hi, I'm Andrew Zinn, and I've only survived as the MSTP director for a decade less than Skip at UT Southwestern. So I'm struck by something that David brought up at a meeting, maybe 10 years ago, about the overhead to be a physician scientist, and he focused on maintenance of certification, et cetera. But I think about this more broadly. Maybe a component of this problem is that physician scientists are high bandwidth individuals, but we have now overtaxed that bandwidth with the burden of everything on the research side, research compliance and grant writing and manuscript, the effort to publish. On the clinical side, of course, everything. I don't have to belabor here. Maybe AI is a small part of the solution on the clinical side, at least as far as note-taking and that thing, but I wonder if we are addressing this possibility that we're just, and this may relate to the slide that Jay showed about burnout, that we're taking people and putting them in an impossible environment to really succeed. They don't have time to do all the things, the networking, the other things that we say that will promote success until we can do something to relieve that burden. And maybe Dr. Jane has some thoughts about that, or other people on the panel. Thank you.
Thank you.
Yeah, I think the regulatory and certification environment has been a challenge, and so I do think there's a lot of discussion. There's been some movement in this space, but I think we could do better. I think it is the point is very well taken.
Evan Knock, UT Southwestern. I have a question for David and Mukesh. I completely agree that you mentioned the propensity for trainees on wards to align with faculty and come to the labs, and that certainly happened. I do neuro-oncology clinic 1 day a week, and I have 2 neurology interns writing papers with me right now that came from that experience. The problem is when early career investigators are recruited to institutions, you're expressly disincentivized to take on additional clinical duties because, of course, that eats into your K award 75%. And often, if you're doing 1 day of clinic, let's say, you're almost at that percentage anyway. So my question really is to Mukesh, as dean, when you're writing an LOI, how would you alter an LOI for an early career recruit to incentivize them to do some more teaching time to recruit people, engage the physician scientist community, while not disincentivizing them against their, let's say, 75% K award protected research time?
Well, I think when you recruit someone, you recruit and you support them very vigorously. But we try not to recruit an enormous number of individuals that we can't support or support them in a suboptimal manner. And so if you support them both from a salary perspective as well as support for their lab, it gives them the opportunity to do other things that they don't have to spend as much time, writing grants and worrying about all of that, and are able to support their other activities. To me, that's one of the only ways that I can think of where you recruit less, but you support people very vigorously.
Right. Yeah, but I think there has to be like a financial actual amount that's attached to that commitment. Otherwise, the 25% time may just be spent doing whatever their clinical duty they're doing and actually not contributing to the community building.
Yeah. So while it's hard to pay a 80-20 the same as a cardiologist as the 100% clinician, we use an amalgamated rate where it gives you a competitive salary, but you're still not going to be making the salary that 100% physician, a clinician makes. And I think that's, personally, I think that's reasonable because the reward structure for what we do as a physician scientist is different than a pure clinician.
We can talk about that offline too. Okay, next question.
Vivian Chung from Brown. I want to push back a bit on the fact that training medical students has less impact. As Bob and Mukesh have mentioned, we formed a physician scientist support foundation. And now with ASCI, we run a program supporting medical students. And we picked students very carefully. Most of them are students who never had any research experience. And that was one point that was pushed very hard by Brian Kobilko. And when we got the application, it was kind of very enlightening. So who are these people? Those are students who almost like had to work during undergraduate years. By chance, they are able to get into medical schools, right? And they just did not have those research opportunity. And we surround them with mentoring. We pick the mentor very carefully. Every student have a sponsor. And now, even though we have only a few classes, all of them are planning to stay as physician scientists. They're looking for research opportunity during residency. They talk to us about how to do this. So I'm just urging us not to give up on the medical students program. I know maybe, Doris Duke had a bad experience, but overall, I think that is still a very good way to get MD only physician scientists.
We didn't have a bad experience. We were proud of every person, but we wanted to act like scientists. The goal was to increase physician scientists. We didn't, it could have been design issues. So it's great to hear that you guys have taken a design approach that's paying off.
So I think we'll have a chance later to really talk about how do we think about impact, right? I don't know if we're going to change the number of physician scientists, but each individual, I am sure, we change their lives.
Great, we're going to keep moving because we're right up on we just have 30 minutes for lunch, so we're at about 11:30.
I just wanted to bring up one idea that really I don't think I've heard or has been explored. So we have a great community here looking around the room of physician scientists around the country. But when we think about developing physician scientists, we think about it at an institutional only lens. Can we start thinking about trans-institutional mentorship and development of physician scientists rather than an institution-based? Because we have limited margins at each institution. There might be niches for some at some places and not others to develop them better. But if we have mentorship across institutions, so any thoughts, particularly with some of the foundations and their funding mechanisms, to talk about development of trans-institutional mechanisms for development?
I would just, since the question was directed to foundations, maybe I just thought I'd make a general observation related to your question that's unencumbered as I am by any expertise. A physician's, the endangered species language is really interesting. We do a lot of work in conservation as well. So I know something about endangered species. The argument for preserving an endangered species is that the species is an end in itself, that the existence of an endemic species is valuable. Physician scientists aren't ends in themselves. It's a modality of research that's correlated to incredible breakthroughs over a period of about 50 to 60 years and unlocked the potential of the Vannevar var Bush insight in biomedicine and health. So I think, to your question, I'd say yes, and think even more systemically. What is the kind of research that needs to be done? What is the talent that will enable that research? How do we enable that talent to flourish? Some of it will look very much the same as what the innovations that the Yellow Berets came up with, but I'm guessing that some of it might look different than the institutional pathways and containers that we're used to, if it's going to continue to be valuable to society.
Hi, I'm Matt Seligman. I'm at UCLA and the VA Greater Los Angeles, and so I really need to preface my remarks. I'm speaking for me. I do not represent the U.S. government. I do not represent the Department of Veterans Affairs, which will be important for my comments. One, briefly, Dr. Ginsburg, to your point about physician scientists not being just wanted on the wards. There are a few people I could disappoint in leadership by not doing more clinical work. I think that the problem really is the pressure to do clinical work, and the reason why I don't do more clinical work is because otherwise I can't sustain my research career. Dr. Jane, Dr. Ginsberg, you're both at institutions that are affiliated with VAs. And the reason why I want to bring that up is that when I think of a place that has actually built very successful, sustainable careers for physician scientists, it really is the VA. I've had the pleasure of working at three, or training at three. I now work at one of them. Leadership at all of them has included physician scientists throughout. And it really creates this very clear path, whether you're a basic scientist or a more health services oriented scientist, to sustain your career and ultimately help sustain the careers of others. And I'm wondering how you've encountered that model in your careers.
I think that's a great point. And one of the things I'd say is that my sense, and I'm not directly familiar with the VA, is it's much less RVU driven. And you know, they're not counting the chips quite the same way they are across the street in the academic medical center, where somebody like me who's only there for, used to be for, you know, a month, a year, a half day a week, it's not worth it, you know, because I don't code quickly enough and I don't do that. And in the VA is a little bit above all that. So I think maybe if we had the VA model for our whole healthcare system, that might really work. But I think right now the VA is a great model, I think, for a place that we could maybe learn from.
Yeah, I would just echo throughout my career, I've spent a lot of time at the VA. I still attend at the VA, but it's a great training ground. You have obviously a couple of additional shots on goal for funding. And often the metrics, the pressures on the clinical environment, RVUs is a little different. So great point, and thank you for bringing it up.
Hi, Manasi Shah from Eastern Virginia Medical School. My question kind of echoes over the last two questions and discussions. I was introduced to research much later, basic science research much later after I came from India from medical school, worked at Albert Einstein, and then trained in endocrinology at UT Southwestern. I had excellent training, but because of immigration, I had to go to Eastern Virginia Medical School for underserved and was asked to do 100% clinical for 3 years, which I'm sure you all are aware of. Going back to research world, despite all the big names and big trainings, was difficult. What actually helped, I tried to get into all the big schools again last year, but it was difficult to get protected time for research. What helped was the healthcare system, the health hospital system actually invested in me and gave me a 3-year, almost like a KL-12 for next 3 years. Because I think they see that potential for innovation and keeping people, you know, within the system, not letting them leave. And they have created whatever they could scrap from all the mentors in the institute, which is not a prolific research institute, a sort of a program that they're training 2 people every year with time, mentorship, everything. And I think this is really, really important that we think systematically, because now I struggle, I have time, but now I struggle with resources. Where do we don't have a metabolomic score or, you know, a genomic score. Where do how much do I go back to my old mentors and try to find mentors to write an NIH award next? So I think we really need to, we found it difficult to find mentors who want to do trans-institutional mentoring. And, you know, I got Burroughs Wellcome Fund at UT Southwestern, which is institutional. Maybe the foundation could help people like us who don't have the big institution and names, but still are very passionate about research. And I think it's really important we think of these kind of trans institutions. Just wanted to comment on that. Thank you.
Jose Cavazos, UT Health San Antonio. I was part of a task force in 2016 trying to get the implementation of the physician scientist report by at NIH. Several of us were there. We had at the table all of the LCME, ACGME, and everybody else, AMA, AAMC, et cetera. You know, one of the recommendations that came about is the problem in residencies to have research residencies for every single specialty. And unfortunately, while everybody agreed in the table, it just didn't happen. And so perhaps this is the time for the National Academy, as we suggested a couple of years ago, to come up with some pressure for our accreditors across the board to try to infuse more science into medical school, residency, and junior faculty.
Great question. I'm going to kick this back to maybe Mukesh, because what I see is that downward pressure from the hospital because of the RVU targets to, and be as fast as possible. I mean, what, field do you have the data collecting person also be the data entry person? I mean, that's one of the things that slows us down as physicians, and creating enough time to be able to do some of these things and to stop and think critically about the patients that we're seeing. I think that's one way of looking at it. David, you may also want to comment about kind of the reverse, where PhDs actually are kind of rotating with us to learn more about how to translate. So there's sort of both ways to think about it.
I go. I'm trying to crystallize the question, Juanita.
So the question is basically creating that time to bring back the basic science, kind of even back to Bob's, point, having, when we were rotating on the wards, the attending would basically bring all of that basic science to bear on the patient. Now there's that pressure. We don't have time to do that, right? And we are training our residents that they're not really interested.
So I don't know how many institutions do this, but in certainly my prior institution, and we're starting to implement it now at Brown, is having the physician scientists be a complement, a co-attending with a full-time clinician. That gets around a couple of things. It gives young people the opportunity, what David said, he met his mentors on the wards. This is a way to complement the clinical with teaching rounds, essentially, with a physician scientist. That's I think one way to sort of enhance or invigorate the pipeline.
They actually experiment with that a little bit at Michigan, and I did that for a while. And frankly, I'm not sure it really worked. The problem is there's work to get done, there's business to get done, and the physician scientist who was tailing along to do some teaching, the residents want to get out of there. The attending wants to get his note written and make sure he's got the right billing codes, and after a while they just dropped it.
Yeah,
because
so
there wasn't enough interest.
It was a little different, Dave. It sounds like you went around with the team. Yeah, this would be separate. So you have your work rounds, but once or twice a week, you would meet with the physician scientist and you would discuss a singular case that would be picked and really do a deep dive into that, which is more manageable for the David Ginsburg who comes out of the lab to do it, and it doesn't slow down rounds in most days.
Yeah, I mean, I'd certainly be open to giving it a try, but I'd be pessimistic about the chances. Keeping the house, the house staff there got work hour restrictions, and they're sitting there watching. They want to get home, and you're going to sit there and hear about DNA and splicing, and get me out of here.
It does seem to me that what everyone seems to be describing is that a relationship that what is supposed to be a symbiotic relationship between a financing mechanism and a research mechanism for pedagogy on paper is not in reality. And that probably has to do with the fact that the financial realities have changed for the financing. I mean, I think it's very interesting that the example that got held up is the public payer. That's what works. The person who doesn't need to get a rent. And the person who does need to get a rent is killing it if they get 2% net. So, it's going to be hard to square the circle on that math over the short term, much less the long term.
Okay, I was told we could go a little bit longer. So if people have any additional questions, yes, go ahead.
If there's a couple of minutes, I just want to come back to an important comment that was made regarding the reinvest.
Introduce yourself too.
I'm sorry, I'll be there in a second. I wanted to go back to a comment that was made about reinvesting successful commercialized technologies back into training. I'm Ruben Flores. I'm with Ligan in San Diego. I'm very excited to be here. Right now, I'm in the business of funding in the order of $150 to $200 million late stage registrational therapeutic programs. But I spent 11 years as an administrator, vice president, and director at technology transfer offices at LA Biomed, UC San Diego, and USC, where I help many research scientists successfully navigate and get their technologies to the marketplace. Emil Kakis at LA Biomed, who invented Aldurazyme, Ranjan Dohil, who invented a treatment for cystinosis at UCSD. We can talk about that later, but there are mechanisms, right, that are very well established at each institution that lay out how those monies that are received should be allocated. And I think longer vision, establishing longer vision programs that can help provide funding for this kind of training would be something that perhaps you should look into and advocate on a long-term basis, and happy to talk about that later.
Somebody want to make a comment on?
Just one quick comment on that. I think it's funding basic research. The problem is very early. Are you going to the industry biotech support is great for later stage stuff, but how are we going to do the fundamental basic science discoveries that whose clear translational application isn't quite evident at the beginning? That's a hard part.
Yeah, one way around it a little bit is if you have a partnership where the private partner has a right of first refusal on technology comes through. Just one approach. I'll also just want to comment that we were very fortunate in establishing PSSF to receive support for training for medical students. That was from Amgen, and then it was a number of other organizations, including Burroughs Wellcome, matched it. So there are ways, and I think the biotech and pharma industry obviously has a real vested interest in the success of physician scientists, given that so many leaders in that space are part of the eventually go into the industry sector.
Go ahead.
Thank you. Linda Deemer at UCLA. I've been very interested in the idea of shortening the pathway. I think that's a really important issue. And with the question I'd like to get some opinions on is how much time is the right amount of time to be doing research during medical school? And are we contributing to burnout if that amount of time we're using is too long? And should we front load or back load the research during this pathway?
I'm actually going to stick in a little point that because I have an MD PhD student in my lab now, and he's complaining about having to do all of these shadowing rotations, and that's taking him away from the lab. And I'm thinking to myself, you could finish faster if you didn't have all of those shadowing experiences. You can come and watch me do endoscopy, but you don't need to spend the extra time, because in the end, you really are not going to learn medicine until you are an intern and resident. And I think my opinion is that, and that's kind of the old school of doing it, where maybe you take the time on your own to do the shadowing, but he was saying there's just too much formal going on the wards, and in the end, you don't really remember it until you actually have to use it. So that's one way to shorten it.
I was just going to make two comments. One is on the issue, Linda, of shortening. One is a large part of the world does not do 4 years of college and 4 years of medical school. So I was thinking about this, Skip, when you spoke about the time. I just didn't get a chance because we went on to the next question. So I'm glad this came up. It's just something we as a community, as a society should think about. That's one. The other is the MD only track. So Bob is a wonderful example, and all the founders of PSSF came into science late. So it might be there's a issue of duration and the intensity and the quality of that experience, but it may be that you don't have to do the MD PhD, but it's once you know what you're interested in, you're a little bit more mature, you've gone through training, and you can focus for 2-3 years, and that is often enough for a motivated individual to kickstart their career, and you come out a little bit younger on the other side.
Something that, might be valuable well, first of all, Mark Zuckerberg still hasn't reached the median age of your first R1. So I mean, you just can't have labor mobility like that in the 21st century and attract and excite the best people of an emerging generation who think by the time you're 22, your career you should have, already be a billionaire or whatever. But I think that something that might be valuable from other industries, again, you all are the experts in what you need to know to be able to do the work. Most other industries, the conversation about training is that there is going to be an overlap between when you can begin to produce economic value and what you need to learn over the course of that career in order to have long-term value. Some of that has to do with the way in which the four-year college degree is just less and less appealing to a significant portion of the population, to some extent aided and exacerbated by the lack of fit between a four-year degree and the labor market in certain sectors. And a lot of that has to do with technology in other sectors. And I think the reality that most employers think they face, which is that what you'll need to know when you come in is not going to be the same thing that you'll need to know 5 years after you come in or 10 years after you come in order to be successful. So again, that's where the conversation is in other industries. And so there may be some insights there to think about. To your point, is there an overlap between what you need to know to start being useful to the system and what you will ultimately need to know to be the apotheosis of the physician scientist?
Okay, Chris.
Yep.
Thank you.
Chris Williams from Vanderbilt. I direct our MSTP, R38, and Associate Director of Research Education at our Cancer Center. First off, I'd say hats off to Evan and Jennifer for organizing this wonderful event, and the National Academy of Medicine for hosting this robust discussion. I think one major crux for retaining physician scientists in this career path is this issue of it's taking too long to train physician scientists. When they're approaching their should I stay or should I go point, which often is at the fellow to faculty or resident to faculty transition, they're much older. Being much older means you have much more things going on in your life. Being married, having kids, those things all cost a lot of money. And so they're entering their faculty stage thinking, am I going to have a very low salary or do I bail and go into private practice? One of the problems with shortening the time that it takes to train is licensing. So the LCME is very rigid about making sure all physicians are trained identically, even if they're a little bit different in what their careers look like as an academic medicine physician scientist. And then on the other side, at residency, there's also a fair amount of rigidity. So it's time-based training. They have to have a certain number of weeks in each sort of clinical activity, regardless of whether or not they achieve those educational goals in a much shorter time frame. So I do agree, I think, with what Jose had mentioned, that if this group could figure out a way to get the licensing boards to think more creatively, that might be a way to shorten time to degree. Just want to emphasize one other thing that hasn't been mentioned is that's the value of community. And it's so important that our trainees have the opportunity to peer and near-peer mentor. And that's why our pre-doctoral trainees need to be hanging out with our residents and fellows that are in physician scientist career paths, and our residents and fellows should be hanging out with the junior faculty who are physician scientists as well. Thanks.
Great, thank you.
I would echo all of the things we just said. Keith Choate from Yale. I happen to be a chair of a department of dermatology. We have 8 extramural K awards, and 3 who are making a K to R1 transition. So I only mention that because I think it's very important for us to really draw a fine point on the importance of physician scientist training programs in residency and fellowship as a real engine of producing new investigators. And I think that that's really the critical moment at which we really need to intervene. Have all of these exceptionally talented individuals coming out of medical school and out of MD, PhD training programs, but we don't always catch them when they come out of the gate. And I think that if we don't have effective ways to catch them when they come out of the gate, creative ways to fund them, creative ways to shorten their time to independence, it really is about having a model for success rather than a model for failure. And I think that the way that we've been successful in our programs has been having realistic expectations about compensation, which are not as high as their clinical peers. They've been about having role models within departments, about embedding physician scientists in basic science laboratories, keeping them in place well through their early development into the phase of obtaining an R01, and really creating a community of investigators to provide support in those low moments.
Thank you. Last comment, and then we have lunch. The caterers needed some time to set up, so this is perfect.
I'm even more of a black sheep. So my name is Jack. I am one of the dots who left. I would love to echo a few things. So one is I would love for this group to think broader about what the definition of impact is. I think there are many of us who still do research in private industry. I think there are quite a lot of comments about the importance of mentorship. I don't know if this embarrasses Vivian. I was partially trained by Vivian. So I ended up doing administration and starting companies. But there is a significant amount of mudfuts who are doing science as well as research in industry. And it seems like that is almost completely written off in some of the conversations here. The other is, I would say, I know very little about basic science. Almost all of my previous work was in translational and computational sciences. And I think the time it takes to train mudfuts and the amount of resources we give them is very disproportionate right now compared to what industry does. I spent 10 years at Google, starting Google AI and Google Health. And I spent probably 3 years at Columbia just trying to get access to data, like literally IRB on IRB and IRB, getting like 100 radiology reports. That was my thesis. And like, I go to industry, I have unlimited compute power, like they buy literally entire health systems worth of data. Like it's very hard, frankly, to say that even the level of science is equal when you have teams of engineers working over there. We're willing to pay mudfuts like coming out of school, 300 to 500K. Like I think asking young people to frankly make that sacrifice is very, very disproportionate, both in the just to get the training done and then to frankly take a salary hit compared to clinicians and then compared to industry. So I would love for this group to try to think about like how to make that more equitable, and to think about what to do with a group of clinicians who are doing real work and making a lot of impact outside of staying as a faculty.
I just want to comment because you said much better what I was trying to say earlier. So the real question is, what sort of insights happened in that blueprint you gave that shows laboratories around the clock? What kind of knowledge was uniquely gained there? Why is that valuable? How does that happen today? But second, is there a value to that happening in an independent research setting called a university? Because by the way, that's the thing under attack today. The independent research setting called a university. So I thank you I think this is a great note as someone who's an outsider. These are really important questions that many of your supporters don't have a clear answer to.
Okay. Quick comment. Yeah, Jack is a very accomplished physician scientist who straddles like biomedical research, industry. He went to Google Brain, as he said, but he also did a startup called Ansible Health as well. He was the advisor on OSTP as a MD PhD student. Yeah.
We're not going to take the online now. No. Well, I think they're waiting for us to send. Okay, all right. I'd like to thank the panelists and the audience for such a robust discussion. And those Lou and Ivy online, thank you so much for your participation. Lunchtime. Okay.
Thank you.
the panel assembled up here, so I think if we can go ahead and conclude lunch. Feel free to bring your snacks back into the room if you need to. All right, I think I'm going to turn it over to Joe Wu to kick off our next panel and get us going. Thank you all so much.
Okay, we're going to get started. So please take your seat. And so I'm Joe Wu. I'm at Stanford University, and I'm the moderator for the session. And we'll have an exciting session coming up, following up on this morning's session. And so I'm going to just start off by asking some, what I would say, easy questions. And then toward the end, then we'll ask tough questions. And then afterwards, we'll have the panel discussion. So I'll start first, turning to my right, asking Elena, and I kind of prepare a few questions. So Elena, the definition of a physician scientist is shifting as digital health, AI, entrepreneurship, and new team science models transform medicine and research. So from your perspective, how is the role of a physician scientist evolving? And what are 2 or 3 priorities that are most urgent for sustaining their impact in the next decade? Yeah, go ahead. Yeah, go ahead.
Thank you, Dr. Wu, for the invitation. Thank you, Jennifer, for inviting me, and Victor, of course, for sponsorship. I represent the Association of American Medical Colleges, and I will answer the question, but I was also asked to give some background context for our discussion about this topic. And much of what I will share has been raised by some other presenters and commenters, but I'll try to put it into some context. As we've discussed many times, the concern about the viability and sustainability of the physician-scientist workforce has been a topic of conversation for decades. And Dr. Ginsburg noted the prevalence of research among medical students. And in our most recent questionnaire of graduating medical students, this is 17,000 students who completed the 2025 survey, almost 80% of which represents 80% of graduating medical students. 90% of them reported that they had undertaken a research project with the faculty member during medical school. When we asked them about their plans for the future, about half report that they plan to participate in research during their career. And among those who do plan to participate in research, slightly more than half plan to be involved in a limited way, and a small proportion, 3%, plan to focus exclusively on research. So that's the perspective from the 2025 class of medical students. As we know, however, by the time they complete their training and become faculty members, their portfolio of work has changed quite a bit. In a 2021 survey, there are about 200,000 faculty at medical schools. 2/3 of them are MD, 7% are MD PhD. And according to the AMA, in 2020, 1.3% of US physicians reported research as a major activity. And in a sample of AAMC data matched with NIH data of 14,000 faculty, 14,000 faculty representing 7% were PIs on NIH R01 awards. That population of NIH-funded investigators was 60% PhDs, 24% with MD, and 16% MD PhD. Last year, one of my colleagues, Dr. Alyssa Brown, published a study in JAMA Network Open about physicians who are engaged in research. Most studies focus on MD PhDs or other definitions of research, but we know that research-engaged faculty represent a minority. And in this 2022 survey of physicians, 14% reported being engaged in research, and 4% reported that they spent more than half their time on research. So this has been a longstanding concern and has been highlighted. The NIH Directors Advisory Committee created the working group and recommendations, as we have said already, sustained support for MD PhD programs, innovations to modify or shorten the training period, and expansion of loan repayments. So at the AAMC, our top priorities in this area are ensuring stability in the biomedical research enterprise, including funding for research and support for training, and we are actively engaged in all those topics. We believe we must broaden our conceptualization of researchers, including the terminology that we use for them. We often talk about physician scientists. We may have different definitions of what that term means. We talk now about research engaged physicians, which recognizes that people can come to that from multiple training perspectives and that it may change over time, but that it represents their commitment and training. And finally, we believe that institutions must increase their efforts in fostering the career development of research engaged physicians and creating mechanisms that promote interdisciplinary collaboration. These might include mentorship programs, as was eloquently demonstrated by Dr. Lefkowitz, and networking communities, which support those who are at similar career stages. I'm sorry, Joe, could you repeat the question because now
That's completely fine. Yeah. So this is good. So I was going to ask you, the physician scientist is shifting in terms of digital AI entrepreneurship, startups, and so forth. From your perspective, how is the role of physician scientists evolving? And what are 2 or 3 priorities that are most urgent for sustaining the impact in the next decade?
we recognize at the AAMC that the world is changing, the priorities are changing, and the type of research and scholarship that people engage in is also changing. Like everyone, we are focusing on AI and the impact of that, so that's undoubtedly one impact. But we still believe, as I mentioned, our priorities are ensuring the stability of the workforce, ensuring that faculty members are supported by their institutions, by national organizations. And so that would be the same whether someone is working in digital health and entrepreneurship. I think it's on us to redefine our expectations and our support. But to me, these are timeless principles that will continue to apply.
Thank you so much. So my second question is to Rob. Rob, you've moved between academia, federal leadership, and industry. Do you think the evolving role of physician scientists now requires embracing such cross-sector pathways as part of their identity? And if so, how should we prepare the next generation for that reality?
Well, Joe, I think you've heard me say this before, but I want to object to your premise from the start. The idea that people that make medical products are an industry and that the healthcare delivery system is not an industry is the craziest thing I've ever heard of. The medical products industry is a tiny fraction of both the money and the power of the healthcare delivery system entity that most people in this room work for. It's an industry. So let's stop calling it industry versus, I don't know what else it is. So I barely recognize the description that's gone on for most of today of what the world is like. We live in a sea of information that's available to everyone, including people who quote are researchers and people who are not researchers. And to me, what we're missing for the most part is a quest for learning, which is what Lefkowitz really well described. It was in a particular setting of working in a laboratory, but I think the same thing holds just as much for what do you do with a patient with an elevated lipoprotein (a), or how do you best provide mental health services? And what I'm seeing is the industry that delivers healthcare increasingly doesn't want anything to do with learning, and it's making it very hard to do so as a matter of strategy. And so, yes, I think we need a cross-sectoral focus on learning. And I think the primary problem that we're dealing with is a combination of financialization. I keep hearing about these razor-thin margins, but if you look at the aggregate financial wealth of our major biomedical healthcare delivery institutions that house medical schools, it's enormous. It's just that most of the money is being made through investments of endowments and other things, and the margin on operations is small, but the total aggregate money is huge, and it's not being applied in a way which gives adequate due to learning and research as a component of the system. So, I would hope that we can move towards a learning health system. Remember that term? The theory is highly advanced. And I think we really need to stand up for that as a way of doing it. Now, some of that is protecting people who need to work in a laboratory because you need that. A lot of it is just saying, if you're practicing medicine or nursing or pharmacy, not to insult anyone, but I would argue the average Walmart clerk is doing more research than the average doctor today. Everything that goes through Walmart is barcoded, it's measured, goes in a data warehouse, it's analyzed, it's fed back for the purpose they have. What's happening in medicine is doctors don't even know what's happening to their data. It's going into systems which are almost totally dedicated to optimizing the finances of the corporation they work for, the health system. And so that's what I think. We have to create a system which views this whole enterprise differently. And I'll stick with my Humpty Dumpty analogy. Jay didn't acknowledge it, but right now, the current system that you all are talking about is being taken down. And maybe it could be rebuilt in a cross-sectoral way where we'd all be dedicated to learning for better patient outcomes. Hard to argue what we're doing in the US today is very good. It's the worst of all high-income countries in terms of health outcomes. Maybe that was enough to post in it.
So I'm going to move on to Anna. So Anna, you've helped advance mission-driven science through philanthropic initiatives and also impact funds that blend private and philanthropic resources. How should physician scientists operate within these ecosystems? And maybe as a follow-up question, given your role at the ASCI, ASCI is evolving in its support and recognition of physician scientists who are engaged in translational innovation, entrepreneurship, and institutional leadership. What is the ASCI's role in this as well?
Thank you, Joe, and thank you, Victor, for having us today. Yes, maybe I can speak from these two perspectives. So the first thing is to speak as a representative of the Broad Institute. For those of you who may not know, we're an independent research institute that was formed from a collaboration between Harvard and MIT. So half of us are Harvard faculty, like myself, and half of us are MIT faculty, and our appointments come from those institutions. But the Broad is not a hospital and it's not a school. Our only business is research. It's a community of about 4,000 scientists and staff. And I have a role on the executive leadership team, so I'm speaking a little bit from that perspective as well as from the perspective as a faculty member. And so it is true that we have, over the last 20 years, the Broad turned 20 last year, we have sort of spearheaded a different way of thinking about how to do biomedical research, which could be a useful model in this setting. And it does center around philanthropy, although I think one thing that people may not recognize is that if you look at our about $600 million annual budget, about a third is federal, a third and a little more than a third is probably philanthropy, and the rest is industry. So we have a flexible, sort of diversified model for funding our research. And what I can say from my own perspective, especially in this climate that we're all discussing, I would say maybe because we have the track record, but I have personally been impressed with our relative success with philanthropy this year, especially because I think that there are many fellow Americans who have capacity who recognize that this is a time for them to step up. And so I think that maybe this is an opportunity, and I will come back to it in my role as ASCI immediate past president and how I think we can harness that as well. So I think, philanthropy has a role to play, and the way that we've utilized it at the Broad is actually the highest risk moment is when you're seeding a new idea, a little bit like what Dr. Bhattacharya was talking about. And that's the time when, traditionally the NIH has not been, I think he's right about that, has not been very willing to take those risks, right? Industry certainly is not built to take those risks. And so philanthropy is uniquely positioned to really seed those early, most innovative ideas. And, over the last 20 years, certainly, the Broad is known for CRISPR, for the Human Genome Project. We've built a lot of new initiatives, including the one that I'm now spearheading, which is sort of a comprehensive approach to genetic diseases with a view to mechanisms and ultimately therapies. And so, the idea is that all these things sound very high risk when they first begin, and philanthropy can see them, but then ultimately you can seek federal support or industry support as you continue down the sort of the path, if you will, to translating the discoveries into benefit for patients. And so I wonder if the physician scientist ecosystem could benefit from a similar approach. And so now I will switch, to keep my comments brief, to my role as just immediate past president of the ASCI. I've been now on council for 7 years, and so I immediately recognize, and there are many of my colleagues here, by the way, from council, as well as our executive director, John Hawley. So all of my colleagues at the ACI, we all recognized several years ago, at least when I joined council, that there's a need, the membership, I mean, by definition, these are our colleagues, many of you here, who are very successful, right? And so the concern was about the leakiness of the pipeline at the step before you're actually an independent investigator and then eligible for AACI membership. And so we really wanted to think about how we develop programs for that earlier part of the pipeline, retention programs. And over the last 6 years or so, we have been quite successful with some of our early career programs where we bring people who are at that late postdoctoral before independence stage where there's a lot of attrition. We bring them to the meeting and they can participate and form a class. We give them training around how to write a grant, how to write a paper, how to run a lab, how to be a manager, and then we also have a program for the K08 awardees who are a little bit farther along, but still not at the R01 stage. And we do the same thing. We create a buddy system. So these emerging generation awards and young physician scientist awards are part of this program that has now been reviewed over the last 6 years and appears to be successful in terms of retaining colleagues. And one of the ways in which we measure success is conversion into AACI membership, And so that's something that we've been very happy with. Again, the programs are pretty new. But in my presidential address this past April, I announced the AACI Impact Fund. And so this is an idea to raise, we're aiming to raise $18 million over the next few years to endow these programs in perpetuity. And actually, our commitment now extends to the post-bac program, which is, for students who choose medicine as a path a little bit later in their college careers, and so going to the post-bac program. So we have that. And then we also have partnered with the Physician Scientist Support Foundation to now make that part of our sort of trajectory as well. And so we're looking to endow all these programs and ultimately grow them. And I do think, to bring it back to the question we began with, philanthropy can be an exceptional tool for, building something that can really help. I do think that the for-profit industry, if you will, as a way to distinguish between our industry and the pharmaceutical industry.
Go to the board meetings, you can't tell a difference.
I would agree. That's probably true. Fair point. I agree. But nevertheless, our colleagues in the biopharmaceutical industry, many of whom are my friends and colleagues, people I grew up with and in medicine and science, and I deeply respect them, of course. They're all stakeholders in the training programs for physician scientists. And so it's not ready to be announced yet. John would kill me if I would say it in public, but I think we do have one partnership with an industry partner for this impact fund for the ACI. And we hope that that can become the need is for additional partnerships, because we do think that our colleagues in the biopharmaceutical industry should be co-owners. So philanthropy and industry as alternate strategies for funding support systems for physician scientists is where I would like to see us do more and more. Thank you.
Thank you so much, Anna. So Ken, your work has helped define how digital ecosystems can support research and care. As AI and interoperable platforms expand, how do you see the definition of a physician scientist shifting? Are they still primarily clinicians who do research, or becoming data scientists in their own right?
Well, it's been a long time since I had to wait till 1 p.m. in a day before I heard the word artificial intelligence. So I'll kind of bring a little of that in here. So, and speaking of Stanford, Dr. Wu, so what I've been hearing is that if you're going to go into a hot AI startup right now, you need to find someone who had an MD, never practiced, got a Stanford computer science degree, and now is going to make 7 figures. And that is the absolute currency in the sort of VC funded startup world, is one of those. And there's a limited number. but that's what the VCs are looking for. And also, one thing that I think is important to recognize in a meeting like this is that we're looking at DeepMind coming up with AI co-scientists, and these things are pretty good, and AI is winning the Nobel Prize in science, and the role of the scientist is going to be evolving in ways that we don't fully understand. It's more discussed, I think, on what's going to happen to doctors, but the scientific role is going to change as well. And so we don't fully know the future skills that are needed. So I think, at this meeting, I think all ideas in the breakouts, I think all ideas should be on the table. And so to talk about like this, to get at your questions, like who are these people who can sort of traverse these worlds? If you go back to the Belmont report, which was from the after Tuskegee and some other very bad things, we had this sharp divide between what is research and what is clinical. And it wasn't only the Belmont report that was responsible for that divide, but I think it nonetheless made it really sharp in terms of how we define these things. And now we recognize that research and clinical, particularly in this field of like, how does AI enter medicine? How does precision medicine happen? Is really, it's a critical moment that's going to really require the best scientists. And if you look at who's going to be delivering healthcare in the future, an AI-trained PhD without an MD, or with an MD, but also without an MD, who gets to know a clinical domain. And I'll tell you, they can do this. They can read the textbooks also, and they can read the articles, and they can get to know a clinical domain. They may be delivering more care than the physicians. And so people like me went into more like population health and large scale data because we wanted to do more than just the one patient at a time that, for example, I was experiencing as a pediatric emergency physician. I loved it, but I wanted to have a bigger impact. Now, if you're a clinically trained AI PhD researcher, you can have a big impact by having something that gets diffused throughout the entire healthcare system very quickly. And if you think about what happens in precision medicine in a big academic and medical center, what I've observed, and people may disagree, but what happens is you get a patient who becomes interesting to somebody. And that somebody has a lab, and that somebody grabs some chunk of that patient and brings it to the lab and slices it up, and then even interacts with the family and presents potentially a diagnosis or even a treatment. But it's extremely inequitably distributed and kind of randomly distributed. And if we want to make precision care and AI-enabled care into a standard and really train a group of physician scientists who can do this, we have to blur back together those distinctions. And I'll just say that it really takes a multifactorial approach. The funders have to be willing to fund this kind of work. The regulators have to help us not separate them so much, and the relationship to industry. Let's take pharma as an industry, and now we've got the huge frontier model AI companies as an industry. There are things that we might like about the way medicine developed a relationship with pharma. There may be lessons learned, and we can begin to apply those and then figure out how our researchers come in. Researchers used to study the drugs that were made by pharma or make the drugs and license them to pharma. There are going to be similar cycles in AI that I think we have an opportunity with that, decades-long history with pharma to think about how that shows up in AI.
Thank you so much, Ken. And then last question goes to John. John, surgeon scientists face a unique demands on their time and funding As definitions of physician scientists expand to include leadership in innovation and translational ecosystems, how should institutions and funders adapt expectations of productivity and success?
So I'm going to talk a little bit about surgeons and money, but I also want to take the opportunity to talk about some fundamental constructs that I think are just broken, or constraints, I might say. And then I might be bold enough to put forth sort of a naive recommendation. I do note that there is a paucity of surgeons in the room, so maybe I shouldn't say this, but I actually don't think surgeons are disadvantaged in this context at all. In fact, I think there's a lot of opportunities for surgeons in this context. First, while there's been much said about the impetus to focus on clinical productivity, surgeons have an advantage there. They tend to be profitable on the professional side, but they also are generally highly profitable for hospitals. And so there are unique opportunities actually for surgeons to cross-subsidize their other mission work. In addition, they have a great opportunity to leverage grateful patients for philanthropy, to take on some of these unique and new ideas that we've talked about a little bit. I will say that one disadvantage maybe they do have is that the paths they take tend to even be longer in many cases, particularly in neurosurgery in my case, than other areas. And I frankly think that's just nuts. I think we have a construct, or we have a situation where mostly these are mandated by accreditation agencies. And the idea that someone would do 4 years of medical school, which by the way was a concept that was initiated in the 1500s. We're talking about AI, and yet we're accepting a construct that was initiated in the 1500s, that they come out of medical school with debt that's about $250,000 that they probably won't be able to pay off in any reasonable amount of time, is absolutely nuts. And surgical residencies, the length that they are, just add to that. And I just fail to understand why we don't have a much more clear-cut, merit-based approach. In any industry, Rob, to your point, this is an industry, right? In any industry, we would educate and we would have a merit-based approach. And there's really not much of that being done. The other fundamental constructs that I think, or constraints that I think we have, which are beyond surgeons, but I think do impact negatively all of the physician scientists, are these concepts of over-the-cap, and now the fairly ubiquitous approach of funds flow, right? For the past several decades, hospitals have been more profitable than physician practices. And so this has generated this move towards employment. And when we do that, we have this idea that because you have a PhD or you do research behind your name, that your salary or your reward should be somehow a blend between those two specialties. And I think that's just crazy, right? Who here would just take a 20% pay cut or a 30% pay cut? It just doesn't make any sense to me. Now, not all of the rewards that we get in as physician scientists are compensation, but it certainly is a part of it. Now, CU may be unique from a financial perspective, but to Rob's point and others, while there are continuous and repetitive threats to hospital and medical profitability, there are significant margins out there. And most of the institutions, even if they have dwindling or even inverse margins, still have very, very large balance sheets. And what's hidden behind that is the investment income that they get. So I actually believe that the money is there. And we just really need to take a different approach, right? Most of us are sort of subject to or participate in this funds flow model that systematically discounts the value of physician scientists. And I think the National Academy has a great opportunity to put forth and change that mentality to say, no, the funds flow models that we should be using in academic medicine should actually be supporting that at full dollar or full reward value. And I think this group has the power to do that, right? The consultants, you all know them, are simply following a model that we've accepted. And we don't have to accept it anymore. We can change that model. It wouldn't actually be a huge amount. So my recommendation would be that as part of this, we've set out some of those ideas and say, look, we're not going to tolerate this anymore. This is a learning problem. Our health systems aren't learning. At the end of the day, it's costing us more money than it would cost if we just changed this constraining construct that somehow we're going to discount that learning in our environment.
Great insights for everybody. And I think I would ask the audience to line up and ask questions to the panelists. But I think before the audience members are lined up, I just want to opine on a couple of my own thoughts and observations over the past 20 years. So first of all, I do have a lot of respect for our clinicians. they work their quote unquote butt off, and they should, in my opinion, they should get paid more than physician scientists, right? Number two, I do think that we tend to complain too much on the wards or to our colleagues, and then our trainees get a negative vibe from that, hearing our complaints. And so every time when my trainees ask me, I say, this is the best field to get into. This is the best field to get into. I think that positive energy is needed among all of us. But I also want to get into what David Ginsburg was saying in the beginning. In my observation, I think it looks like a pyramid, right? So the undergrads, all of them, they know they need to do research to get into medical school. The medical students, all of them, they know they need to get research, do research, even though they're not interested in it, to get into good residency program. All the residents know that they need to do some research to get into good fellowship program. But as soon as they hit the fellowship program during the research month, you ask them what they're doing. In cardiology, they say, oh, I'm going to do extra echo, extra nuclear. Those guys are going to private practice, right? Now, here's the thing, right? So let me give you a real life example. So let's say, for example, the clinical fellows who really want to do research, they come to my office. I ask them, number one, are you okay with the pay cut? They say, yeah, that's fine. Number two, is your spouse okay with the pay cut? If your spouse is not okay with the pay cut, it's not going to cut it, right? And I went through that with my wife when I was a trainee at UCLA. And then number three, I asked them, you're a physician scientist, you got to come in on the weekends, write grants and papers. While the other guys are playing golf, are you okay with that? And they say they're okay. So 1, 2, 3, check, check, check. Number four, you have to have a great mentor who can kind of show you the whole way. Now, after all of that done, the leaky part, in my opinion, comes down to this. You have an associate professor, 2R1 funded, and seeing 1 month a year, and for inpatient, half a day a week, outpatient, very productive. Salary is 300K plus benefits. The clinicians are getting paid through 400K plus benefits. He's okay with that, she's okay with that. But then in academia, we argue over who's going to pay for that gap. And that's very discouraging to these people who've made it, because everybody just don't want to pay for that gap. And it happens all the time. And so I would say among the leaders in this room, John, Mukesh, I think, Victor, previously, past and former leaders, Rob, who controlled the purse string, figure out a way to solve this issue. This is really, it all comes down to money, 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 and that's it, yeah.
Going to be the contrarian and say that maybe it's not about money, right? But it's about that our field is boring. Like smart kids do not become medical students anymore, is what I worry, right? At a time when we have self-driving cars, have a robot that cleans my house, we're telling kids that they have to come in for 4 years of undergraduates, they have to do some shadowing, then they go through 4 years of medical school, another 5 years of clinical training, and they may or may not get grants to run a lab. Well, their counterparts, right, have 4 years of undergraduate in computer science, they work in a startup, lots of fun, they have freedom to do whatever they want. Right? Like, who are we really kidding? It's what I worry about, right? Like, where will we be in 10 years? I think it really is time for us to think about what the curriculum should be. How are we going to ask these kids? I don't think they are, at least a medical student I meet, I don't think they are ready for the AI world. They don't have the computational background or the mathematical background to understand what is going on. So I will say we need to go back and restart a curriculum. I know I'm the contrarian.
So you guys are not answering? So I want to say two things. One is, I loved what John said about and Naftali Kaminsky from Yale, about the fact that we need to reestablish the value of a physician scientist. We create value for the system, right? Nobody wants to go to a non-academic medical center. Academic medical center is a place that has science, has physician scientists. And I think we need to get, how would we say, our share of the pie. We generate the revenue, right? And I think this, we don't advocate for ourselves, and the pendulum has sort of, I admire clinicians and educators, but the pendulum has swung way too far. You know, the physician scientists have to reclaim their position. The other thing I think, and that's a little bit of a question, is the alternative careers, because the physician scientist training is not only a basis, and actually I a little bit cringed earlier when there was a discussion only about discovery, because we all know that science is actually only 10% discovery and 50% reproducibility, and another, I'm beyond the 100% implementation, right? So physician scientists are key, not only to academic medical centers, but to industry, to policy, to politics, to everything. So I think we need to really rebrand ourselves as really the most exciting way to be a physician. Hopefully this helps.
So, John, you want to take this question, and since you control the purse string as well? Yeah.
Well, I actually just think that there's actually is plenty of money to go around. I don't think it's mutually exclusive, right? So it's just sort of a mindset, and we maybe need to change the mindset. But I also would like to riff a little bit on the comment about branding or marketing. To the degree to which AI seems sexier than being a physician scientist, then yeah, we're not going to win that. But I still believe personally that having the opportunity to impact and interface with patients at a crucial time in their lives is still the most rewarding career that anybody can go into. And we need to make sure that that brand and that marketing is still out there.
Can I comment on this? I spent yesterday morning with a company working on, who's not, the GLP-1 pathway with some novel findings from a human study that were leading to intense back and forth with multiple academic investigators at multiple institutions. The idea that the infinity of human biology is not one of the most amazing things you could ever possibly be interested in, it is bad marketing if we're not selling that. I mean, this was just incredible, and it was all stuff that we would have never even imagined a couple of years ago unravel because of the intensity of the research, the commercialization, the patient care, the human studies, and then back into the lab about what on earth are the actual pathways that are causing this clinical phenomenon. It's hard for me to believe that a vacuum cleaner in your house is more interesting than that. So, but maybe we're not selling it, but it seems like we ought to be able to.
I add some, oh, sorry, go ahead, please.
So just a few comments. One, we know that the number of applicants to medical schools is stable. So I don't know if that says our field is not boring, but thank you for that provocative observation. I also think this is an opportunity for us to reconsider the curricular elements. I don't represent an accrediting body, but we interface the AAMC a lot with accrediting bodies. And maybe that's a different group that needs to come into the conversation, because what is the end product? How do we get there? What are the milestones? I'm also a member of the American Board of Pediatrics Board of Trustees. We talk a lot about competencies versus time-based curriculum. And I'm sure any of you who are involved in residency training issues face that, how do we know when someone is ready for practice, whether it's residency or fellowship or postdocs, whatever. And so I think these are opportunities for us, whether these standards were established in the 1500s or more recently, to reconsider what is the product, how do we measure those outcomes, and how can we reimagine some of those trainings?
I think there's one, I think there's kind of a critical branch point that I think we're starting to face. So if you look at what AI, I think, is going to do within healthcare systems, there's increasingly large numbers of physicians are employed. Most more and more of them are employed by big healthcare companies like Optum, and more are employed by private equity held companies. So, but across those and academic medical centers, there is, what I've observed is there's increasing divide between the executive layer and the physician layer. And AI, I think, will widen that gap. And in precision, and so what's happening is the physician scientists are solidly in the physician layer. They're not in the executive layer. And so the question becomes, with AI, with precision medicine, is the executive layer going to look outward and sort of outsource the next generation of how we do diagnosis, how we do care pathways, how we interact with patients? Is that going to get outsourced, or will academic medicine return a little bit more to its classic physician scientist roots and really build that expertise inside? And the costs of developing AI models and things like that have definitely pushed towards the industry side. But the opportunity to make this, to do the marketing, I think, is really to make it clear to folks that they're going to have an impact on patients' lives directly. And that opportunity is there, but there are many forces that we might at least want to examine, in an activity like this, that will drive us in one direction or another.
We have so many waiting. Let's give them a chance.
I guess I just want to follow up on what Kenneth you just said, and also what you had said before. You talked about Google's co-scientist, and as you know, GPT-5 now is also supposed to be really good at answering healthcare questions. It's been trained for that purpose. It was one of the main purposes. It feels to me that a lot of the innovation in medical AI right now is really coming from industry. It feels like it's a shame, because in theory, physician scientists could play a major role in shaping up the future of medical AI, but I don't think it's happening. I think we can reasonably say that it's not really happening, at least, probably not on the East Coast, maybe a bit more at Stanford and around the Silicon Valley. But, how do we address this? How do we figure out a way for physician scientists to shape up the future of medical AI? I'm just curious if there's any answers to this question.
We have, I guess, Ken, you want to answer that? So we have a lot of people in the queue, so just quick answer.
Sure. It really gets back to what I'm saying is, are academic medical system executives going to look outward to outsource this stuff and have it be, and really use it to further squeeze the docs into efficiency? Or are they going to internalize the science and the implementation science and the AI science to really grab a hold of what the next 10 years of medical care is going to look like? And I can't quite tell yet.
We also are going to need to stamp out the bureaucracy that exists and is stifling in most of our academic institutions, and learn to take a little bit of risk.
My question is also kind of bouncing off a couple of these questions, but something you mentioned, Dr. Mandel, is that if you have domain knowledge and you're really good at computer science, for example, or these, AI machine learning, you are able to produce innovation in healthcare, right? Without being a physician entirely. And I come from just a pure CS background, jumping in now, trying to get into the physician scientist pathway. And I'm able to produce work that gets accepted into conferences, medical conferences, that's, with just domain knowledge of the project. And it makes you wonder, because one, you mentioned, there's such high pay, 7 figures, and OpenAI, all these companies, Google Brain, are doing such fast work in this space. And the physician scientist pathway is, on the contrary, not fast. So how does one differentiate themselves if they are pursuing a physician scientist pathway with the PhD in, computer science or computation, like I want to do, to maintain that difference and that delineation where, it is not the same as someone who's just a PhD and, getting good domain knowledge in their space. And really, I'd love any opinions.
Yeah, we can both take it. I just wanted to maybe add a little bit more color. It's not just about medical AI. So just to say, I'm a physician scientist and I have a collaboration with Google DeepMind. That's because I'm a mechanistic cell biologist, but I can produce data at scale in real biological systems, which is very valuable. So we are working together to train a model, which means that the people in my lab, whether they have background like yours, and I do have some of those, or whether they're more like cell biologists, like the way that I came up in science, we work together. So I have this vision that we actually, and I said this in my presidential address, there's never been a better time to be a physician scientist. It's a very exciting moment, but it's exactly because we can actually, have these bilingual people like yourself, you're the perfect example. And we can grow physician scientists with those skills as we think about sort of the future. I'm trying to do it within my own sort of context at the Broad, but I think that there are many other opportunities to do that. So it's not just about clinical data and how our health systems are going to deal with that, but there's actually, for physician scientists, especially those of us who are working in laboratories and do mechanistic work, there's a wealth of opportunity. Demis Hassabis is a friend of mine, and we've sort of crafted a project together. They couldn't do it without us, and we obviously can't do it without them, right? But it's a very symbiotic sort of relationship, and I think that there's opportunities to do more of that as we move forward. So there doesn't have to be they don't have to be distinct or siloed. They can start to, we can have, with people like yourself, we can start to bridge these areas. And that is an opportunity for growth for physician scientists, I think.
I'll add one more sentence. One thing you can do, work with clinicians because they're the ones who have the patients, but don't assume that the clinical insights that you're generating and the processes that you're generating will be any less valuable than what they're doing, and potentially more valuable. And I think you'll see there's a lot of receptivity there.
Yeah, that makes sense. Thank you.
Next.
Just a quick comment. I'm Nate Cooperman. and I'm like the local guy. I'm the chief academic officer at Children's National. I'm chair of pediatrics. I also have my NIH portfolio like everybody else and my gaggle of mentees. So I just want to make a comment. And first of all, our research building, which our research and innovation building, is an innovation district building where we have basic scientists, we have clinical scientists, and we have startups there because again, having as many people looking through different lenses at the same time, I think is healthy. Like my research team, none of us have the same lens. We all have different lenses because that's how I think magic happens. So I do think we have to, focus a bit on that. But the main comment I was going to make is around communication. After Dr. Bhattacharya's presentation, I raced off to Congress to advocate for funding again, it doesn't matter. This is nonpartisan. Happened to be on the red side of the aisle and whatnot. And, advocate and explaining why the scientific process is so important. I think we have to be really good with our communications. For me, when I'm speaking to people on the red side of the aisle, without not being political, just whatever side they're on, for them, about innovation. They want unicorn companies. They want the company, the economy to be very robust. That's what I focus on. And I also say that, if you cut Medicaid funding to Children's National, guess what? The whole enterprise falls down. So we need to maintain research funding, this, that, the other, but because they don't want to lose access to their children and their grandchildren. On the other side of the aisle, it's more just normal discussion like we're having here without being political. But I do think we have to focus on communication. The last thing I'll say about this, I watched a webinar from CDC scientists. It was really fascinating. They were talking about COVID. And as we know, they were doing the best they could with limited data. And it looked to the public like they were changing their minds all the time. They weren't changing their minds. They were acting on the best available evidence, but they did a horrible job. They admit themselves they did a horrible job of communicating that to the public. So I think, sort of as a 30,000-foot umbrella over all of this, we have to get the trust of the general public by educating well, communicating really well. At Children's National, we have a podcast that, it's not a pitch. I happen to run it. I didn't want to run it, but it's not about our clinical care, but it's about our science and how without the science, you cannot deliver great clinical care. It's really just to educate people. And I think we just all have to really focus on that.
Thank you so much.
I'll say something quick, and it capitalizes off of what he said, is I think we all talk about physician scientists and their value, but there's no quantifiable measure that we can point to. Maybe what we should do is together as a group come up with a way that we quantify the value of physician scientists to a medical center, because it's some of the things that he said. It's like the innovation is why patients come. They don't come to an academic medical center they do it for our research. They do it because of what we're advancing for them. So why don't we quantify that and give that information back to these medical school administrators so they realize why that money needs to be spent? Because a lot of them are saying, well, we're just looking at this RVU model. So we need to give them a model that explains that information.
John Bird from the University of Cincinnati. And I wanted to start by putting an exclamation point on what Dr. Greca said, that there's not a better time to be a physician scientist. And we need to convince the physician scientists that are coming up of this. And one of the big challenges of physician scientists as they're coming up is they know they want to do science. And the training that we subject them to is not as scientific as the work they're doing, in the sense that they can be done with their training if we use competency-based training versus time-based training that we're currently using, and get them through quickly so they can move on. And this has been something that's been studied, it's been shown to be effective, and guess what's holding it back? It's not the regulatory, it's not our regulatory societies, it's the hospitals, because our healthcare is built upon residents and fellows training for a certain period of time.
Thank you. Jennifer, you have a...
Yeah, I had a follow-up comment on the person who was questioning about the value of physician scientists and doing research on physician scientists. So I'm going to put the PSSF leadership on the spot here. I know you guys did a McKinsey consultant report a couple years ago. So from what I understand is that like it was $10,000 plus to generate that report, and they interviewed deans, chairs, physician scientists, et cetera. And their conclusion was that that physician scientists add value, but also that we're short of 200 to 300 physician scientists. And what is the cheapest way to do that is actually to train more MDs to become physician scientists. So I don't know if our PSSF leadership has any comments or follow-up to that in terms of exact details about value physician scientists add to the economy, et cetera.
Maybe.
Vivian or Mukesh, or PJ if he's on the call.
You want to use the mic, Mukesh?
So I don't know if there was specifics quantitated, but the general idea is what's been articulated, which is that physician scientists add great value to the healthcare system and frankly, the broader community, both in terms of economic impact, bringing patients there, clinical trials. I mean, there's downstream revenue. A lot of this conversation has been around health systems. And that's the point I think I tried to make when I was on the panel, but it's really important to emphasize and reemphasize typically a few times a year that same principles.
I'm Alyssa Toulouse. I am an early stage investigator at Boston Medical Center. I'm a family physician and an addiction specialist, and I study treatment retention for patients with opioid use disorder. And with that background, you might not be surprised I have a question in a slightly different vein, which is how do we fund, in this conversation we're having in the landscape, social good research? By which I mean research that advances patient outcomes without necessarily bringing in a lot of revenue, right? Flashy media headlines, financial stabilization for institutions. I'm talking about things like helping patients just take their metformin most days of the week. Things like how do we develop models of care that let babies and children stay with their parents who are struggling with substance use? You know, I think we can all agree that these are the kinds of questions that we know not only improve outcomes for patients, but for generations subsequently. And yet we haven't figured out a way to fund this kind of work in a sustainable way, and not just for the scientists who are doing the work, or not just for the topics themselves, but for the scientists, because they tend to come from departments who are already under-resourced. And so, you know, I'm looking to sectors, industry, venture capital, philanthropy, right, that haven't necessarily recognized their capacity to really stabilize work in these domains and create opportunities to actually fix these very solvable problems if we just put resources in the right places.
Joe, this is right down my vein, and I know this sounds repetitive, but One thing I'm worried about from this discussion, I'll just say it again. We paint a picture that a physician scientist is someone who's going to work in a lab and is going to do research for a good, very significant part of their time. And when we tell our medical students that, we're also telling them, if you're going to be a clinician, you can't be curious about how do you keep a patient on a drug. And we don't teach them how to think about that at a time when the information is sitting there to answer those questions if we just put a modest amount of money into it. And it really worries me a lot. The only solution, I think, to this kind of research, as long as we're in this financialized environment, is for the NIH to fund, or NIH, maybe AHRQ, I don't know, will it still exist? I don't know. But if it's social good and it's not in an area where profits are being made by health systems, they're not going to emphasize it. So it's got to be supported by the federal dollar. But it also can be much less expensive. You don't need a fancy lab. All you need is data and a set of tools and an environment where you can actually ask questions and get answers. And I worry that a lot of the reason the questions don't get asked is because the answers are going to be adverse to the finances of the system that people are working in. The gatekeeper is the executive that John mentioned, they're really saying, without saying it overtly, don't do this kind of research because it's going to tell you you actually need to have more clinics for addiction and tobacco and maybe a little bit fewer Ritz-Carlton looking cancer centers sitting there.
I was just going to say that there's a discussion about AI, and I work in AI. I'm an assistant professor at Penn, and I always get tons of students who are interested in these kinds of projects. And some of them have an engineering background, and some of them a lot of them are actually interested in medical careers as well, or mixing the two. But what I've found is that there's not been enough people to provide them training. I usually try to take about maybe 4 or 5 a year, but that's my maximum bandwidth. But these students are even as undergraduates or as medical students too, publish as first author in really good publications. And I think this is a real opportunity to, because, providing these students good, mentorship and training pathways, I think that's a real untapped potential.
Go ahead. Yeah, very quick.
So really trying to broaden our concept of physician scientists. So I still think that are we talking to ourselves or talking to others? Question really is, what's the definition to begin with? Is it defined by time, by the work you do? I'm not sure we do. So when people say the numbers are dropping, by what measure are we saying they're dropping? Secondly is Lefkowitz. I mean, he's just amazing and a model that we all aspire to. But today, as you said, people have the ability to do data science, social science, health economics, health policy, engineering. In fact, in this group that we try to get Kevin Volpe and Rob Pettigrew to say the spectrum of physician science is huge now, not just biologic sciences, right? And not just, as Bob said, a laboratory you need to work in. That changes dramatically, in my mind, the definition and therefore the contribution. I think we need to really be realistic in looking at today, what is an endangered species? By Weingarten's time, he can measure that very easily. Today, I think there's so much embedding of science, even though people say clinicians are not using them. I think many of them are doing a lot of really interesting questions. Would you consider them as physician scientists? What percent of time? And if you begin to put all that together, maybe it doesn't look so bad after all. I just want to be provocative. This is why we had this session. It says, evolving world of science and technology, right? So I don't know if you know the answer, but I certainly want to throw it out there to say the model's changing rapidly. Science is changing rapidly. And where can you draw a line between when you're doing research, when you're taking care of patients? Sometimes you don't. Can you use your time when you're seeing patients to ask scientific questions? Absolutely. Can you pose those questions to others to do the research? Yes. So I'm not sure whether we've been talking on the same language, all of us. That's why I want to have this, because we're dealing with a rapidly evolving world with evolving science, technology, and clinical care. So I'm not taking away the financing, the corporatization, and all that stuff, but I do think that we need to understand what we're talking about as we want to define where we are and what we want to incentivize.
Great comments, Victor. Go ahead, Anna.
I can try to take a stab, Victor. I think you're right, first of all, to say one way to think about it, and my colleagues on AACI Council can help, who gets into AACI now versus, in decades past, right? And there's a clear shift. And so maybe that's one way that one could define what is the new definition of being a physician scientist. I'm of the opinion that it could be expanded even further. But so we have people who are investigators in laboratories, of course, which is sort of you could call it the more traditional definition or model. But increasingly, I would argue that more than a third of the inductees into the AACI, as an indication of our evolving definition of the physician scientist, are people who do, of course, clinical research. We have amazing representation here to my left, cutting edge clinical research, people who work in population-based investigations, people who do policy and health outcomes type of work. So to the extent that we can, agree on definitions around scholarly work that is sort of contributing to an innovation economy, these are all things that are sort of harder to define in many ways. And on council, we struggle every fall when we elect the next class. But I think it is reflective, the changing landscape of our membership is reflective of a shift in, appropriately so, again, a comment I made in my presidential address, that we're increasingly using humans as our subject of research. And I think that's fine, because we live in this world where we have more tools than ever before to be able to interrogate humans and human activity and behavior, patients, of course. So I think there is an evolution. What I wanted to say, maybe a little bit more provocatively, when I had control of the joint meeting agenda last year, anyone who was paying attention would notice that we had many more of our industry colleagues invited to the meeting, not just to be there, but to speak. We had George Yankopoulos there, we had, past members, we instituted a new award that went to David Altshuler, who can argue has not done incredible scholarly work, but is now leading Vertex in terms of as their CSO. So I think that there's a role for an expanded definition of the physician scientist, including our colleagues in the for-profit, not to be distinguished too much from the nonprofit hospital industry, to Rob's point. So I think, yes, we have to expand the definition. And from that perspective, it's still concerning that the numbers are lower than they should be, because I think that there's still financial pressures from the institutions as to how many people will actually be interested in that scholarly work and are asking those questions, and where will the funding come from that. So I don't think that one expanded definition takes away the concerns about the field, but I think a proper definition of the field, to your point, is absolutely necessary so that we can make progress and keep our messaging clear for the general public so they understand the value that we add. So that's just from my perspective, some thoughts on the topic.
I think, Victor, maybe let me chime in a little bit about this very quick. In my opinion, my own personal opinion, my role model is Roy Vagelos. He's a physician scientist, did great in his research at WashU, went to Merck as a CEO, did a lot of philanthropy as a CEO of Merck, and then afterwards board of Regeneron, and now he's quote unquote made a lot of money that allows him to do a lot of philanthropic support to UPenn, Columbia. That's also another definition of physician scientist who crosses into academia, industry, philanthropy. Yeah.
I won't disagree with that definition, but that's not the point I'm making. I'm not making the point about people's career pathway. They can end up being enormously rich doing whatever they want to do. But the point is, are they pursuing science as part of a career, certainly at different stages, leading to an evolving career pathway altogether? And I'm just simply saying that one should, I think students and trainees will be very encouraged if they're told that they are doing science. Of course, if they meet the criteria of doing science, versus saying that they're just not doing enough because they're not fixed in this particular model. That's all I'm saying, right? And I think part of the discussion, starting with Jay to where it's to right now, much of the focus I've heard from Bob to say, how do you actually bring them in? Then how do you get them started? How do you sustain their career? So when you look at all the schemes of NIH, et cetera, it in some way gets them started, but not sufficient to talk about how to sustain those careers. And that's what we're not talking enough about this meeting, right? We can talk another K model, another whatever. I think it's fair to say there's enough try and effort. But the question really is how do you sustain, support those careers is going to be a key issue.
Skip Brass, University of Pennsylvania. Looking around the room, I noticed that I'm one of the older members of this congregation. So forgive me when I say that most of us in this room are a bit behind the curve. I'll refer to data on MD PhD programs, not because that's the only way to become a physician scientist. It's just the data set that I'm most familiar with. And with those data and my contact with undergraduates and post-bac students show that they're already thinking about this stuff. They're way ahead of us. It used to be that applicants to the MD PhD programs all wanted to grow up to be Dr. Lefkowitz, and many of them still do, which I think is a good thing, meaning they're interested in basic science research that has clear clinical implications. Why? Because that's what they've experienced and that's what they love. But there are now many people training to be physician scientists in MD PhD programs who want to grow up to be economists, right? Or want to be anthropologists, or want to be social scientists of all sorts, who want to be biomedical engineers, who got the message more than a decade ago that what's key to success, one form of success as a physician scientist, is to do translation of things from the laboratory into the clinical setting and into the place where you can actually do things to help people. Things like CAR T-cell therapy or gene therapy or RNA technologies, and the list goes on and on and on. This is what's attracting them at this point. And I think that what we need to do is to make sure we're not getting in their way by telling them that there's only one pure way to be a physician scientist when you don that garb for Halloween costumes, that there are lots of different ways to do it, and we need lots of different people who want to do those things, and then give them the ability to do that. Now, the data on MD PhD programs say that somewhere between 7 and 9% of graduates of MD PhD programs over the decades have gone into the biotech or pharmaceutical industries. I think that's interesting. That's a good outcome, but it needs to be larger. And so I'm really pleased to see that the MD PhD students that I work with all want to know about career opportunities that will take them into industry or other places than in academia. Even though the majority continue to want to be in academia, they're interested in other things as well. So at Penn, we run a course that's all about translational research, where a lot of the faculty and preceptors are people who have, as physician scientists, gone into wonderful careers in industry or who have developed things within the academic setting. So again, I guess I'll summarize all of that by saying that there is no one definition of success as a physician scientist, and that it's up to us to recognize that and not to consciously or unconsciously give them the message that if you don't fit a particular mold, that you are not what we want to see and not what NIGMS is going to fund us to do in the future with our T32s. Thanks for having this topic as a panel.
Thank you very much for the comment. Last comment? Yeah.
Hi, my name is Jay Vias. I'm over at Columbia. I work with Roy Vagelos in terms of putting together a new physician scientist training program. Prior to my getting to Columbia, I spent 28 years at Mass General Hospital as a physician scientist. 9 years of those were running the residency program at MGH. So I oversaw graduate medical education in the Department of Medicine. So I have a pretty intimate knowledge of what happens in undergraduate medical education as well as graduate medical education. And I really do think it's a miracle that we get people who are intellectually curious coming out of these programs. It is really fascinating to me how much we spend a lot of time talking about process and getting a lot of things done. How do we diurese a volume overloaded patient? But we rarely talk about on rounds, what does it mean that these two patients look so phenotypically different, even though they carry the same diagnosis? And so that opportunity to inject intellectual curiosity at the bedside is what we need to be focused on. That is where I think our challenge is in this particular area. A byproduct of making an environment that is focused on intellectual curiosity will be curious physicians who are going to take on many of these questions that we don't even know we need to be asking for now and into the future. And so I do believe that that's one of the most important things that we need to be focused on in that area. So I wanted to share in 30 or 60 seconds a pilot program that we put together at MGH that we thought was really helpful in terms of this. It allowed us to get a lot of our physician scientists to be engaged in graduate medical education. And that was something we called the Pathways program. It was a 2-week program that every resident in my program had to do, where they were paired oftentimes with an MD PhD resident and a couple other residents, so a total of 3 residents with a physician scientist. And they spent for 2 weeks focused on one patient. They didn't see anybody else except for one patient. And that patient oftentimes eluded some type of diagnosis or had a treatment response that was vastly different. And their job was to actually come up with, a hypothesis as to what was going on in that patient. And they would speak to clinical experts, basic scientists, a whole variety of individuals for 2 weeks. And at the end of those 2 weeks, they would present at noon conference. What did they learn from this particular patient? They would share the patient's story, and then they'd share what they understood and what their hypothesis was in terms of the type of future investigations they would do to try to better understand what was going on in that patient. The goal wasn't to play house or to figure out some miraculous diagnosis. The goal was to exercise a muscle that gets atrophied in medical school and in graduate medical education, which is how can you be curious about a particular patient? And our way we do healthcare right now, and I've been on the wards with my residents, when we have 6 patients overnight, we have a fixed amount of time that we can talk about those patients. And when that fascinating patient that comes through those doors, we have 18 minutes to talk about that patient. Then we have to move on because we have to discharge patients, right? So we need a system by which in education, we incentivize this ability to have this intellectual stimulation, because that's what our residents and our trainees want. And if we can do that, I think we'll solve a lot of our capital problems, as well as being able to identify the kind of problems that we need to face in the future. Thanks.
Thank you so much. So I want to thank the panelists, Eleanor, Rob, Ann, and Ken, and John for this great discussion. I also thank the audience for your participation. Thank you so much. Let's go.
Michelle. Yeah, it'll aim for around 2:45. And I think because we have fewer people, so hopefully. Yeah. Yeah, maybe we can, if we could get Michelle to come, that might be the first thing. Yeah. We might go ahead and get started.
So this panel, much is spoken about how to provide sustainable support. I think when you heard Jay's presentation, and then some of the conversation we had, I think becomes an important panel to say, you need resources to support physician scientists. What are they? So in my travels, what I discovered is, people have different models. Certainly in our model, you heard quite a bit about Jay's rendition about the different schemes of supporting them. What I've learned, in fact, in Quebec, they have a very interesting model that supports physician scientists. And this gets down to the issue of what kind of payment and support you get. To Singapore, you heard from Ivy earlier. And in fact, what Singapore's done is to say deliberately, we're going to create a whole generation, physician scientists, by having government to say, that's what we want to set doing. And then, of course, we have the other ranges of conversation in terms of, so you're going to hear from others about the other models. So that's the purpose of the discussion. So we have Paul Utz, Michelle LeBeau, Carol Jabat from Quebec, and Sei Bing Tang from Singapore. And Vivian, thank you very much for moderating the session.
All right, thank you so much, Victor. And we've been so looking forward to this session. I think we can't say that we have a monopoly on the bold models because we've been hearing about them all day, but we're excited to be the closing panel before we move into our brainstorming session. So this is going to be really, really fantastic. So first, let me just provide a little bit more on the introductions for our distinguished panel. So we will be hearing from Michelle LeBeau, who is the Chief Scientific Officer Emerita of the Cancer Prevention and Research Institute of Texas and Professor Emerita of the University of Chicago. Professor Tan Sei Bing, who is the Group Chief Research Officer of Sing Health and the Senior Associate Dean of the Duke NUS Medical School and Executive Director of the National Medical Research Council. Welcome. And then via Zoom, we'll be hearing from Carol Jabet, who is from the Fonds de Recherche de Quebec, the Vice President of Research overseeing the health sector. Welcome. And also Professor P.J. Utz from the Department of Medicine at Stanford University. Welcome also. So I was asked to just give a few opening remarks, which I will be very brief because I know we have terrific presentations and going to have some great discussion. So my name is Vivian Lee. I am at the Harvard Business School now. And I was actually a bit surprised to be reached out for this opportunity to be a part of today because it's actually been a while since I've been thinking a lot about this, about this particular topic. But when I did think about it, I was thinking about it very intensely. So I, like all of you, am a physician scientist. My PhD is in engineering. So I'm in that group. And probably more recently, my work is more focused on, say, health economics and health policy. Early on, I received one of the earliest K-23s, which then converted to an R01. And I don't know if David Ginsburg is still here, but I am in radiology, one of the ROADs. So you'll appreciate that just by getting my first R01, that justified my appointment to be the vice chair for research in the department, along the lines of see one, do one, teach one. So that's the vibe that we went with in radiology. And I moved with Bob Grossman into the dean and CEO's office at NYU, where in my first year as the vice dean for research and science, we negotiated and then received $650 million for the residual rights for Remicade, which were then used to fund and invest in research. So as we talk about these various funding mechanisms and the way in which we value what we do, very top of mind for me. Not only did we receive that, but we also subsequently received over $100 million in donations from Jan Vilcek to support education as well. Huge benefits from that research endeavor. Shortly thereafter, I was very fortunate to be in the position to be able to recruit my own vice dean for science in Dean Lee, who has gone on to be the president of research at Merck, and also a vice dean for academic affairs, Carrie Byington, who went on to lead all of the research efforts at the University of California system. And they had a number of really brilliant innovations that they put into place at the University of Utah to invest in our research programs, in particular in our mentoring of faculty. But since that time, since my time in academics, I was recruited away by Rob Califf, so I can blame him, to the dark side, whatever you want to call it, private, for-profit, to work at Google in Alphabet to lead health platforms. I was the founding president of health platforms there, to start a number of businesses and really think about how we can apply technology to improving health. And it's really from that perspective, from the outside in, that I see enormous opportunities for us to think about how we can be bold and be different. And I just really applaud the National Academy. I applaud Jennifer and Evan and the team at AJIA, together with Victor, of course, for bringing us together, because this is a pivotal time in history. And we're seeing remarkable transformations in all segments of life. And if there's one thing that I've taken away from the recent developments, is that disruption isn't always great, but it's definitely possible. And this is a time where I think we can see tremendous disruption opportunities for the work that we're talking about now. So what we're going to do now is each of the presenters has some slides. So we're going bold and going visual. So we're going to have 4 slides per presenter with guidance of around 5 to 7 minutes maximum, hopefully. I thought we would start with our local presenters first and then go international. So PJ, are you tuned up? Is he tuned up for you to present?
I am, if you're able to hear me okay.
Terrific. Yes.
Great. Yes. Well, thanks. I'd like to start off by thanking Jennifer and Victor for inviting me to this. This is really important topic. And I won't take the full 5 to 7 minutes. I really want to make sure that there's time for discussion. And so I put a lot of thought into this and kind of thought ahead of time that we would not be talking about some of the earlier steps in this whole process. So I'm showing here a figure that came from a paper. You can see the authors there from a JCI paper from 2015. It came out right after the physician scientist workforce working group report that shows the attrition over time. And what I think we've not discussed much here is that the pipeline starts much earlier than this. Number one, it starts all the way with K-12 and how we think about our kids when they're in elementary school. And it does not end with an R01 as the main. I don't think it should end as the main gating item for success. And we'll talk more about that. Next slide. So let me talk about some of the problems. And so I came up with 7 of them. The really good thing about going later in a presentation is you can modify your slides based on what you hear. So I was able to do that over lunch. So first is that STEM in America is not something that's embraced. We heard from Jay saying that 1/4 of all Americans don't trust science, where we have terrible STEM education in our K-12 system compared with other countries, especially China, Japan, Korea, many other countries. And so that's clearly an area that we have to improve as a nation. The second is, and this came out of the ASCII meeting, there was a trainee who said, I keep hearing about the pipeline, but it's not a pipeline. It's more like a refinery. A pipeline just takes liquid from point A to point B, sometimes over thousands of miles if it's oil. But in the case of our trainees, they're getting refined along the process. There's multiple different touch points that you can see over on the right. So we really need to think about that. We're going to talk a lot about sustainable and diverse funding. And I have the word diverse funding in there as being incredibly important. The proposed cuts to NIH funding have scared all of us and really made us realize how dependent we have been on government funding. And those days have to end. We have to assume that government funding may not always be there. We're going to have to come up with other things in our portfolio. Integrating each of these steps is also something that has not happened. When I didn't give any introduction to myself, but I'm a physician scientist. I've run a lab at Stanford for 26 years now. Used to run the MSTP. I'm Associate Dean for Medical Student Research. So I got a lot of experience. And when I was the MSTP director, it really scared me when my students would leave because I didn't know what was going to happen to them when they went to a new institution. Were they going to be supported or not? So these programs right now, these different steps are not well integrated. How we define success, again, I don't think it should just be an R01. People who go to industry and do really impactful science may go work in the government, at FDA, CDC, wherever it might be, all clearly very successful. The bulk of what we've heard about so far has been about MSTP or MD PhD programs, but I'm going to advocate strongly for MD only physician scientists. The McKinsey report that PSSF was able to solicit actually cost more like $1 million. It was a really detailed report. And the key take home point there was that the estimate was we need to have between 150 and 200 more slots per year to just stay at steady state. And the easiest way to do that is through MD only trainees as opposed to MD PhD. And the last thing that I'm adding here is about MD admissions. That is a huge problem. You can see up above, I have K-12 STEM undergrad and gap years. We haven't talked at all about this, but gap years are now the norm for students applying to medical school, often 2 or 3 gap years. So that shifts everything to the right in terms of the curves. And the MD admissions process is an enormous problem since they tend to select against physician scientists, even at our own institution until recently. Next slide. So these are some of the solutions that I'm thinking about. Talking about a bold solution on the far left for K-12. There are high school research programs around the country. Roswell Park in Buffalo has had one for about 70 years. There are 11 in California, all as part of the California Institute for Regenerative Medicine. But I'm listing some other programs there that have been terminated. Howard Hughes used to fund high school programs. NIH had the Osofsky Scholars Program that's been terminated. Doris Duke has left this area also. So we need to come up with some big, bold plan to have some sort of a national integrated program for high school students to get interested in STEM. At the undergrad level, you have, again, Roswell Park has had a program for 70 years that also allows undergrads to work in research labs in the summer. Amgen Scholars has been in this space across the whole country and in fact internationally for a long time now. And the Tri-I program is another really bold initiative that has been highly successful. And then if you look further to the right, you see for MD only and for MD PhD, the ASCII Scholars Program, formerly the PSSF Scholars Program, is funding gap year. Howard Hughes has left this area. Unfortunately, it would be great to re-engage them. NIH, their gap year program was put on pause this year, which is really devastating. And then MSTP went down. The number of slots went down by about 3% last year. It is anticipated, based on a survey I did where I got responses from 34 different MSTP directors or MD PhD program directors, is poised to decrease by 10 to 15% this year based on what we can tell. And then on the far right, there's other really good programs, Burroughs Welcome, the CAMPS program you've heard about. And we really have to leverage industry in a better way. So let me go to the last slide. I'm just going to show in 15 seconds a really bold thing that Stanford has done. We're the only school that I'm aware of that has a 5-year curriculum. It's called the split curriculum, where medical students do the first year of med school like they ordinarily would. Where you see white space there, that's time for research, fully funded by the Med Scholars Program, which has a large endowment. In the second year of med school, students split their second year into 2 years. And in the fall and winter quarter, they're 50% research, 50% class. Spring and summer, 100% research, fall and winter of what we call M2B back in the research lab. So they have 7 consecutive quarters of research. And our goal is to have about 30%, roughly a third of all of our 90 students enrolled in either MSTP or this program. And I can talk more about how we fund it later. Thanks.
Great, thank you very much. Michelle, would you like to present this? You can probably do either.
Thank you, Vivian. I'm delighted to be here to tell you a little bit about the CPRIT model, which many of you may be aware of, but I'd like to tell you a little bit more about the program, because unless you're from Texas, you may not be aware of all of the different elements and programs that CPRIT supports. It's really an innovative state-funded model. and has had a remarkable impact on Texas. If we go to the next slide, please. Secret was created in 2007 by a constitutional amendment, and the legislature committed $3 billion over 10 years. This was renewed in 2019, making Secret a $6 billion enterprise. Secret's charge is to invest in the research prowess of Texas institutions, to create and expand the life science infrastructure, and to add high-quality new jobs in Texas, to expedite innovation in research and breakthroughs, and to add high-quality new jobs, and then finally to develop and implement the Texas Cancer Plan. Secret first awarded its initial grants in 2009. So to date, we've invested $3.9 billion in 2,149 grants. So we have a budget of $300 million annually. And this is from bond funding in Texas. And Secret has three major pillars: the academic research program, the product development program, and the prevention program. The largest program is academic research, and we've invested $2.7 billion to date. About 45% of that has gone directly into research, and 55% has gone into recruitment, training grants, research cores, and investing in emerging institutions, particularly those who are located in areas that serve underserved populations. Some of the signature programs that you may be aware of include the recruitment program, and I'll come back to that on the next slide. But I think one of the big advantages of Secret is that it has also supports new core facilities, which allows the development of new technologies for Texas investigators, as well as training grants. And the training grants have been very broad. They have funded STEM programs. They also support pre- and postdocs, and that includes a number of MD graduates during their graduate training, as well as during their postgraduate career, and as well as clinical fellows who are doing research research years during their clinical fellowship. The product development program invests in early stage companies, and the bulk of the money is to support the development of clinical therapeutics. But they also have programs for devices and new technologies and seed funding. Finally, about 10% of Secret's annual budget goes to providing prevention services to underserved population in Texas, and that includes screening for cancer screening and vaccination programs. If we go to the next slide, it just shows the recruitment program that I think most of you have heard about. And to date, Secret has recruited 340 investigators to Texas. They come from all over the United States, but they also come from international locations. And one of the things that surprised me when I generated this data a few weeks ago was that only 17% of these awards go to MDs or MD PhDs. And you can see that in the pie chart on the right side of the slide in the orange and yellow boxes. But interestingly, that is heavily weighted towards senior investigators, towards the established investigators. And those are $6 million awards for 5 years. I think one of the reasons for that is because academic institutions have additional sources of funding with which to recruit clinicians and physician scientists, whereas Secret is heavily used as a source of funding to recruit laboratory-based PhD investigators. But this creates an opportunity now for academic institutions to use this as a venue to expand the recruitment of physician scientists. On the last slide, I just show you some examples of some of the mechanisms that we have that are that target physician scientists and are heavily used by physician scientists. On the research side, we have R01 type awards called individual investigator grants, high risk, high impact that are like R21s, and multi-investigator research awards that are like PO1s. The advantage of these awards is that we very much promote including early stage investigators as PIs on the research projects, and that's really viewed very favorably by the reviewers of the grants. And the next clinical trials, we have several awards for clinical research, such as individual investigator awards to support clinical trials. We have several awards designed specifically for training and career development for physicians and physician scientists. And these include training grants, which I mentioned already, and those, are not exclusively designed for physicians, but also include PhDs. But this is an example of a mentored award that has a high success rate. A new award that we introduced about 8 years ago is an Early Clinical Investigator Award, and this is to support early clinical investigators in their first faculty appointment and provide 50% protected time for them to develop as clinical researchers and to develop their skills as clinical trialists. And these investigators have been enormously successful. The only downside is that they're highly desirable and heavily recruited elsewhere. We also have designed a similar award for mid-stage investigators, clinical investigator awards. And this again has been successful because these investigators are very much involved in mentoring early stage investigators in clinical research. And finally, we have commercialization awards that are designed for early stage companies for therapeutics, devices, diagnostics, and technologies. We also support now 2 core facilities that have designed very extensive training programs for investigators who are interested in commercializing their cancer therapeutics, and now a new program for cancer devices. And this is a very intensive course in business development and drug development. And they work very closely with entrepreneurs and venture folks and really learn the ropes. I'll just finish up by mentioning a few lessons learned throughout the about 17 years experience that we've had now with CPRIT. The first is that I think as judged by CPRIT, state-based initiatives can have a very high return on investment as judged by multiple metrics, including business growth, biotech growth, academic growth. For example, the rate of increase in NIH funding has increased exponentially, much greater than just the recruitment would be expected by the individuals recruited to CPRIT. The legislature mandates matching funds from the institutions of 50% of the award that CPRIT gives them. And that creates and is a major commitment to sustainability. But as you can imagine, sustainability still remains the biggest challenge for all of the grants that we issue. There are many challenges with public-private partnerships. Very hard to work out the IP arrangements with academic institutions, for example. I think the state has mandated 5% indirect costs. That's the max, and that's a huge limitation and will become an increasing barrier, I think, for some institutions now who wish to submit to CPRIT. And I think in the current environment, we're going to need to work very, very closely with academic institutions to both determine what mechanisms of funding are most impactful for them, but also what is most needed by the academic institutions, given our current academic climate. And finally, I think the last thing we've learned is that the state funding model provides a very important opportunity to work with academic institutions to identify gaps and to develop RFAs that will address high profile or high incidence cancers and clinical issues within the state, and to develop RFAs that address those issues. And we, as you can imagine, those RFAs that are developed in close alignment with the needs of the academic institutions are those that are most successful. So thank you for your attention.
That was terrific. Thank you. Okay. I'm sure we'll have a lot more questions about that bold model. Carol, would you like to present next?
Sure. So I will wait for my slide before thank you so much. So first of all, as my colleague, thanks a lot for the invitation. For me, it's a very nice opportunity to speak a little bit about the FRQ, so this provincial organization, but it's also a very nice opportunity to talk about the signature programs that we have to support researchers' careers, especially the physician, scientist careers. And it's also a great opportunity. I was listening for a while now to also get some information and good advice through the discussion that is happening during this day. So thank you so much for this. Next slide, please. So as I mentioned, the FRQ is a provincial government granting agency. So our mission is to support the development of research capacity within the academic sector. So it's really the main clientele that we have, academic sector. And the key words are truly building research capacity. We do not fund research project. Of course, we fund a little bit, but it's not our job. Our mission is to support and promote research excellence, and it will take another day to define what research excellence means. So we know, all of us, that we need to get further, and we need to get more or define new metrics to define what excellence is. But again, it's another topic, but I will be interested to hear about this. And our mission is to support careers for students and researchers, of course, with the goal to advance knowledge and innovation. We are a governmental agency, as you see on the below on the slide. The funding and ministry for us, our Ministry of Economy, and for the sector I'm representing, the Ministry of Health. I think it's very interesting to have these two ministries for working together to be sure that the granting agency we are is able to function. What does it mean building research capacity? You have this on the right of the slide. When you look at how the investment, the annual investment is split over the different programs we have. So main part of my budget is going through research careers and promotion, and how we can support, sustain this careers pathway. So we support 650 career grants per year as an average, and among them 38% goes to physician scientist grants. Another big part, another big chunk of the budget is dedicated to training. We have an MD, PhD program, scholarship program. I'm not satisfied with, because I think that we miss some link between the MD, PhD scholarship programs and the physician scientist programs. We still need to work on this one, but we have a regular program for master doc, postdocs, and most of the students, even MDs, PhDs, goes to this program. Another very interesting part is that as building capacity, we support operations of research center based into the healthcare organization and hospitals. And it really helps because we work together to support the physician scientist careers. And as I said, a little bit thought to a research project. Next slide, please. So as I said at the beginning in the introduction word, our career support program is really the flagship program of the FRQ. It was launched, 40 years ago. So obviously I'm managing the program, but I was not the one thinking about this program. So it's a long time now we run this with very, very little changes over time. So it works very well designed, very highly appreciated by the community being the physician scientists, being the universities, and even in some way the healthcare organization, but I will come back to this one. There is a key success around this. So why is this longevity for such a program? Because indeed it's a partnership, a strong partnership between the FRQ as a granting agency, the Ministry of Health, and the La Fédération Québécoise of Medical Specialists. So the Medical Specialist Association dedicated some funding to this program. So without this part, it will not work. The objective, of course, is to support career development and to be sure that we bring two things, indeed three things. We bring funding, and it's important, I will come back to this, but it also enables the physician scientists to get protected time. So it can dedicate some time to the research and not only to the clinical side of his work. And we also bring some mentorship. Next slide, please. So how does it work? So we target, as I said, physician scientists. They have to be affiliated with a healthcare organization, but also they have to have an academic trajectory. All pillars of research are eligible, so we are not looking for a specialty or another one. It's open to clinical, epidemiological, basic research, and I could list the different type of research, but you understand the spirit of this. We provide support for up to 11, 12, even 15 years of the research careers. So we do not support only the launch of the research career. We really try to sustain this career over a while. So I also think that it's a difference with some other programs that we could figure out. We begin very early, right after the fellow, right after the postdoc, right after a residency, and we go through the 12 or even 15 years. We support the funding model I see is also key here. So you figure out we have a physician scientist in front of us. So part of his salary is coming from the clinical work is continue to do. But part of the salary has to come from the research side, the research work that he's doing. For this research work, FRQ is paying part of it, but the Federation of Medical Specialists is paying for the adjustment to avoid any pay cut in the salary comparing to the entire specialty. So in some other words, being a physician scientist in the Quebec province supported by the FRQ means that you will get the same type of money that someone not doing any research in your specialty, which I think is an incitative very important. Next slide and last slide. So even so, this program is working very well. So as I said, I don't think I said it, but just to mention, we receive over 100 applications a year, and it's pretty constant, pretty stable. We're facing some challenges. The Quebec healthcare system is a governmental one. So this is something that we need to know, to understand where the difficulties are. So we cannot have as many physicians as we would like. So it's really the government which is assigning the number of physicians that a healthcare organization can get. And if the government decides not to get so many physicians, of course, the first ones that are going to be targeted are the physician scientists. So here we have this tension right now between what do we need from for the clinical side and how do we communicate the importance of research to be sure that we can keep this type of people invested in two different activities. So first challenge, of course, it's the pressure is very, very high. So we have waiting lists that are becoming longer and longer and longer. So everybody is thinking that the miracle is just to do only clinical work. Forget about research because it's not a priority. And at the end of the day, the problem is going to be solved. It's a little bit short as a view, but this is what we are facing. The other problem we have, and here it's in French, and because this is the name of the agency, Santé Québec. So before we have some autonomy for the different healthcare organizations, but this autonomy is disappearing with the constitution of only one organization organizing all the healthcare system across the province. And this organization has not, as a priority, research on the top of the list. So for us, it's very difficult to get the protected time I was mentioning before and be sure we can continue the program. So I would say that the issue are not about funding. The issue are what do we consider as being a priority? And as it was said in the previous panel, what do we consider as being the value of physician scientists in the care journey of patients? Thank you so much.
Thank you very much. Sabing, would you like to speak?
Thanks so much. So thank you very much for inviting me to share this meeting. Actually, it's been very fascinating for me listening to the discussions this morning. A lot of the issues are not exactly the same, but certainly very familiar to what we experience in Singapore. And I'm certainly looking forward to talking about what we have done there and hopefully, some lessons that we can hopefully share with the group here today. So first, I thought it'd be helpful to say a little bit about the Singapore ecosystem. Ivy talked about it earlier. She shared a little bit about SingHealth in particular, but I thought it would be helpful, through the slide that we have here to say a little bit in terms of how we are structured. It does actually impact what I'm going to share later because there are some advantages of being a country that is very small in many ways, how we're organized, and also in terms of the ability to roll out policies and initiatives. I think clearly it will be easier in a setup like Singapore, which is small and relatively easy to manage. But I did want to give a little bit of background. So in Singapore, our public healthcare system is organized into three healthcare clusters. So that's the colors that you see in the map, the Singapore map on the left side of the slides. So National University Health System, the NHG Health, and SingHealth, which was what Ivy was talking about earlier. Ivy mentioned that for the longest time, more than 100 years, we had a single medical school. So that's the National University of Singapore, the NUS Medical School. And then about 15 years ago or so, Duke University in Durham partnered with NUS to create a second medical school. And that second medical school is partner SingHealth. And more recently, through a collaboration between another university in Singapore, the Nanyang Technological University and Imperial College in London, they created a third medical school. So very conveniently, we now have 3 healthcare clusters. We've got 3 medical schools, and very neatly, each of these healthcare clusters partners one of these medical schools to try and push, particularly in the case of SingHealth, Duke NUS, as well as in the National University Health System, academic medicine. Complementing and supporting the healthcare system that we have, we've got a couple of research funding agencies in Singapore. I noticed in an earlier presentation, they talked about the value a little bit also of having multiple agencies, and that's certainly the case in Singapore too. So we're very glad that within Singapore, in the space of supporting biomedical research, we've got obviously the Ministry of Health, for which the agency that I represent, the National Medical Research Council, we're under the umbrella of the Ministry of Health. And of course, as part of the Ministry of Health, we're keen on seeing how research can lead to better healthcare outcomes, improving the care of Singaporeans and so on. That's a very important role. But we also have colleagues in the Ministry of Education. So they fund the universities, for example, the medical schools. And clearly from their point of view as well, biomedical research is important too, right? From support, because they're supporting the medical schools. And interestingly, we've got our colleagues at the Ministry of Trade and Industry. So for the trade and industry, my colleagues in the trade and industry group, they see research as a potential economic engine for Singapore, attracting investments, generating startups, and so on. So the nice thing about that is, although the 3 ministries, the 3 big agencies have very different goals in terms of why they want to support research, the outcome is the same. And the outcome is that can we come together to see how best we can support certainly biomedical research in Singapore, and particularly how do we support physician scientists or clinician scientists, as we call them. Next slide, please. Yep, that's right. And we do this by having several schemes. So the first thing I should say, to set the context a little bit, is that we run grants, a bit differently in Singapore. Some parts are very similar to what the NIH does and so on, but other parts less so. And in particular, when as a National Medical Research Council, in the different grant programs that we have to fund projects, none of them actually pay for the PI's time. And that's an important thing to clarify, because what it means is if an investigator in the university, in the hospital, applies for one of our grants and is successful, what that means is that the grant will pay for your research assistant, your research fellow, your consumables, your equipment, everything except your own time, right? And why is that the case? Well, that's the case because the university already pays for the salaries of the PIs, the individuals. In the case of the healthcare system, the hospitals pay for the salaries of the individuals. So no one's salary needs to be dependent on whether you get that grant or not. But that doesn't solve the problem, because particularly in the case of the healthcare system, if the hospital pays for the salary, of course, I'm paying the salary of the doctor in order to see patients, in order to do clinical work. And then depending, I guess, on the goodwill of your head of department, he or she may or may not give you time to do research, right? So that's a challenge. I mean, it works sometimes because you've got a very enlightened boss, I suppose, who gives you the time to do research. In other cases, it does not. So how we've tried to solve this problem and help this problem is to create a range of awards. So what these are, they are competitive awards that people apply to. So someone applies for a grant. As I said, the grant doesn't pay for your salary. But on top of that, you can apply for one of these awards. And this awards gives you the protected time. So if you're a clinician in the hospital, for example, you win one of these awards that I'll talk through very quickly in a second. What it does is that we are saying to your institution that we are now taking over the payment of the salary of that particular investigator. So that person is now expected to do research 50% time, 70% time, whatever has been agreed. And the institution is required to then free up the time. So that's the thinking behind these schemes. I'll just quickly go through the different schemes that we have, starting at the bottom, the part in green. So the Research Training Fellowship, that's a bit like a scholarship that's paying for young MDs, for example, who may not have a PhD before, they want to pursue a PhD a little bit later in their career. So we fund that a bit like a scholarship. Transition Award, the second line from the bottom, the second line in green from the bottom, is our entry-level award. We don't even consider it a clinician scientist award per se. It's more in terms of trying to help support individuals, give them the necessary protected time, get them into a position whereby they can be successful in terms of competing for the clinician scientist awards, as we call it, which are the categories above that. And just very quickly on that, so the parts in orange, the clinician scientist award, HPHSR, which is essentially talking about a population health clinician scientist award and the clinician innovator award. So the difference between these three categories, 5 years ago, we had a single category for clinician scientist award. And the idea was that here's the award that protects your time that I was talking about. People apply for it. But we noticed that because of the way the panels were formed, that there was a slant towards supporting research, certain types of research. Typically, it would be lab-based research, for example. And we were not getting enough awards going to individuals who were interested more in, for example, health services research, population health research, or those who are involved in technology. It's not a question of we wanted to de-emphasize one and emphasize more of the other, but we felt that it was useful to differentiate having different awards and panels. And it's not just in terms of calling them different things. The panels will be different. So for example, the award category, the second one there that focus on policy, the members of the review panel will be individuals that are working that space. They would be the ones who recognize that, well, it's not just about whether the applicant has a Nature paper or not, but does the person have a track record, for example, of research that leads to changes in policy. So we wanted to craft different panels with different expectations and requirements in order for individuals to compete for this awards. So that's the part in yellow. And then the ultimate award, the Apex award that we have, is the part in orange at the top. That's called the Singapore Translational Research Investigator Award. It's a generous award. So it gives Singapore $6 million, which is about 4.8 million US dollars to a single investigator over 5 years. Pays for the person's salary, of course, but we don't pay that much in Singapore. It pays for the person's salary, but actually also to allow him or her to form a team, do some research as well with the money. And importantly for us in Singapore, it's a tool that we also use for individuals, for example, who want to spend some time from overseas, who want to come to Singapore, for example, do research. So that's an award that's available to them as well. So the point here being a range of different awards, but the goal here is really, can we find a way to protect time of individuals, of physician scientists, so that they would be freed up in terms of typically clinical workload, to do research. I would add as well that it's open also to full-time faculty in the universities, but for them it's more a question, for example, if they have a very heavy teaching workload, for example, and we similarly buy out their time. Next slide, please. I mentioned the 3 healthcare clusters. So in my earlier slide, I talked about the government level initiatives that us as the National Medical Research Council puts in place. But within each of the healthcare clusters, the NUHS, the NHG Health, the one that Ivy talked about earlier, the SingHealth Duke NUS, they would have a range of internal awards that they also put in place. So how it works is that these awards typically would focus on the pipeline and helping to groom investigators and young clinician scientists or potential clinician scientists to compete successfully for one of these national awards. I focus a lot on funding schemes. I didn't say very much about other things, other mechanisms that we put in place besides funding schemes, because my understanding is we did want to focus a little bit more on the funding schemes. But I should say that certainly within the healthcare clusters, there's a range of, for example, clinician scientists support units where they give mentoring, where they talk about they have engines to sit down with individuals who are interested in clinician scientists careers or potential clinician scientist careers, link them up with mentors, talk through the implications of what it means, including some of the very difficult questions that were raised in the earlier discussions. A lot of them would be things that an individual, a young doctor in Singapore, considering whether to go down that path, would go through similar considerations, right? What is the impact on my salary? Would my career path be slower than my colleagues and so on? So we want to put in place some of these centers, some of these groups to sit down and help guide and hopefully support these individuals as they go down that track. Next slide, please. This is my final slide. Key success factors and challenges. This is, of course, my own view in terms of what I feel has worked well and what I feel has worked less well. So key success factors, government support and recognition. I think that is very critical in the Singapore context. It's something that the country has made a very clear decision that it's important that we want to build up some individuals. We recognize the value of such individuals and the government support, both in terms of funding, of course, but also in terms of the recognition, right? And acknowledging the value that clinician scientists bring. So that's very key. Number 2, healthcare clusters and institutional leadership support. So that was one of the slides I showed earlier, that the healthcare clusters as well, in a more bottom-up fashion, I suppose, have also put in place the necessary mechanisms to try and support this. And these points are where I was referring to when I started the talk, that in a country like Singapore, it's easier to manage, right, in terms of the coordination between government policies and what is done in the healthcare clusters. Number 3 is emphasizing that point a little bit more, the close engagement and partnership between us as the funder, the healthcare clusters. We work closely together. We want to make sure the schemes make sense. It leads to number 4, actually. We have adapted and evolved our programs as well. So having a constant willingness and eagerness almost to hear feedback, to be willing to tweak our schemes, to see how best it can work. Number 5 is recognition for clinician scientists. I used to be very skeptical about this, and what I'm referring to is, so yearly we have a big award ceremony. We get the minister or one of the high-ups, if you like, to recognize them and talk about that. And when I first started getting this, I'm a practical guy, right? I said, give them the money, don't worry too much about recognition, they'll be fine. But actually, it actually makes a lot of difference, right? In terms of just the profile, and particularly for those clinician scientists who are struggling with some of the issues that came up. Am I valued for what I do? Is it important? Does my boss really prefer the guy who's seeing a lot more patients than I am? So having, intentional attempts to recognize, tell them that they are valuable, we recognize them over and above, of course, funding their time and paying for their salaries, I feel is very important. Robust selection and monitoring. So this is a no-brainer. It is a competitive process. We want to make sure the bar is sufficiently high. It's not for everyone, but for those who are suitable, qualified, we do want to support them as much as we can. Finally, very quickly, challenges, no different from, I'm sure, the US and many other countries. High clinical load, people are busy, lack of protected time in some departments. So of course, this one, we hope that our schemes help it, but I think that it remains a challenge, the high clinical workload. Sustainability of funding and rising costs. So this is something we always keep an eye on in terms of, of course, money we have to be good stewards of the funds that we receive. I don't actually think that the funding is the biggest issue, because my sense is that if you have a young individual who's talented, we can always find a way to support you, if not from us, someone else, right? Because that has to be the spirit. It's a question of, it'll be a real shame if we have individuals who are well positioned to be future clinician scientists and don't get supported because we didn't have money. I mean, it's of course possible, but hopefully we don't face that situation too often. Healthy pipeline of young clinician scientists. So this is not a money question. This is the question about how do we encourage young individuals, in spite of the different schemes that we have, to be willing to take up that choice of career. And that's a challenge for us. How do we build up the pipeline? Number 4, grooming talent in evolving new areas. So what this is referring to is that, like everyone else, we say precision medicine is important, AI is important, aging is a big issue in Singapore. How do we get more individuals to be willing to be clinician scientists, do research in some of these areas that in some cases more challenging than others? Number 5 is an interesting one for us. In Singapore, the nursing community and the allied health community are not so active compared to many other countries in the world in terms of research, but we see great potential in building up the group of nurses who are interested in research, pharmacists, allied health professionals. So how do we develop them more? And the final one is talking about clinician innovators. So for us, we define this as being the group of individuals who are very keen to get involved in research, with the goal less about academic publications and so on, but really to spin out companies. And for us, we feel that the take-up in that particular space has not been so good. Okay, so thank you very much.
Thank you very much. I know we're a little short on time, so I might invite people who want to ask questions to queue up. And as you're doing that, I just have a quick question for you. I mean, we've heard innovations now from a lot of things that we heard were a little bit untouchable earlier, like we heard from PJ about changing the curriculum in medical school. I would have thought from this morning that was impossible, but you've obviously taken that on, to funding from the state of Texas, no less, to support long-term research, to thinking about other people who are invested, like the medical specialty associations in supporting it, as well as the clusters. And so my quick question is really probably mostly for you, Michelle, but anyone else can speak up, which is, how do you, especially the fact that you got a renewal of that $3 billion, so how do you prove that you're actually successful to your constituents?
So we use a number of metrics, including economic evaluation of costs saved per cancer that is detected by our prevention services. We look at the number of jobs that are created by CPRIT, by the number of people hired. We look at additional revenues from the companies that are brought to Texas, and the revenues that they bring in, the capital that they raise and bring in. We look at the return on investment for the investigators who we recruit, and the awards that are made, the grant awards that are made, and follow-on funding. So it's really a whole battery, and patents and all kinds of things. And the metrics are extremely positive. Anytime you look at it, of course, is a snapshot in time, but they really exceed the investment. The money that we've put in is always exceeded by the return on investment.
Okay, that is fantastic. My own personal takeaway from this is we just need a playbook from Texas, and then we can just cut and paste that across the country. That's really valuable. Thank you.
Well, many of you may know that Texas is just about to pass a similar law for dementia, a similar institute now to fund a new dementia.
But for so many of us who are looking for the evidence and the data that you have.
Yeah.
So
Please.
my question, coming from Texas as an associate dean for research, is precisely for Michelle. And that is, if you were going to do it again, which we are about to have to embark with DPRIT, is you have academic research spending, about $2.7 billion. And within there, you have attracting investigators, senior investigators to the state, having some training grants, and some, R01, failures perhaps, and other offbeats. Then you have the product development and the prevention component, which is 10% by law. Would you have the same level of expenditures, or strategically, would you be doing it in a different way? I mean, what are the lessons? I mean, we have since 2009, so this is 16 years of data. How are we going to be approaching DPRIT and perhaps the refunding of CPRIT eventually in 2029?
It's a great question, and it's a little bit of heresy to talk about changing the funding metrics at CPRIT. I think you really have to look at the state that you're serving and the disease, the patient population and the disease. I think that Texas could very easily and would greatly benefit from investing more in prevention services, because as many of you know, it's a huge state. There are large swaths of very geographically remote areas and rural areas in which patients don't have access to routine medical services. So there's a very good investment on that.
But the return on investment seemed to be in the product development, in the investment in the startups.
The current investment is mostly in the science, and that is because research is what was our charter, is to invest in research. And product development and investing in early stage companies was added later, was added after a few years as the legislature became interested in, is there a way for us to make CPRIT sustainable in terms of money coming back to the organization? But that's a long-term prospect, and I don't think we can ever really expect it to break even in that way. We would have to have a real blockbuster drug, or a couple blockbusters.
There are now 2 ADRCs in Texas.
Thank you.
Thank you all for speaking. In our previous session, we talked a lot about the diversity in what a clinician investigator might look like, right? It's not simply people doing wet lab science or moving wet lab science, from bench to bedside, as we used to say. It is increasingly people who are trained as data scientists or social scientists or economists who think at scale about the medical record or about the healthcare system broadly. And I think we saw 3 different approaches or degrees to which this different array of physician scientists is really embraced by these different funding mechanisms. And I was hoping maybe some of you could comment on how these decisions were made. I guess I'll be a little more explicit. Like, it does sound like the NMRC in Singapore, FRQ in Quebec, really embrace and support physicians who are thinking about the health system or who are thinking about how their work supports larger health policy. And I hate to put you on the spot, Dr. LeBeau, but it does sound like CPRIT, and maybe I misunderstood, has a slightly different view of that. And I was wondering if you could talk about maybe how that's the case. I'm sorry to put you on the spot on that one in particular. But it is better.
So we fund cancer research across the continuum of cancer research. So it's really exciting to be funding, biomedical engineers, to be funding imaging scientists, to be funding prevention researchers, and they can be MDs or PhDs across the whole continuum.
Maybe I can just add a little bit because you asked a little bit about the process. So for us, I mentioned this now that we used to have an open scheme, so a single scheme, everyone applies. But at the same time, we kept saying, where are the outcomes that we're after? We wanted to see changes in policy. We wanted to see spin-outs and technology. Why were we not seeing as much of this as we had hoped? And when we drilled into it, we realized that part of it was that the schemes, although they were meant to be open and fair to all, because it's influenced by who's on the panel, the focus, the terms of reference, that it will be helpful for us at least. It's not necessarily the case for everyone, but for us at least to have explicit schemes and say upfront that this is the scheme for you if you were doing work that hopefully would change policy. And it's actually still early days in terms of how it works. I'll be honest about that, but the signs are promising.
Thank you.
Vivian, you mentioned Remicade as an amazing success story where there was substantial funding that came to NYU as a result of licensing. I think it's safe to say that there are not so many success stories like Remicade. I think there are very few of them. At the same time, most medical centers sit on a tremendous amount of IP that is really not well used. I think also safe to say. How do we move forward on this? How do we unlock this IP that sits in medical centers that could fund, medical research and physician scientists and so on? Like, is there a new way to think about this moving forward?
I can take that for 1 second and then I'll pass it to you because I can see you definitely can answer it better. As somebody who for the last, for 5 years was on the outside, so coming from the tech side, the one thing about technology, Google at the time was generating about $8 billion in cash per quarter. So you would think, oh, we could do anything. But actually, what do we not have access to? Patients, clinicians, anything that any people that we need, who we really need to understand in order to do our work. So we had a very pressing need to develop collaborations with health systems and health delivery systems in order to do good. And of course, with me as leading that effort, I was very determined to make these relationships possible. And I will tell you that academic medical systems are impossible to work with. It's just impossible, So as soon as you go in, the work cycle is completely different. We're turning on monthly or every 2 weeks a release of a product. And if we can schedule a meeting within the next month, it's a miracle, for example. And then there's this issue of IP. Everybody with their care pathway thinks that that's IP. I said, it's a public guideline. It cannot possibly be your IP. It is something that we all do. IP is what is in the code and in the software. So there are a number of things that I think are really disconnects between the industry side and what academic medical people believe. And maybe one thing that we could do would be to bring together some of the folks who have straddled both sides, who understand that, to maybe accelerate some of the learning. Because I agree, there is an enormous amount of value that is sitting in our academic medical systems that is untapped, first of all, so that could be generated into value, and which as part of that untapping could create a ton of research opportunity for our faculty. It would be so fun, honestly, for them to be able to do that and to partner with many of us on the outside. So thank you for that question. Please, Michelle, did you want to add to that? Evan, go ahead, please.
This question is for Carol. I think as we were planning this symposium, I became aware of the career grant from Quebec that I think is truly innovative in its ability to take on financial risk by giving 50% salary support regardless of specialty, which in the US essentially does not exist, and I think is a major limitation of physician scientists entering essentially 30 career paths in specialties that are not, traditional, like medicine and neurology and pediatrics and surgery, et cetera. So I was wondering, for that model, how did you sell that, or how was that sold as a viable way to involve physician scientists in more non-traditional pathways? Because here in the US, many programs like the Road that has been mentioned and like 25 other specialties simply will not allow some physician scientists to enter and won't even support K award funding because it's essentially not financially viable. And so I think that model could be adapted to significantly expand physician scientist training in specialties here that are really underrepresented.
Yeah, I think that we need to consider how the healthcare system is designed in Quebec and the tension or the negotiation that have to happen between the Ministry of Health and Healthcare Organization and the Federation of Physicians. So physicians are autonomous people, okay, like SMEs, like startups. So they are not directly paid by the government or by the healthcare organization. So they are autonomous individuals. So when they work for the healthcare system, it's a negotiation between the government and the federation to see what are the efforts that are going to happen from both sides. So of course, physicians want to be paid on a valuable basis with increasing in their income, and the government want to cap this income. So you see how they can negotiate. So to get the increase that they want to have on their salary, the federation have to give something in exchange. And the something in exchange they find was, if we were to both invest in research, it would be a win-win situation. So this is how it happens. So nothing to see with FRQ at the beginning. So really a tension between a government and an association. So they decided that the common win-win will be research. And after, it was pretty easy to find the equation to say, okay, now we know how to invest. We know where the funding will come from. The funding will come from this negotiation. So where is the best incentives? And the best incentives is, if I want to do research, I cannot be pay cut for this, okay? I should not, there is no way that it has to be an impact on my salary. So this is where we come to this equation where FRQ is paying part of it, and this is our mission. So paying for a physician scientist or paying for regular researchers, it doesn't make any difference for me. So the association is paying part of it, and the clinician has the other part. So indeed, there is. It's not a risk. It's not a risky situation. It's more a win-win situation based on some negotiations. So I don't know if I answer correctly. And this is why, again, the funding is not the challenge for me. The challenge for me is government. How many physicians do you want to have in your hospitals? And are you ready to continue to protect time for this physician to do research? It's really the challenge here.
That's a very interesting model that we haven't really considered here. So thank you. Please. Okay, now just in the interest of managing time, we're at 2:56. So maybe do we want to go through the queue?
Yeah.
So then very quick questions and
Yeah,
quick answers if we can, please. Thank you.
Yeah. So I'm Adam Lin from Northwestern. I'm a junior faculty.
I feel like we're being judged. If there's no great way to define physician success, physician scientist success, but we're being judged on how we are sustainable or promoted is really not what's on the website, but what are we really judged? So my question for everybody is, it seems like we kind of, and I apologize for analogies, we're judging people on more of like a Taylor Swift model, like you want to be good at singing, writing, and performing, or how do we kind of pivot to more of a team-based model? Or I have young kids, so they watch K-pop Demon Hunters, which is the #1 Netflix streaming video movie for all time, where the character's voice actor and a singer are complete different people because they're both good at different things. So how do we kind of pivot that structure, if you guys have any thoughts on that?
I'm wondering, PJ, if you want to take that on, because you've been thinking about this new curriculum at Stanford, and you must be thinking about how it can address create different models in terms of the outcomes.
Yeah, and well, in terms of the outcomes, since it's the program we have is really focused very much on MD-only physician scientists, with the biggest endpoint being entry into a research residency. So it doesn't really address this question. But I would just say that I don't see where things are going to change, where you're not going to be judged based on clinical excellence as well as research excellence. That's the nature of the physician scientist path.
Victor.
So we brought people together to say bold models. And of course, what we've heard is a number of really interesting models. I think the question I want to know is how we're going to put something forward that's doable, right? So let me take a step back. First of all, I think everybody talks, there's got to be value of physician scientists. Because for states, for province, for countries to invest in those dollars for scientists, you got to have value. And I would say that there's enough evidence that there's value added, but we need to make sure we make that case. Second, of course, if you look at what the challenges are, one is security of salaries or income, and second is equality of income, right? Because the RVU argument, all that stuff say clinicians make a lot more than scientists, therefore there's an equality, I'm going to choose clinician. And really what Quebec did is to equalize it, right? Now, I don't know if we have an equivalent of the Federation of Medical Specialties, but something like that, let's talk about the sources next, that enables us to say, if you really are chosen, you're given that kind of support in which you don't have to worry about the differences in salary. Because where NIH has a cap, and whatever you get, guess what? You're going to have to make up the difference. And that's where the big issue is. Third is the duration of support. And this is where 12 years, Singapore, all those things are very clear. Now, when we talk about all our mechanism, they're not targeted for physician scientists. Here, they have pathways for physician scientists or clinical scientists. If you're a doctor and the right researcher, we can give you that many support, that many years of support. That's what we need a model going forward. Look at this. And finally, the sources. What I find is real interesting is state-based. Well, I was leaning over to Linda and say, California stem cells, same thing, right? You can initiate bond to say the return investment is there, therefore we can actually do this by measuring. So that value of PS is really, really important. So state-based, you heard provincial-based, not too different. I was just in China. Beijing's going to do the same, right? So there could be a local or federal for that matter. How do you get federal-based is a question. Then, as John Sampson said, institutions need to make an investment too, right? So your point earlier about IP, his point about balance sheet, you name it, the fact is that if you're committed to it, it's not that difficult to put aside set of dollars. I used to run the Duke Health system. I put a lot of money over to the school. The question is, are we committed to say a portion of it goes to physician scientists, right? So I think we have the ingredients and industry. I was leaning over to Bob and say, PSSF, when we were working with them, had a very ambitious goal to say, what if we create the kind of training path needed? The dollars are huge. And of course, industry will never step up to do those. However, if you look at, you disagree? Love to hear industry.
Where is value getting generated and who is capturing that value? And if 50% of the pharmaceuticals are actually being developed in academic medical centers, we are creating an enormous amount of value that we aren't always capturing.
That's right. But that is a much bigger issue that has to do with NIH government, because we give away everything to industry without anything in return. That's a policy issue. Now, if you say industry is willing to give a certain amount because it's generated, it would be wonderful. All I'm saying is industry has the equation, but for years we've been talking industry. I've never seen them step up in a real way. But let's find a way that will do so. So I'd say that we now have the ingredients of the various sources of funding. Let's put something together, right? Security, inequality, duration, and source of funding. I do think this panel has given us a bunch of, so to say, components where we can start thinking about how to go forward. I don't want to walk away from this meeting with another conversation, right? And there's a lot of things interesting here. I'd love to see at the end of this being put together in some form that could be forward, that put forward. And then let's see, we can get the implementers. Thank you.
Thank you, Victor.
Thanks for the very interesting panel. I'm thinking about alternative, bold models for sustainable support, but rather than from across sectors or mechanisms, thinking actually from a longitudinal standpoint. Earlier, we heard some comments about the value and relevance of deep, immersive, highly rigorous experiences that really launch an individual into a physician scientist track. And other comments we've heard, well, maybe we should figure out how to shorten that timeline to sustainable funding. And the problem with constrained timelines is that they're not always accessible to all potential investigators, whether because you have lived experience of chronic disease, or perhaps you are a parent and you're the primary caregiver in your family, et cetera, et cetera. And so in developing these alternative models that have been presented today, I'm curious to learn if anyone grappled with this idea of alternative fluid models of support that allow for fluctuating engagement with investigation because of the very real life experiences that we all have, even though those life experiences actually often allow us to ask even more meaningful questions when we're able to re-energize and come back to some of our collaborative efforts.
Carol, you talked about 12 to 15 years of support. Do you see models where where the investigator is able to pivot during the course of their careers? And can you just mention?
Yes, definitely. So now it's totally part of our criteria, and we recognize non-regular pathway. I don't remember exactly how we name this, but it doesn't have to be as a continuity, and so it's about maternity leave. Anything that was mentioned. We also recognize that we should be able to re-enter in our process people with experience, people who has decided to go for a while in industry and come back because they have some values that is really beneficial to the rest of the system. So it's not as a continuity, it is we are able to interrupt and go and come back.
Thank you very much. I just wanted to respond to just your point, Victor. I feel like you've summarized really nicely the charge forward from this group. And maybe to that, I would just add one point, which is tying us back to Jennifer's opening slides of the survey of the candidates. Because in my mind, I feel like as we move forward with a better, bolder vision, it's really vital that we are continuing to think about the students and the trainees that we want to attract and retain along this way, because change is slow. And if you see my email inbox with the number of physicians who want to come and leave healthcare, it's really worrying to me. And so just one thought about that is this reminds me a little bit of in the business side of how we think about product market fit. And what I mean by that is we're trying to match a career trajectory kind of a life vision with these trainees who have enormous amount of potential. And many of the things that we've talked about today are about how do we, if we're trying to sell them on this career, how do we assure them that they're going to have success and they're going to have satisfaction in this career, which I feel like there are many things that we've talked about today that might ensure their ongoing, their success, better success, earlier success. But I don't want us to lose sight of the fact that this is one of the most satisfying professions, that we have the highest impact on people, that we do what matters. And I feel like one of the things that sometimes we don't do very well is, you know, if you think about the business side of it, we're not very good marketers. We're not very good communicators of just how important this work is. And the people that we inspire to come to us, they're already motivated to begin with. But if we can continue to light that fire and build that enthusiasm and show them that we're able to think and pivot and respond to the modern era in a way that they're looking for, I think that would be incredibly important as we move forward. And in order to do that, we need to have their voices at the table at every step. So that would be my final. You don't want to build a product without your customers at the table. And I'd like to encourage us to think about doing that at the National Academy. So with that, please join me in thanking our amazing panelists, and thank you very much.
So in the interest of time, because we're running a little bit behind, we can take a quick stretch break for a couple of minutes, and we'll reconvene here at about 3:10. We'll set up for the breakouts, and then you can take a longer break as you're making your way to the breakout rooms. So we'll see you back here in a couple of minutes.
Yeah.